musculoskeletal, skin, and connective tissue. Rotor cuff. So we're starting with anatomy and physiology with rotor cuff muscles. Okay, this is what it is, and you just gotta remember these four. Shoulder muscles that form the rotator cuff. Sorry, did I say rotor? Rotator cuff. Supraspinatus and suprascapular nerve. So supraspinatus is this one. Okay, and it's supplied by suprascapular nerve. It abducts the arm. So when you say abduct, it's the one that, when you abduct someone, you run away, right? So it's the one that goes away. Okay. Supraspinatus is supplied by suprascapular nerve. Suprascapular is above the scapula. It abducts arm initially before the action of deltoid. Okay. Most common rotator cuff injury, trauma or degeneration and impingement, tendinopathy or tear. Okay, so right there. Okay. So tendinopathy or tear, assessed by empty full can test. Okay, that's when you ask them to pick up a can and then try to spill the can or empty the can out, right? So when they try to do that action, it actually hurts them. Okay. So supraspinatus, known for abduction. Then you have infraspinatus. This is also supplied by, it's right there. So supra and infra are like right there. And that's also supplied by the same nerve, suprascapular nerve. It externally rotates the arm, right? This is the pitching injury. Internal, external, okay. So it's like you're grabbing your blazer or something and then opening it up. That's the external rotation arm. Okay. So this one was abducting the arm. This one's rotating it externally. And then you have teres minor, axillary nerve. Okay, so it's supplied by the axillary nerve, adducts and externally rotates the arm. Similar to this one, but it also adducts. Adducts the one that, makes it come closer. You add the arm to your sides. Okay. Then you have subscapularis, upper and lower subscapular nerves. It internally rotates and adducts the arm. Okay, this is supplied by subscapular nerve. That's pretty easy. It's in the name, so subscapularis. Okay, so that's this one right there, under the scapula. It's supplied by the upper and lower subscapular nerves. It internally rotates and adducts the arm. Okay. You have to know this. So supraspinatus, supplied by suprascapular nerve, and it adducts the arm. Then you have infraspinatus, again suprascapular nerve, and externally rotates the arm. And you have teres minor, which adducts and externally rotates the arm. And you have subscapularis, that internally rotates and adducts the arm. They test you on the empty can test. Okay, they'll be like, so the physician asks the patient to tip the can sideways or downwards. Which injury is he testing for? He's testing for supraspinatus injury in that one, right? Then this person had injury during a baseball game when he was throwing the ball or pitching the ball. What's the most likely muscle that got injured? Then that would be infraspinatus. Okay, so to remember this, there's a mnemonic. It's called SITS, right? So supraspinatus, infraspinatus, teres minor, and subscapularis. Scapular nerve for subscapularis. Teres minor is axillary nerve, and these two are suprascapular nerves. Okay, it's innervated by C5 and C6. So if we were to look at this brachial plexus, that's C5 and that's C6 right there. Okay, and then you have arm abduction. Okay, so this is about abduction again. So we learned about supraspinatus until deltoid takes over, right? So that's 0 to 15 degrees of abduction. Uh, the muscles supraspinatus nerve is suprascapular. Then beyond that, it's gonna be taken care of by the deltoid from 15 degrees to 90 degrees. And deltoid is supplied by axillary nerve, similar to teres minor. Then you have more than 90 degrees is done by trapezius. This is supplied by accessory nerve. And then you have SALT or serratus anterior, supplied by long thoracic as well, above 90 degrees. This is an important one as well. Okay, so upper extremities. Now we're talking about these. Okay, let's bring that up there. Okay, so axillary C5 and C6. It's fractured surgical neck of humerus, and anterior dislocation of humerus can cause the injury to axillary nerve. Okay. There's also fracture of anatomical head of humerus. Okay. But we'll talk about that later, I guess. So this is the axillary nerve right there, going behind the humerus. So fracture surgical neck, that's the surgical neck of humerus. Anterior dislocation of humerus can also cause that. Okay. Okay. So what will you see? You'll see a deltoid, right? It supplies that, so it's gonna be flattened deltoid, and that's usually the one they give you in the question stem. Loss of arm abduction or at shoulder, more than 15 degrees. Okay. So loss of arm abduction, because that's what deltoid does, right? From 15 to 90 degrees. We just looked at that. Loss of sensation over deltoid and lateral arm. Okay. Good enough. So C5, C6 is the one that this comes out of. Musculocutaneous C5, C7. This is the upper trunk compression. So upper trunk is right over there. If that is compressed, I guess that's the upper trunk. Actually, let's look at the upper trunk. So there's the trunk. So that's the trunk that they're talking about. Okay. Upper trunk compression. So the presentation will be decrease in biceps. Okay. So that's the musculocutaneous nerve. Okay. And it's attached to the head of the biceps right here. Not the head, but the insertion of biceps. Right. So decrease in biceps reflex. Loss of forearm flexion and supination. Loss of sensation over radial and dorsal nerve. Okay. So radial is the one with the thumb. So that's, I remember, radial. Okay. And dorsal forearm. So behind. Musculocutaneous. It has cutaneous on it as well. So that means it's superficial. Right. That's why it's the sensation over those areas as well. If it helps you remember that way. Okay, and now we're on to radial, C5 and T1. So all of these apply the nerves to radial. Okay, not supply, but make radial nerve. So compression of the axilla, for example, due to crutches or sleeping with arm over chair, Saturday night palsy, or mid-shaft fracture of humerus, repetitive pronation supination of forearm, for example, due to screwdriver use. Okay, so finger drop. Injuries above the elbow causes a loss of sensation over posterior arm and forearm, similar to this one, right? The posterior forearm. And dorsal hand. Wrist drop, loss of elbow, right wrist, and finger extension. So they're talking about this part right here when they're talking about dorsal of hand. Okay. Where was I? Wrist drop, loss of elbow, wrist, and finger extension, and decrease in grip strength. Wrist extension necessary for maximal action of flexion. Injuries below the elbow cause distal paresthesis. Okay, so that's important. Below this injury, below this elbow, will cause that without the wrist drop. Okay, and this is everything that's above the wrist, elbow. Okay, so if there's an injury above here, that's a radial nerve right there, right? So if it's over there, then it's gonna be all of these things. But if it's below the elbow, so right there, uh, below the elbow causes distal paresthesis, and without the wrist drop because it's below the wrist, right? So it's not supplying to the wrist. So that's important to remember, because they'll tell you that there's an injury over here or here, and then you stop feeling which nerve was it. Okay. Okay. Upper extremity nerves. So median nerve. This is made by C5 to T1 as well. Supracondylar fractures of humerus. Proximal lesion of the nerve. Okay, supracondylar fracture of the humerus. Okay, that's right there. So anywhere over there. This will cause proximal. This is proximal lesion of the nerve. Carpal tunnel syndrome and wrist laceration. This causes distal lesion of the nerve. Okay, so there's proximal and distal for median. You'll have APAN and hand of benediction. Okay. Loss of wrist flexion and function of the lateral two lumbricals. Opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. Okay. So for this, you need to know what these are. So let's go look at those. Okay, so we have lumbricals, right? So these are the ones in the middle between the fingers, and it's only in these ones. Okay, not the thumb. The thumb doesn't have lumbricals, so it's over here, 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 and here. Okay, and opponens pollicis goes to the thumb. Okay, it's for the uh, finger that does opposition, so that's the thumb. So that's opponens pollicis. Okay, and then you have abductor pollicis brevis, um, again for the thumb, right there. And then you have flexor pollicis brevis as well, so that's over there as well. So all three of these go on the thumb. Okay, and then you have adductor pollicis, but that's something else. On this side, you have the small finger or pinky or mini-me, so adductor digiti mini-me goes there. Okay, and then also flexor digiti mini-me brevis for that one. Okay. Loss of sensation over the thenar, eminence, and dorsal and palmar aspect of lateral 3.5 fingers with proximal lesion. Okay. So injury of median nerve will cause APAN or hand of benediction. That's somewhere here. Okay. So that's the hand of benediction. That's what it looks like, and APAN's not here. Okay. But it sort of looks like uh, they don't have it. Let me see if I can just search it up. Okay, so that would be the APAN. This is ulnar. Let's hand up connecting. That's APAN right there. Okay, so it's kind of like that. Okay. Why? Because it's telling you which one it's supplying to, right? So all the ones that we saw, where'd it go? Should have gotten rid of that. So all of these are not getting supplied anymore, so they're not gonna function, right? So it's 3.5, right? So 3.5 of this one. That's what I said, right? Yeah. Lateral 3.5. So it's going from lateral to inwards. Or this would be the medial one, wouldn't it? No. Yeah. So 1, 2, 3.5 of this, I guess. Anyways, so all of these won't function as it's supposed to. So that's the one reason it's causing that. Okay, ulnar nerve C8-2T1, fracture of medial epicondyle of humerus, proximal lesion, fractured hook of Hammett. This is important. This is what is going to cause the injury and ulnar question. It's from a fall on outstretched hand. Okay. So hook of Hammett is where? Let's do another one. It's near the pinky side, right? Over there, or over there. Okay. Compression of nerve against Hammett as the wrist rests on handlebar during cycling. That's how you get it. Cycling or even like motorbikes. When you put your weight against the handlebar, it causes compression of this nerve. Okay. And fracture of medial epicondyle, so that's the medial epicondyle right there of humerus, which will cause proximal lesion. So you get ulnar nerve, because ulnar supplies to this part of the hand on digit extension. Okay, so when they're trying to extend the arm, these fingers don't extend. These ones will. So half of this finger but not these. Okay, so the hand you get is called the ulnar nerve. Okay, and so that's what that would look like while extending in the fingers. These will extend, but not these, because ulnar nerve is injured. Radial deviation of wrist upon flexion, proximal lesion. Okay, so that's important. They might give you that as a description, that there is a radial deviation of the thing. Why? Because the radial muscles are not being opposed anymore, right? So it's going towards that and not the ulnar, because ulnar is not responding. Decrease in flexion of ulnar fingers, abduction and adduction of fingers like the introsi, thumb adduction, action of ulnar to lumbrical muscles, loss of sensation over ulnar 1/2 fingers, including hypothenar eminence. Okay, so this would be the thenar, and this is the hypothenar part of the palm. Okay, uh, just do that. So that's the hypothenar part. Okay, um, and it's gonna get loss of sensation over that because that's the part right there where ulnar nerve supplies it, right? Whereas on this side it was a little bit of thenar eminence for the radial nerve. That's why there's loss of sensation over the thenar eminence over there. Okay. Recurrent, uh, recurrent branch of median nerve. Superficial laceration of palm, apen, loss of thenar muscle group, opposition abduction, and flexion of thumb. No loss of sensation. Superficial laceration of palm. Okay, so when someone comes in with a sword and they put their hand out, I guess that one right there. So it's gonna hurt this area, right? Majority of it. So that's the part that's applied by the median nerve. So you'll get again apen. Uh, why? Because this time you're not doing a flexion. You're doing a flexion and not extension. Okay. So that's what it would look like. Because only the ulnar nerves would go down, and these wouldn't go down if you were trying to do that. And that's how you end up with the apen, right? Trying to make a fist. So I guess like that, basically that's what they're trying to show. When you try to make a fist, the ulnar nerves are going down and the median nerves are not. So I guess that's how it happens. Okay, no loss of sensation. Humerus fractures, proximal to distal, follow the arm. So axillary, radial, and then median nerves. Okay, so axillary, radial, and median nerves. If you were to just draw it out, it'll be a lot easier because then you can just follow the median nerve goes all the way up here, right? If you follow this one. Okay, so median nerve goes medially. Okay, and then you have radial nerve. Radial nerve has two paths. One goes behind the humerus and the other one comes in front. And then also this is called the recurrent branch. And then you have this one that's going back. Sorry, this is the recurrent branch and this is the radial nerve by itself. So the recurrent branch goes behind the radius and then supplies the back of the hand. Okay, since it's the back of the hand, that's why you get supply of radial nerve at the back of the hand from the recurrent branch of median nerve, right? Uh, and then you have radial nerve coming from here as well. And then the ulnar nerve goes from behind the epicondyle, medial epicondyle, and then back in front into the ulnar part of the hand. All right, so that's this part right there, over there. Okay. All the other ones are pretty straightforward. You just gotta memorize them out. Okay. Okay, so onto this. So there's C5, C6, C7, C8, and T1. Okay, these are the roots or the nerve roots. Okay, and there's also long thoracic that comes through that. What does it supply? It's salt, right? So serratus anterior. Then you have the upper, the lateral, and the branches. So you can think of it like the neck, the shoulder, and the arm bit. Okay. Okay. Before we start going into this, let's understand this a little more. Okay. So if you were to have a cadaver, right? So this is what that is. It's C5, C6, making a superior, uh, and the lateral cord, right? So the lateral cord is going lateral to the body. That's why it's called the lateral cord. Okay. So that's this part right here. The superior is also the upper. So that's what upper is. Okay. And then the lateral cord goes into the musculocutaneous. Okay. Uh, let's bring this into. Okay. Put that up here. It's on this side. Okay. So the superior goes into the lateral and into the musculocutaneous. Okay. So that's the superior going into the lateral, and this pink one right here is the musculocutaneous. So that's how that travels. Okay. Then you have this is AD, anterior division and anterior division. Okay. So they didn't name the divisions here, but it's AD, and then there's posterior ones, these two. Okay. Then you have middle over here, and then posterior cord. It's called posterior because it goes behind. Okay, so that would be this posterior one right there, the posterior cord. Okay, so it goes behind and it splits into two, the axillary and radial. Right, so axillary and radial, right there, the 5 and 6. And then you have inferior, that's right here, the lower one. The inferior goes into the medial cord. Okay, it's called medial because it's medial to the body. Okay, and then medial, and then this one turns into median nerve. Okay, uh, so that's this one right there, number 8. Okay, and then you have the ulnar nerve right here as well, so that's this one right here, coming in from the inferior one as well. Okay, so you're supposed to know, if you understand this, then you'll have an easier time to understand what this means. Okay, the axillary artery is right there. Okay, that's the red one, so we don't actually look at that, but anyways, uh, okay, so again, superior goes into lateral because it's lateral to the body, into the musculocutaneous. Middle makes the gets middle and superior makes the posterior cord, right? And posterior divides into two, axillary and radial, which goes to axilla and the radial radius, right? And then inferior makes middle and that, uh, ulnar and the median nerve. Okay, so it makes the median right from here, sorry, from here and then ulnar over here. On this side, you see how it goes into this as well. So that's what this is. It's going into the posterior cord right there. Okay, and then it's splitting into this. So that's why it's part of that as well. And these roots are what corresponds to those numbers and letters that they're showing. C5T1, C8T1, because that's where it's coming from. So nerve fibers. So when you're looking at this, the reason it's different colors for different ones, it's showing you that it's coming from there. Okay, so we already did this, but let's just go over it again. Axillary nerve is C5 and C6, so that's red and blue. So when you see axillary nerve, it's the one that splits, right? So this one, so you'll see red and blue over there going into the axillary nerve. Okay, fractured surgical neck of humerus and anterior dislocation of humerus. That's what's gonna cause the injury to that. And if it is injured, what are you gonna see? You'll see a flattened deltoid and loss of arm adduction at shoulder, right? It limits like from 0 to what was it? Sorry, 15 to 90 degrees because it's deltoid, right? Then you have radial nerve, that's C5 to T1. So C5 to T1, you'll see all the colors: red, blue, green, orange, and purple. Okay, so eventually all the fibers end up into this. Okay, and remember, this is the one where it's coming from behind, right? Because that's the radial nerve right there. It's coming from behind the humerus, right? It's going behind this into the spiral groove. That's the part it's called. So radial nerve and the spiral groove of the humerus. Okay, so it's coming back from back there. How does the injury happen? Poorly fitted crutches, right? Compresses the axilla. Okay, this is important not to mix this one with axillary nerve, because that's usually what they think. And since you put crutches at the axilla, so you're gonna think that it's gonna hurt the axillary nerve. That's not true. It's gonna hurt the radial nerve. Okay. This is the one with the Saturday night palsy, right? And another part where it can hurt is mid shaft of the humerus fracture, because that's where it spirals out of, right? It goes behind into the spiral groove, and that's the mid shaft of humerus area. So if it happens here, since it's supplied by all of these nerves, it's going to have effect from all of these that's supplying the wrist, and then that's why you end up with a wrist drop in radial nerve injury. Okay, musculocutaneous, that's C5, C6, C7, right? So C5, C6, C7, and the musculocutaneous is this pink part right here. So you'll see red, blue, and green there. Okay, red, blue, and green, and that supplies the screwdriver, or when you're trying to use a screwdriver, supinator and pronator action, right? So it supplies the biceps brachii, coracobrachialis, and brachialis. Okay, so the injury or compression of this will lead to loss of elbow flexion and loss of forearm supination. So it's not pronation, it's just supination that this one deals with. Okay, musculocutaneous, the forearm supination. That's important. They ask you that if injury happens at this area or compression of musculocutaneous, which of these will you not be able to do, or this patient will not be able to do? So it would be supination, because they'll have supination, pronation, and something else. And then you'll be like, okay, so it was supination, pronation. It's not, it's supination. Okay. They gave you this more radial nerve over here, and this was the radial nerve. So this is the recurrent one, the one that comes from the back of the radius. Okay. So when it comes from the back of the radius, this is the part that gets supplied by that. Then you have hypothenar area, that's the ulnar part, and this is the median distribution, right? Median nerve sensory distribution right here. recurrent thenar eminence as well, and a little bit of thenar eminence is supplied by the radial as well. And on this side is the radial and that. Okay. Uh, did we do? We did 3. So we have median nerve now. That's C5 to T1. So you'll see all of the colors for median nerve, right? So red, blue, orange, purple, green, and that's the distribution of median nerve going to there. So if it's a proximal lesion, so proximal is supracondylar fracture of the humerus, you'll get a when you're trying to make a fist, only the ulnar nerves will function, so nothing will happen in the median nerve distribution of the hand, right? Okay, so that's how you get the Pope's blessing or the benediction, whatever that was. Okay, and over here you have distal lesion. That's the carpal tunnel or wrist laceration. At rest, it's gonna be at like this. Okay, um, it's gonna be flexing because this is where your carpal tunnel is, right? The the tunnel right there. Okay, so when you compress that, you can imagine what's gonna happen to your fingers, right? It's gonna curl up like that. Uh, then you have right, so the recurrent branch of that thenar eminence superficial palm laceration will give you append unopposable thumb. Okay, let's do ulnar nerve first. Okay, C8 to T1, so C8 to T1, so you'll see orange and purple coming down from there to there to there and to the ulnar region of the hand. Okay, so if it's a distal lesion, that's fracture of the hook of Hammett, right? Distal is away from the core, so that would be this part, anywhere here. Okay, it happens when you fall on outstretched hand, you get a fractured hook of Hammett. So again, the part that's supplied by ulnar nerve is not gonna fold, right? And then you have, if you have proximal lesion, this is a fracture at the epicondyle, right? So right over there, medial epicondyle of the humerus, funny bone, trying to make a fist will look like this. So basically at rest is that, and when you're trying to make a fist, it's going to be that. In proximal lesion, okay. So you have to remember the difference between them. But I don't think they test you on that. They just tell you that when they're trying to make a fist, they can't. They fell from. Actually, there's also a question about a person falling from a tree and they grabbed a branch while they were falling. So what happened there? Uh, it could be either this or this. If that happens, for I think if it shows up, we'll do it that. And then SALT or long thoracic nerve supplying the serratus anterior, right? So that's this thing dissecting, or over here the number 4. Okay, you get, oh, this was the one, right? So clump policy, inferior trunk. Okay, we'll do that now after this. So here serratus anterior, you get it from a stab wound or surgery. You get winging of scapula. You need to know what that looks like. So let's look at that. So when you're up against the wall, you tell them to do that and you'll see this, or it's going to be prominent like that when they put their hands up against the wall like that. Okay. They cannot abduct arm above horizontal position. Okay, so when you tell them to abduct, right, so go outwards above 90 degrees, they won't be able to do it. Okay, because serratus anterior, we read about it happens, its action is above 90 degrees, right? So it can't go above that. Okay. And then inferior trunk C8 to T1, so anything that supplies that, I guess. C8 to T1, so that's this and this, I guess. So total claw hand is what you get. Risk is sudden pull upwards on arm. So I guess this is the one I was talking about. And get claw policy. Okay, so let's do this now. We have a little bit of idea. Okay, so starting with, let's see how we're gonna do this. Okay, I'll go through this and we'll just reference this. Let's see what is here. So division of brachial plexus, remember to drink cold beer. So R is root. We don't have to memorize it now that we know what these things are, right? We can just call it the neck, uh, shoulder, knees and toes. Right, so this is the shoulder part, I guess. This is the neck part, and that's not anything. And this is the arm part right here, right? Okay. How are we gonna look at these? Okay, let's look at this one. Okay, so first one up is Erb's palsy. Let me bring this too. Okay. Erb's palsy. So this is or the waiter's tip. So it's like that, the arm. Um, traction of or tier of the upper trunk, C5 to C6. Right. So C5 to C6 is gonna do the upper trunk or the superior. Right. So this area right here, number 1, is the Erb's palsy. Uh, the causes are in infants, it's lateral traction on neck during delivery. Adults, trauma leading to neck traction, for example, falling on head and shoulder in motorcycle accident. Right. So anything that would cause traction on the neck or neck injury because of traction or something. Right. Uh, so which ones get supplied by C5, C6? Right, so we see that's musculocutaneous, uh, lateral cord, this, all of them, right? Let's go through this as well. So C5, C6, C5, C6, C5, C6. So axillary, musculocutaneous, and radial, right? Muscular, axillary, radial, they get supplied by this. And C5, C6 median as well. So this as well, it comes from the upper trunk. Just not ulnar. That's it. Even this one, right? So they all get supplied by that. So you'll get muscle deficit for all of them. So for deltoid, because of supraspinatus, uh, okay, sorry, deltoid and supraspinatus. So supraspinatus was 0 to 15 abduction of the arm, right? And this was 15 to 90 for abduction of the arm. Then you had infraspinatus, that's you opening up the blazer, right? External rotation. You have supraspinatus, 0 to 15 abduction of the arm, right? Let me just make sure right? External rotation of the arm, infraspinatus, and this is abduction of the arm, 0 to 15. Okay. And biceps brachii. Okay, so that's not the musculocutaneous, right? So Herb gets dips or tips. We don't need to remember that. We don't need that. We remember it by itself. So muscle deficit, because of deltoid and supraspinatus, you won't get abduction. Arm hangs on the side, so that's why it's like that. Then you have infraspinatus and supraspinatus, right? This is again abduction, but this is what it was, external rotation. So since it can't do that, it's going to do a internal rotation or medially rotated arm, right? So you get medially rotated arm, so the palms on the back now, right? Because it can't do lateral rotation. And then you have biceps brachii. So since you can't do supination, your arm will be pronated, and you can't do flexion, so it's going to be extended. Okay, and this is what the presentation looks like then. Okay, so it can't do abductions, that's why it's adducted. Okay, and that's called Ubbs palsy. It's the traction or tear of the upper trunk, C5, C6 over there. Okay, so C5, C6 anywhere here, injury because of pulling of the head to the other side or stretching it or whatever that causes injury of that. Okay, next one is clump. This is traction or tear of lower trunk, C8 to T1, so the ulnar ones, or inferior right there, so lower. Number 2, clump palsy. Okay, so infant's upward force of arm during delivery. Okay, so when you pull the arm, this is the one that goes out first. In adults, it's trauma from grabbing a tree branch to break a fall. Yeah, that's the one that I was talking about. Okay, so muscle deficit is intrinsic muscles of hands. These are your lumbricals, interossei, thenar, and hypothenar. Okay, you need to know what these are coming from, where. So let's see. Lumbricals we already talked about, right there. And then intrinsic muscles of the hand. Intrinsic muscles are just like the muscles inside your hand. Okay, so this is right there would be your palmar interossei, and then D is the dorsal ones on the back, right? See if there's a better one there. Okay, so lumbricals were on the sides, right? And then you have interossei, not here. Let's just do interossei. Okay, so these are like right there, interossei. Okay, in the middle of your palm, and we know where thenar and hypothenars are. Okay, so all of them are going to get affected, so it makes the claw hand. Lumbricals normally flex metacarpal phalangeal joints and extend sorry, not meta, it's middle carpal, I think, and distal or dorsal DAP. Why am I skipping on the full forms for this? I think I'm still sleepy, man. Distal interphalangeal and metacarpophalangeal. Okay, and proximal interphalangeal. Okay, so that's distal phalangeal, proximal interphalangeal, and middle or metacarpal phalangeal joint. Okay. Okay, so all of those are gonna get affected because of these. Okay, and that's how you end up with a clunky palsy. Uh, thoracic outlet syndrome. Okay, so that's compression of the lower trunk and subclavian vessels, most commonly within the scalene triangle. Cervical anomalous first ribs, arrows in A, right over there, or you have Pancoast tumor, right? So it's gonna just compress all of these right over here, the upper or the lower, sorry, the lower trunk right there. Okay, and subclavian vessels. Okay, cervical, we did that. Same as clumps palsy, so that's how you get that. Even in that's what you get in thoracic outlet syndrome. Atrophy of the intrinsic hand muscles, ischemia, pain, and edema due to vascular compression. Okay. Winged scapula, we talked about that one already, right? So it's coming from C5, C6, and C7 into the long thoracic nerve. Okay, so lesions of long thoracic nerve roots are C5, C6, and C7. You get wings of heaven. The cause is axillary node dissection after mastectomy or stab wounds, right? So right after the mastectomy they had, or a stab wound to the thoracic nerve, you get winging of scapula. It supplies the serratus anterior, salt, right? Inability to anchor scapula to the thoracic cage. It cannot abduct arm above horizontal position. Okay, because we know that anything above 90 degrees is supplied by two things. One of them was serratus anterior, and the other was trapezius, right? Or the traps. Okay, so that's what you get. And done with brachial plexus. How much time do I have? 10 minutes. Okay, I think we can finish this. Wrist region: scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, trapezium. Okay, sorry, that was triquetrum. So long to pinky. Here comes the thumb. The one I remember is what was it? It's she looks too pretty. Try to catch her. Okay. Yeah. So she looks too pretty. Try to catch her. Okay, you have to remember where you're starting from. Yeah, whichever one, or you make up your own mnemonic. Okay, so you always start from scaphoid. Okay, and scaphoid is right there where the touching the radius. And then you have to remember where pisiform is. It's always on the lateral. It's the one that's popping out at the back of your hand where the ulnar ends, right? And then the one touching the thumb is trapezium, and then the hamate on the top on the other side. Okay, so scaphoid, lunate, triquetrum, pisiform, hamate, capitate, trapezoid, and trapezium. It's very important that you know where these are, because they'll give you an x-ray of a hand, and then they'll just point to one of these bones and ask you which one is that. Okay, scaphoid, palpable in anatomic snuff box, is the most commonly fractured carpal bone, typically due to fall on an outstretched hand. Okay, this is also a thing that happens. We talked about the hook of Hammett compressing the ulnar nerve, but this can also happen from the same type of injury. Okay, fall on an outstretched hand. So that's scaphoid right there, because it looks like it has a scaphoid dent in it. Okay. Complication of proximal scaphoid fractures include avascular necrosis and non-union due to retrograde blood supply from a branch of the radial artery. Occult fracture not always seen on initial X-ray. Dislocation of lunate may impinge median nerve and cause carpal tunnel syndrome. This is an important one. This is how you end up with a carpal tunnel. Okay, dislocation of lunate. That's the lunate, and that's where your carpal tunnel is. Right here, these are the carpal bones, and this is the ligament, flexure retinaculum ligament, and right under it is the canal or the tunnel, right? And that's where you have all the median nerve coming. You have the flexure digitorum superficial tendons over there, okay? And compression of this is what causes carpal tunnel, because if you compress medial nerve, or if you just press it, you can see if you press the ligaments right under on your wrist, it's gonna flex the fingers, right? So that. And then there's also Guyane tunnel. It's similar to this, but instead of median nerve, it's in the Guyane tunnel. It's ulnar nerve that gets compressed, and then you get the medial side of your hand getting, you know, the numbness and tingling feeling. Okay, so dislocation of lunate may impinge median nerve and cause carpal tunnel syndrome. Fracture of hook of hamate causes ulnar syndrome. Okay, so the ulnar syndrome is because of the Guyane canal. Okay, and impingement of the middle median nerve causes the carpal tunnel. That's the difference between the two canals, and you need to remember these two. The lunate causes carpal tunnel. Fracture of hook of hamate causes ulnar. Okay, hook of hamate is over there on the ulnar side. Lunate is on the radial side. Okay. So before we go on, let's look at a few more wrist bones. Right. Okay. So she looks too pretty. Try to catch her. Okay, the biggest one is always going to be capitate. The one that looks like a scaphoid, that's scaphoid. Okay, this is supposed to look like a half moon. That's why it's called lunate, like a lunar, right? So half a moon. It's the T's that you will probably mess up. So the one that looks like a trapezoid, is trapezoid, right? So it looks like a trapezoid right there. Okay. The first one you come across is trapezium. Okay, it's the longer one, and the shortest T has the longest name, triquetrum. Okay, and then the pisiform is right under the triquetrum, so it's like that, or right over it, depending on how you're looking at it from its side, right? So this is under it in this photo, so because this is the first metacarpal, so that's thumb on the radius side. So pisiform would be on the back. Okay. And that's the hamate, capitate, scaphoid. Let's look at another one uh, without the names. Okay. So first thing you do is you figure out which one's ulna, which one's radius. So this is the radius. So that's the thumb, right? And it's always going to be in anatomical position. Okay. But if it's not, you can look at it if you remember the shape. So this is the scaphoid bone, right? So she looks, that's the lunate, half a moon. So that makes this the capitate, the biggest bone, right? And then you have pisiform right there on the back, and on the front you have what was it? Triquetrium or triquetrum, right over there. And then she looks too pretty. Try. So this is trapezium, the longer one, and then this one that looks like a trapezoid is the trapezoid. Capitate, and that makes this the hamate. Okay, important to first figure out which one's radius. Okay, so there's the radius. Then you figure out which one is the thumb, and then the one closest to the radius is where you start from. So she looks too pretty, and then you go on the top from right to left. Okay, cool. Let's take a break here. Okay, hand muscles. You have thenar eminence over here. We know that now. And hypothenar eminence on this side, on the ulnar side, right? We looked at these muscles, correct? The thenar medium, opponens pollicis. Actually, let's bring those muscles back. Let's look at those. Okay. Okay. This is the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. Okay. Yeah. So these three go to the thumb. Okay. So thenar is opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, and superficial head, deep head of ulnar nerve. Okay. So that was this. Now we're gonna do hypothenar ulnar opponens digiti minimi. Remember, minimi is the small finger or the pinky. All these go over there. So opponens digiti minimi. This is the one that helps you touch the thumb. When you bring it, you try to touch the thumb with the pinky. Okay. Abductor digiti minimi. This is the one that takes it away. And flexor digiti minimi is the one that flexes the pinky. Okay. So all of them have the same starting, right? So opponens, adductor, abductor, flexor. Okay. The middle one is digiti minimi. I mean, the pinky is digiti or digit, the small one or minimi. For this one, and for pollicis brevis for the thumb. Okay. Both groups perform the same function: oppose, abduct, and flex. Okay. Dorsal intraosi or ulnar, they abduct the fingers. Okay. And palmar intraosi. Let's see what these were again. The palmar ones too. Okay. So these are the dorsal ones. Okay. And then there are also palmar. So I guess they're on the palmar sides. Right. So these are your palmar ones. Dorsal and palmar. Cool. So dorsal, they abduct the fingers. Okay, and this is important that you know this. The ones on the back, if you slap the back of your hand opens up, right? So all the fingers get abducted if you slap the back of your hands. If you slap the the palm side of your hands, they all adduct, right? So the fingers are gonna come together and probably make a fist, but we don't talk about the fist. We talk about it getting adducted. Okay. Then lumbricals, first, second, median, third, fourth, ulnar, right? Uh, so it's between the first and second finger, right? Which is supplied by the median, and then there's third between the third and fourth. No, that's wrong. It's just the first and second lumbrical is supplied by the median, and the third and fourth lumbrical is supplied by the ulnar. Right, so we already looked at that. So these lumbricals right here. So this is going to the first one, this is going to the second one, this is going to the third one, this is going to the fourth one. Okay. So these two are supplied by the ulnar nerve, and these two are supplied by the median nerve. And we looked at this part. Right. So it makes sense that the first and second one, that's these two, right, or that two right there, gets supplied by the median nerve, and then the last two, that's this one and the one over here, but they both are attached to this side of the hand, so that's the ulnar supply. Okay, so best way to remember that, again, you slap the back of your hand, so dorsal side of the hand, so dorsal introsi, abduct the arm, right? So if you slap the back of your arm, it spreads out, and if you spread the palmar aspect of your arm, palm, sorry, all the fingers get adducted, sorry. This is important, they test you on this, so remember that. Okay, distortions of the hand. At rest, a balance exists between the extrinsic flexor and extensor of the hand. Okay, that's why it stays right there. So if something is not supplying the extensor, then it's gonna flex, and vice versa, right? As well as the intrinsic muscles of the hands. Okay, particularly the lumbrical muscles, flexion of metacarpal phalangeal joint, extension of the distal interphalangeal joint, and proximal interphalangeal joint. Okay, so that's what lumbricals do. Okay, they flex the first joint in the finger, or the proximal joint in the finger, and then they extend the other two joints of the finger, right? So this would be where the first joint is, so that's the metacarpal phalangeal joint. This is the second, so that's proximal interphalangeal joint, and this is the third interphalangeal joint of the finger. Okay. Clawing, seen best with distal lesion of median nerve or ulnar nerve. So distal lesion is over here. Okay. Remaining extrinsic flexors of the digits exaggerate the loss of the lumbricals. So fingers extend at metacarpal phalangeal joint and flex at the distal or proximal interphalangeal joint. Okay, so the opposite of what it does normally, right? So it flexes MCP, so due to the loss, it's going to extend the MCP, right? So it's going to extend the MCP like that, over there, and since it extends the DIP, PIP, it flexes at DIP and PIP. Okay. Deficits less pronounced in proximal lesions. Deficits present during voluntary flexion of the digits. Okay, deficit less pronounced in proximal lesions. So those are like near your elbows or somewhere else, right? Deficits present during voluntary flexion of the digits. So it's when you try to do something, that's when it's gonna show. Okay, so this is what it's showing over here. Okay, proximal and distal injury. So before I get rid of this, again, on the palmar side, if you look at your hand, on the palm side, the last two fingers are last 1.5 finger is supplied by the ulnar, while on the back side, same thing actually. Last 2 fingers and 1.5 finger is supplied by ulnar. On the palmar side, majority of everything else is going to be supplied by median nerve. So first 3.5 finger is supplied by median nerve on the palm, and on the back it's only the above the MCP that median nerve supplies over here. Radial nerve on this side, a little bit of the thinner eminence, but on the back it's majority of the back of the hand that gets supplied by radial nerve, and that's because it goes behind the radius and supplies the arm from the back, the recurrent branch of the median nerve. Okay. Okay, let's get rid of that. Signs: presentation, context, and location of the lesion. So ulnar claw, we need to know what distal ulnar nerve means, right? Okay, so it's anywhere over here. Okay, that would be the distal. So what would be the proximal? Proximal is at the epicondyle, right? So anywhere over there is the proximal ulnar nerve injury. Okay. Okay, so presentation is going to be like that. So if you see an ulnar claw like that, its context is that extending the fingers at or at rest. Okay. So when you try to extend it, it's not going to function properly, right? So it's going to end that way. So what you're seeing here is you're seeing extension at MCP. Okay, so that's extended at MCP, and you're seeing a flexion at these PIP and DIP. Okay, so that's what you're seeing because of the loss of ulnar nerve on the distal lesion. Okay, hand of benediction. So when you're trying to make a fist, the median nerve is the one that's getting the thing, right? So since it's not a distal lesion, it's a proximal lesion, you won't see this presentation right here, right? So all you're seeing is just the extension working it, because I guess it's not getting affected. So your main the ulnar division is gonna make the fist, but not the median nerve. Okay, since it's the proximal median nerve injury. So proximal median nerve injury is again somewhere here. Okay, they probably give it right here. Supracondylar fracture of the humerus causes the proximal lesion of the nerve, and then carpal tunnel syndrome or wrist laceration causes the distal one. For ulnar, again, it was they didn't give it here. Okay. Okay, that's why it's not exaggerated. Okay. However, if it was distal median nerve, you'll get extending fingers at at rest, right? So here you're gonna see this now because it's distal. Okay, because that's what the clawing is happens when there's distal lesion of median ulnar, right? So you'll see extension at the MCP and flexion at the DIP and PIP. Okay, for distal median nerve. Again, that's this part of the hand that gets lesion. So you'll see the median claw over there. So the claw happens again only at the distal lesions. Okay, so for ulnar, say if it was middle epicondylar region, medial epicondylar region that gets injured. Why medial? Because that's where the ulnar nerve passes through, right there. Okay, so that would be your proximal lesion of the ulnar nerve, and you try to make a fist. You won't see this anymore, right? Because that's for the proximal ones. At proximal, you see less pronounced unless you're trying to voluntarily flex the digits. So now that you're trying to make a fist and flex the digits, they're not going to comply, right? So you'll get just what you see at rest. Okay. Okay, so note, atrophy of the thenar eminence can be seen in median nerve lesions, while atrophy at the hypothenar eminence can be seen in ulnar lesions. Okay, so median nerve, because this is this is the thenar eminence, it's supplied by the median nerve. So if you see that it's atrophied, uh, it's because of the median nerve lesion. And if they tell you that the hypothenar eminence is atrophied, right, this area right there or that area, um, you can think of something wrong with the ulnar nerve. Okay, next. Okay, so I have a few mnemonics for this one. So first, before we go into it, we need to know what the muscles of hip are, right? So this is the anatomy of the hip. Okay, let's start with this one. Okay, so that's psoas major is up here. Okay, let's look at this while we look at that. Okay, so psoas major and psoas minor is over here. Okay, this is the iliacus. It's inside of the thing, right? So psoas major, inside of it will be psoas minor. It's going from the spine to the uh, femur, and then iliacus right there, right? Then on the side of the anterior iliac spine, you have tensor fasciae lata, going from here to, you know, over there, back of the femur. Okay, so it's not attaching on the femur head or anywhere. It only attaches back here. Okay, so that's your tensor fasciae lata. Then you have sartorius that just crosses through your hip from here to here. Okay, they don't have sartorius on this one. Okay, so this thing right here would be your sartorius, right? It's going from it, the one that crosses. That's the only one that crosses like this. Okay. Then you have rectus femoris right there. Uh, these ones are the easiest ones to remember. Vastus lateralis is on the lateral side. Medialis is on the medial side, and then there's intermedius as well. They don't talk about it, so I guess it's not important. Okay. So vastus lateralis, vastus medialis, you know where those are. Rectus femoris is like the bicep femoris, right? Is the biggest one, the fattest one. Okay, rectus femoris, and it's in right in the middle right there. Okay, then there's gracilis. That's the honeymoon muscle, right? Because that's how you check your cremastric reflex with this one, the nerve that travels through this one. Or when you grace the medial thigh, this is the one that gets contracted. And there's something happening in your groin area as well. Adductor longus is this one, and then this is the pectineus. Okay, let's check this one now. Adductor longus, adductor externus, so it's on the outside. Okay, this is the back side. Okay, this is not the front, this is the back. This is the front side. Okay, so I think we missed this one, iliotibial tract. Okay, so it's going to the tibia, so it does not attach anywhere on the femur. Okay, this tensor fascia lata. You have adductor magnus right here, adductor longus right there, and adductor brevis over here. Okay, BLM. This is important because that is we'll read that soon. The piriformis is right here. It attaches the sacrum to the head of the femur, or not the head, but the whatever that is. Then this is gluteus maximus. Okay, it attaches from here to here, and the medius is over here, and the minimus is right here in that part. Okay, this is again the back sides. Okay, done with that. Done with this. And we'll look at this while we're doing the other stuff. Okay. So the action and muscles. So for abductors, it's gluteus medius and gluteus minimus. Okay. So I have a mnemonic for that. When you try to abduct someone, you want minimum media presence, right? So minimum for gluteus minimus, and media for gluteus media. Okay. So abductors. When you try to abduct someone, you abduct with minimum media presence, and that's how you should remember that. And these are all actions of hip muscles. Okay, not the knee. Don't confuse it. We don't do the knee. We only do the hips. Okay. Then you have adductors. Okay. You have adductor magnus, longus, and brevis. So you add a hip BLM poster. BLM, remember? So for us, it's brevis, longus, and magnus poster. So add a hip BLM poster. Okay, so add for adductors, adductor magnus, longus, and adductor brevis. Okay, then there's extensors. Extensors are gluteus maximus, semitendinosus, semimembranosus, and long head of bicep femoris. Okay. For this, you just need to know what these are, and when you try to stand up, right? When you're sitting down and then trying to stand up, these are the muscles that get activated. So just remember that. So it's your gluteus maximus. Even right now, if you're sitting down and you try to stand up, just focus on the muscles that are activating. It's gonna be your gluteus maximus, semimembranosus, and semitendinosus. Okay, so this is your semimembranosus, tendinosus, and this is your semimembranosus behind your leg, and gluteus minimus, and long head of bicep femoris as well. Okay, so that's this. Bicep femoris is in the back, and in the front you have rectus femoris. Okay, so on the back you have bicep femoris. So gluteus maximus, semimembranosus, semitendinosus. Then onto flexors. So iliopsoas, iliacus, and psoas. Right. So we saw those where they were. Right. That's iliacus over there and psoas over here. So iliacus and psoas. Rectus femoris is the one in the front, right? So rectus femoris right there. And that's the psoas, and that's iliacus up where? Okay, that right there and that. Okay. And tensor fascia lata, and pectineus, and sartorius. Okay. So for this one, it's flexors. So this would be the flexor. Okay. Sir Ilio, while flexing his pecs, wrecked the female's tension of Lata's face onto his hips. Okay. So Sir Ilio, so that's Sartorius, and Ilio Suhas, right? So Sartorius, Ilio Suhas, while flexing, because these are flexors, his pecs, or pectineus, right? Wrecked the females, that's just rectus femoris. Tension is tension of Lata's face, that's tensor fascia lata, and onto his hip, because these are hip flexors. Okay, it's going to take some time to remember it. You can use your own, but this one is the one that I used because I made it. Okay, so iliacus, psoas major over there, pectineus over here, rectus femoris, and sartorius. Pectineus over here, right? This thing from the front. Okay, then you have internal rotators. Okay, internal rotators are gluteus media, gluteus minimus, and tensor fascia lata. I don't think you really need one for this, but I have one. It's messed up, and lata got minimum media coverage. So lata is like a famous celebrity, right? So someone at the PR department, the intern messed up, and now she got minimum media coverage. So intern as in internal rotation, lata as in tensor fascia lata, got minimum, that's gluteus minimum, and media is gluteus media. Okay, and then external rotator rotation, right? So that's not here. Okay, these were adductors, so that's brevis, longus, and minimus, magnus, sorry, over here. Okay, and gracilis on this side and pectineus over there. For this one, it's iliopsoas, gluteus maximus, piriformis, obturator internus, and obturator externus. I've done this a few times, so now I just remember these from the mnemonics, but it takes time if you want to remember it through the mnemonics. Okay, so obviously ilio is a hip extern. Why? Because he makes maximum gluten-free peri-peri fries. Okay, so obviously is obturator internus. Okay, ilio is iliopsoas, is a hip extern because it's a hip external rotator. Because he makes maximum gluten, that's gluteus maximus, right? Gluten-free peri-peri fries. So peri-peri fries is just a type of spice they add on fries. If you just Google that, you'll see it. So peri-peri fries is piriformis. Okay. So it's obturator, internus, and externus. Okay. In the last one, they just said obturator. They didn't, like last edition, they didn't differentiate between internus and externus, but now they're naming the both of them. So this is, it still works. So again, abduct with minimum media presence, that's abductors of the hip, gluteus minimus and gluteus medius. And then you have add a hip BLM poster, that's adductor brevis, adductor longus, and adductor magnus. Then you have extensors. You just remember when you're sitting and try to stand up, you have contraction in the gluteus maximus, semimembranosus, semitendinosus, and biceps femoris, right? Then you have flexors. That was this thing right here, right? It fits there. Sir Ilio, while flexing his pecs, wrecked female's tension off Lata's face onto his hip, something like that. So Sir Ilios, that's Sartorius Iliopsoas, while flexing his pecs, that's pectineus, female's tension off the face, so that's tensor fascia lata. Wrecked the female, so that's rectus femoris onto his face. Okay, so did we get them? Iliopsoas, rectus femoris, tensor fascia lata, pectineus, and sartorius. Okay. Then comes internal rotators. That's when the intern messed up and lata got minimum media coverage, right? So that's tensor fascia lata, gluteus minimum, and gluteus medius. Sorry. So gluteus minimus and tensor fascia lata. Okay. Then you have external rotators. That's obviously ilio is a hip extern. Why? Because he makes gluten-free peri-peri fries. So obviously for obturator, Ilio for iliopsoas, hip extend, because he makes gluten free, so gluteus maximus. Peri, that's piriformis. Okay, so iliopsoas, gluten maximus, piriformis, obturator internus, and obturator externus. Okay, on to next. Lower extremity nerves. So now we're doing all the nerves over here, supplying these. Okay, let's see if we can figure out where this is from. Okay, so this is the iliohypogastric, so that's from T12 to L1, right? So lumbar 1 and T12 between that. You get iliohypogastric nerve. Okay, it's going to the suprapubic region, right? So there's the pubic region, so it's going above that. Okay, so iliohypogastric, hypo is below, right? And gastric is just the abdomen, so maybe it's like that. And then ilio, because it's in the inside of that, right? So this is iliopsoas. This is psoas, this is iliacus, so iliohypogastric nerve. That's the pathway it goes through. Okay, so sensory intervention is for suprapubic region, and then motor intervention is transversus abdominis, right? That's your those are your abs, and internal oblique as well. Okay, uh, this is going to be cause of injury will be abdominal injury. So there are a couple of mnemonics for these two to remember that. It's abdominal surgery damages the ilio. Okay. I think these are from Dirty Medicine. Abdominal surgery damages the ilio. Right? So iliohypogastric. So abdominal, it's important. So they'll say that this person start feeling sensations after surgery, abdominal surgery. It's going to be because of this. Okay. Presentation will be burning and tingling pain. Okay, so that's what it is. Burning and tingling pain in the surgical incision site, radiating to inguinal and suprapubic region. Okay. Then there's genitofemoral nerve. Okay, let's go look where that is. Okay. So they all look the same to me. But I guess that's the one, right? It's going from, I can't even explain it. Okay, better. So it's going from there to the genital and femoral part, right? Going from genital part and to femoral part, I guess. So it's going in from that, comes out of the psoas muscle. This is the iliohypogastric one, right? It's going from behind that and then into this and then into this. Ilioinguinal nerve is right here through the external inguinal ring. Okay. So genitofemoral nerve, right? Sensory is it's in the name. Sensory supply to scrotum, labia majora, because scrotum is you know derivative of the same thing that makes the labia majora in female, and medial thigh. Okay, so sensory to that. Motor is creamastric. Okay, this is the honeymoon one. Then it's laparoscopic surgery, so that's where it happens, right? Because you enter through this area anyway, somewhere here, so accidentally you can injure this, because that's where laparoscopic surgery happens from. Presentation comments. Decrease in upper medial thigh and anterior thigh sensation beneath the inguinal ligament. Okay, decrease in upper medial thigh and anterior thigh sensation beneath the inguinal ligament. So inguinal ligament would be right here, right? So beneath this area, wherever this is applying, so it's supplying to the scrotum or the labia majora, and here the anterior aspect of the thigh or medial thigh, right? So upper middle thigh and anterior thigh sensation beneath the inguinal ligament, lateral part of the femoral triangle, absent creamastric reflex. Okay, so that's how you would check that. It's coming from under iliohypogastric, so hypogastric was from 12 T12 to L1, right between that. So it's coming now from this thing, that's L1 to L2. Okay, lateral femoral cutaneous, sensory is anterior lateral thigh. Okay, and you stop feeling sensations in this area, and the way this happens is because of tight clothing, obesity, pregnancy, or pelvic procedures. They all can lead to that. What do they lead to? Decrease in thigh sensation, anterior and lateral thigh. Okay. For this, okay, let's finish this. Meralgia, paresthetica. Compression of lateral femoral cutaneous nerve leads to tingling, numbness, burning pain in anterolateral thigh. Okay, so let's just look at where that is. Okay, so that's coming from that to that. That's L2 to L3, right? And going over there. Okay. Mnemonic for this is LFC, so lateral femoral cutaneous, for lazy, fat clothing. That's what this gets affected by, right? If you're lazy, you're obesity, and fat for obesity, I guess, and uh, tight clothing for clothing. Okay, so lazy fat clothing works. Just if you this is usually the one that they'll say that this person stopped feeling sensations after wearing a very tight jeans. Uh, it's because of which nerve that this person is not having sensation in the anterior and lateral thighs. It's because of lateral femoral cutaneous. It's in the name. Cutaneous is in the name, so that should be easy to remember. Then there's obturator. Okay, and its sensory is to medial thigh. Let's look at what that is. Obturator nerve supplies the obturator. Okay, so it's coming from there to the anterior division. Okay, there. So it's coming from L2 to L4, right? According to the book. So that's L4 right there. And it's being supplied by this too over there, and some fibers of L3 coming here too, some fibers L2. So all of them are coming from there. Okay. For this, okay, so let's do this and then I'll give you the mnemonic. Sensory, medial thigh. Motor, obturator externus, adductor longus, adductor brevis, gracilis, pectineus, and adductor magnus. Okay. Pelvic surgery is why this would happen. And there's decreased thigh sensation, medial and adduction. Okay. Okay. So obturator is damaged by the obturator. Okay. Uh, because of pelvic surgery. So that's how you remember. And yeah. L2 to L4 for obturator. On to femoral. This is important one. High yield. Sensory height, anterior thigh, medial leg. Motor is to quadriceps, iliacus, pectineus, and sartorius. Okay. Quadriceps are like your part of your hamstrings, right? Okay. Female nerve going to all of these, right? This is the one that supplies to the most number of muscles, I think. Okay. Nope. Okay. This is a good one. So it's coming from L2 to L4, right? So L2, L3, and L4 coming in, supplying to nerve to iliacus, pectineus. A branch from anterior division goes to the sartorius, middle cutaneous, and intermediate cutaneous, and branch from the posterior division. So that's the anterior division, that's the posterior division. Sorry. Uh, Going to the nerve to rectus femoris. Uh, Vastus lateralis, intermedius, and medialis, right? And then saphenous nerve. This is a sensory right there. Okay, so the sensory ones are these, and these are the sensory ones as well. Medial and intermediate cutaneous nerve and the saphenous nerve. Okay. So sensory, anterior thigh and medial leg. Motor is quadriceps, iliacus, pectineus, and sartorius. It happens because of pelvic fracture. Uh, Decrease in leg extension and decrease in patellar reflex. So patellar reflex is supplied by femoral as well. Okay. So all of these, if they're asking you for the muscles supply by this, it would be all the flexors of the thighs. Flexors and extensor of the thigh. Sorry, wait, no. Thigh and the muscles causing extension of the medial leg, medial part of the leg. So all those saphenous nerve comes from there. Okay, so okay. Basically, what it does, femoral nerve is responsible for thigh flexion and leg extension. Okay, just remember this photo, and you should be good enough from just that. Then there's sciatic nerve. Okay, sciatic nerve is the one that causes the sciatic nerve pain, right? For due to herniated disc. Uh, so let's look at that. Coming from there. Uh, okay, right. So this is where it usually hurts. If there's a, what do you call it? Herniated disc, right? Motor, semitendinosus, semimembranosus, and bicep femoris and adductor magnus, right? So these were your, most of these were your extender of the hip, right? So the only thing that's added here is adductor magnus, and there's no gluteus maximus here. So it happens due to herniated disc, posterior hip dislocation, splits into common perineal and tibial nerves. Okay, uh, this is important. We'll learn about that. Actually, I don't think they'll show it to us. But this thing then, after it reaches this area, the knee or the back of the knee, it splits. Okay. Right there, so sciatic nerves coming in, then there's common fibular nerve, and this is the tibial nerve going all the way down here. Okay, so this one is not that high yield. What is these two. Okay, so common or fibular perineal nerve, common perineal or common fibular perineal. They could use both of them. Why fibula? Because it goes over the fibular region of the leg. Okay, and it comes up and around, and then it supplies this side of the leg. Okay, so intervention is superficial perineal nerve, sensory to the dorsum of the foot except for the web space between helix and second digit. Okay, uh, so helix and second digit, it should be right there. It doesn't supply over there, but they're not showing it here. Okay, so yeah, they showed it here. So here it's the deep perineal nerve that supplies it. So common perineal only supplies over here, and then superficial perineal supplies over here, and then you have nothing over there. Okay, and that's where the tibial is going to come in from. So over there. Okay, we'll do that here. Okay, so sensory, dorsum of the foot, except web space between helix and second digit. We need to know what helix is. Okay, so that's the helix. So between that and the second digit is this, so the area between that. Okay, motor is to peroneus longus and brevis. Need to know where that is. peroneus longus, brevis, and tertius is over there. Okay, so it goes from here to here to here. Okay, deep peroneal nerve goes to the web space between helix and second digit. We saw that. And motor is to tibialis anterior. Is the anterior of the tibia. So this right here is in the name, anterior tibialis or tibialis anterior. Cause of injury, this is important. This is trauma or compression of lateral aspect of the leg. Okay, that's where your fibula is, and fibular neck fractures happens over there. So presentation is the most important thing you gotta remember. That's usually what they test you on. Okay, peroneal everts and dorsiflexus. If injured, foot dropped. Okay, so peroneal everts and dorsiflexus. See what that looks like. Okay, so this is dorsiflexion, this is plantar flexion, this is inversion, and this is eversion or everts, and this is inversion. Inversion is towards the medial, eversion is towards the lateral. Okay, so since it's the lateral aspect, peroneal, everts, and dorsiflexus, right? So this is the normal presentation or normal thing that fibular and peroneal nerve is responsible for. So when this is not there, it's going to invert and plantar flex, right? So plantar flex is also known as foot dropped, right? Because foot's dropped, that's what it looks like during injury. And since it everts, it's not gonna evert anymore. It might invert, right? So it's not gonna evert, so might invert. So foot dropped and inversion is gonna happen. Whoops. Okay, so foot dropped, it's inverted and plantar flexed at rest. Loss of eversion and dorsiflexion, so you get the steppage gait. Okay, so remember that this is what it's known for: eversion and dorsiflexion. Peroneal, everts, and dorsiflex. So ped. Okay, and it, if injured, it calls dropped foot. Okay, then you have tibial. Again, L4 to S3 is coming from sciatic. That's L4 to S3. Sensory is to sole of the foot. Okay, and motor is bicep femoris, long head, triceps surae, plantaris, popliteus, flexor muscles of foot. Don't have to remember that. Cause of injuries, knee trauma and Baker cysts. Baker cyst is just basically a cyst on the back of the knee, I think. So right there, back of the knee is where the cyst happens, and that cyst is called Baker cyst. Proximal lesion, tarsal tunnel syndrome, that's distal lesion. So tarsal tunnel, just like carpal tunnel, it's below the fascia that's on the ankle. Okay, right there. And from under it, you have all these structures passing through, so compression of that will give you tarsal tunnel. Okay. Right there. Cool. So what does tibia, or what is tibial, responsible for? So it's responsible for inversion and plantar flexion, right? If injured, you can't stand on tiptoes, and this is the one that they test you on. So for you to be able to differentiate between the foot drop and tibial injury. because it's responsible for this and standing on tippy toes. So plantar flexion and inversion. So if you can't do that, you can't plantar flex, right? So you can't stand on your tippy toes. It's inability to curl toes and loss of sensation on sole. In proximal lesion, foot everted at rest with weakened inversion and plantar flexion. Okay, because the opposing muscles that are being innervated are gonna act. So that's why you get the foot eversion and weakened inversion and plantar flexion. Okay. Usually, if you just remember this, you'll be good to go. This and this. Okay. When you're walking and it just drops while you're walking, that's called steppage gait. Okay. Let's see if there's a video for this.
This video.
So he can't lift it up, right? Okay. Okay, that's it. Okay. So these two are the most high yield ones out of all these nerves. So if you don't remember any of them, at least put in some effort to remember these ones. Superior gluteal. Oh yeah, this too. They ask you about this, but this one is pretty easy to remember. For this one, you have to remember the nerve root. That's what they test you on usually. Okay, so they'll tell you this person is walking weird for some reason. What could be the cause? So injury at between L4 and S1. Okay, or superior gluteal. So motor, gluteus medius, minimus, and tensor fascia lata. Okay. Medius. So it's this one. Your internal rotators that are gone, right? Iatrogenic injury during intramuscular injection to supramedial gluteal region. Prevent by choosing superolateral quadrant, right? So if you ever administered to someone, this is their butt, right? Okay, like that. Okay, so when you're trying to give them a shot, right? So you make a line across there and line across that. So if someone gives them a shot in this region, they can end up with this injury. So to avoid that, we give them a shot in this region to avoid hitting a nerve. Okay. That just looks wrong. Iatrogenic injury during intramuscular injection to supromedial gluteal region. Prevent by choosing superolateral quadrant, preferably anterolateral region. So the sign that you see is called Trendelenburg sign or gait. The pelvis tilts because weight-bearing leg cannot maintain alignment of pelvis through hip abduction. Okay, normally when you lift this leg up, the muscles over here compensate for that lift. However, and the muscles that compensate are gluteus medius, gluteus minimus, and tensor fascia lata, right? It goes from here to here into your tibia, or yeah, something like that. So when this happens, and there's no compensation is because there's injury of superior gluteal, and it's called the Trendelenburg sign. Okay, how much time I have? 2 minutes. Okay. And then lesion is contralateral to the side of the hip that drops, ipsilateral to the extremity on which the patient stands. Okay. Inferior gluteal, L5 to S2. Motor gluteus maximus, posterior hip dislocation, not important. Uh, Difficulty climbing stairs and rising from seated position, loss of hip extension. Okay, inferior gluteal, hip extension. Pudendal, sensory, S2 to S4, sensory perineum, motor, external urethral and anal sphincter. Stretch injury during childbirth, prolonged cycling, horseback riding, decreased sensation in perineum and genital area, can cause fecal and or urinary incontinence, can be blocked with local anesthetic during childbirth, using ischiospine as a landmark for injury. This is what they give you, and they'll ask you which nerve was injured. It's the pudendal nerve. Okay, we're done. We'll continue this after the. Yeah, so I was talking about pudendal. It can be blocked with local anesthetic during childbirth using ischiospine as a landmark for injection, right? So this is how they do that. They bring it in. They feel the ischiospine. This is the ischiospine right there. Um, it's not as visible there, but just remember that. And then the pudendal nerve, it goes around that that ligament right there, the sacrospinous ligament, right? And that's what that is. So for the ischiospine, that's what that is, right? This little thing that's poking out, that's the ischiospine. Okay. Uh, they usually ask this in a repro question, but now you know what they mean. And it's always pudendal nerve that can get damaged uh, during that thing. Okay, so stretched injury during childbirth or prolonged cycling or horseback riding. Okay, on to knee exam. Uh, the lateral femoral condyle to anterior tibia and medial femoral condyle to posterior tibia. What does that mean? It just means that the lateral condyle is attached to the anterior tibia through anterior cruciate ligament. Okay, so that's the anterior cruciate ligament. Okay, that's the femur. This is the lateral side. This is the medial side. This is the lateral condyle, the lateral femoral condyle attached to the tibia's medial lateral side. This is the anterior, right? So it's attached to the interior. And then there's also one that's posterior as well. The posterior tibia is attached to the medial epicondyle. So that's this little thing that you're seeing. So that's this and this. So that's the posterior cruciate ligament, and the anterior cruciate ligament is this. Okay. Uh, let's look at a few more of diagrams over here. So you remember it like lamp. Okay. So lateral to anterior is anterior cruciate ligament. Medial to posterior is posterior cruciate ligament, right? So anterior, lateral to anterior is anterior cruciate ligament. It attaches over there. Posterior uh, to medial, so medial to posterior, LAMP. So M to P is with P, CL, right? This is the medial cruciate ligament. This is the lateral cruciate ligament. Okay. You need to know it this way as well, because they usually give you like a X-ray of this, X-ray or some kind of scan that shows you from the top view, and then you have to figure out which one is which. But I can't find the top view anywhere. Scan. So maybe they'll give you that, and then they'll ask you which fiber is going from where to where, and then all you have to see is in which way it is, And even if it's not, then it's you just figure out that this is the tibia, this is the medial, this is the lateral. How do you know this one's lateral? It's because you see the head of fibula, and fibula is on the lateral side, right? And when you see two condyles like this, it's going to be the posterior side that you're looking at, right? Because anterior side looks like this. Anterior of the joint looks like this. So this would be the lateral side now. This is the medial side now, right? And then you just go from there. Okay. So from the back, again, this is the lateral side, this is the medial side. You're seeing fibers, right? And LAMP, LA, lateral condyle, so that's this condyle, goes to the anterior of the femur. So you're not going to see it, but it's this fiber right there. That's anterior cruciate ligament. Posterior cruciate ligament goes from the medial epicondyle to posterior, right? So that's this fiber right here. That's posterior cruciate ligament. Okay. This would be your medial cruciate ligament, this one right here, and this would be your posterior cruciate ligament. Okay. If you're looking at the meniscus, this is what it would look like. So this is the lateral side because this is the fibula, right? So this is the lateral, so this makes that lateral meniscus. That makes this the medial meniscus, the tibial collateral ligament, the posterior cruciate ligament over here, right? MP, it goes from the medial to the posterior, and this is the anterior cruciate ligament that goes from the lateral to the anterior. So we don't see the lateral attachment there. Okay, this is the transverse ligament of the knee. This is the patellar ligament, and that's it. Okay, I think we can go on now. So one more time, I'll just read this. The lateral femoral condyle, right? So lateral femoral condyle is which one? It's this one, right? Because that's where the fibula is. So lateral femoral condyle to the anterior part of the tibia. So this would be the tibia, and this is the anterior part. So right there, ACL. That's what this is. Then where's PCL? You do the medial femoral condyle. So this is the medial femoral condyle. There's the posterior tibia on the back over there. So that's where the PCL will go through. Okay. Fibula and tibia. Okay. Medial meniscus is on the medial side. Posterior lateral meniscus is on the lateral side. This is the LCL. That's lateral cruciate ligament. This is medial cruciate ligament. Okay. Anterior drawer test. So basically, how you figure out there's a tear in ACL. This is what you do for that. You bend the knee at 90 degrees angle like that. You increase the anterior gliding, so you pull this leg towards you, like you'll be sitting here, right? Let's draw a little person. This is you with your arms coming out and your hands over here and like that, right? And then you're sitting like this, okay, and you're pulling it towards you. Okay, so anterior gliding of tibia relative to the femur due to anterior cruciate ligament. Lachman test also tests ACL but is more sensitive. It increases anterior gliding of tibia relative to the femur with knee bend at 30 degrees angle. Okay. This is 90. You only bend it at 30 degrees, so this will be like over there, and that's called the Lachman. You don't need to worry about that. All you need to know is to check for ACL tear. You're gonna bend forward, bring it forward, right, and you will be able to do that if that happens. Sometimes they just tell you that after bending the knee, the leg is moving forward, or there's increase in angle or something like that, or gliding forward. What type of injury is this? That's a ACL injury. Okay. Then the posterior drawer sign is you do the same thing, but instead of pulling this way, you push backwards. Okay, so instead of that, your hands are over here now. Whoops. And you're pushing this way now, right? So let's bring that here. uh, let's give you the leg too. Okay, so now you're pushing that way. So bending a knee at 90 degrees angle, increase posterior gliding of tibia due to PCL injury. Okay, so you're pushing it that way, and you'll be able to do that. And the injury here is posterior. Easy. And if it moves anteriorly, it's an anterior cruciate ligament injury. If it moves posteriorly, it's a posterior cruciate ligament injury. Okay. Now there's abnormal passive abduction. Okay. Abduction is going away, right? So when you go away, that's lateral movement, right? And the lateral movement has L in it. It starts with L. So when you're talking about the valgus test, valgus has L in it, so that's lateral for a lateral. If it was medial, it's called varus, and there's no L in varus, so that's the medial one. Okay, just a quick tip for that. Also called valgus stress test. Okay, so this time you're moving laterally. So if you're able to do that, uh, it's the injury is on the opposite side. Okay, so medial cruciate ligament injury. So also called valgus stress test, knee either extended or at approximately 30 degrees angle, lateral or valgus force is applied. So here the force is coming from here. Okay. So when you apply force like this is going to move this way. Okay. So lateral or valgus force, uh, medial space widening of the tibia, right? So when you push it this way, uh, you're creating tension over here, right? And increasing the angle between this over here. So that's going to cause the widening of tibia over there. And if that happens, you have MCL injury. Okay. Uh, so that's called abnormal passive abduction. So sometimes the question stem will say that dude is playing a game of football and someone tackled his knee from the lateral side. What type of injury will you see? You'll see MCL injury. Okay. Uh, uh, yeah. So abnormal passive adduction, also called varus stress test. Okay. Knee either extended or at 30 degrees angle. Medial varus force. So now this is the medial cruciate ligament. So you apply force this way. Okay. You push that way and you're able to create an angle, then that means that you have lateral cruciate ligament injury. Okay. Knee either extended at or uh, at 30-degree angle. Medial varus force is applied. Varus is medial force. Remember, valgus is lateral force applied. Okay. And you have lateral space widening of tibia, so lateral cruciate ligament tear injury. You have that. Okay, so adduction is varus. Adduction is, coming inwards. This is the lateral side. Okay, so the leg is gonna happen to, go medially, and that's why it's called adduction force. Okay. Uh, Adduction. So if you're coming from lateral and the knee is moving laterally, it's getting abducted, right? It's going away. That's why it's called the abduction force on the ankle. Okay. Uh, Valgus force of the knee and abduction force on ankle. Right, so the ankle is moving outwards. That's what I mean. Okay. Then there's something called the McMurray test. Uh, it's during flexion and extension of knee with rotation of tibia foot. Okay. I used to live in a place called Fort McMurray in Alberta. Pretty cool town. It's isolated 5 hours above Edmonton. Uh, Absolutely no significance of that here. During flexion and extension of knee with rotation of tibia and foot. Okay. Um, During flexion and extension. So you're flexing and extending the knee with rotation of tibia and foot. Okay. Tibia and foot, doing that and that. Okay. Pain, popping on internal rotation and varus force. Lateral meniscal tear. Internal rotation stresses lateral meniscus. Pain popping on external rotation and valgus force. Medial meniscal tear. External rotation stresses medial meniscus. For this, let's bring in this photo. Oops. Okay. Okay. Okay, let's look at this while we're looking at this. During flexion and extension of the knee with rotation of tibia and foot. So remember it like line. So lateral meniscal tear. If you have a lateral meniscal tear over here, right? This is the lateral side. This is the lateral side. If you have tear over there, you'll have pain popping on internal rotation. Okay. Okay, so pain popping on internal rotation. So when you're trying to rotate it inwards, right, like that, I guess. No. Okay. Internal rotation and varus force. I'm just trying to think of a person in front of me. I'm holding his foot and the calf, and I'm moving it internally and applying a little varus force, so medial force to it, right? And if I'm able to do that, it's called lateral meniscal tear, right? So internal rotation stresses lateral meniscus. Okay, so let me draw little hands to help you think of that. So your right hand is going to be holding this, right? uh, like that, and then you have left hand coming here and holding the calf from down here. Okay, and then you're moving this way, and with this hand you're moving it that way. Okay, and when you're doing that and this hurts over here, it's because of lateral meniscal tear. Okay, so internal rotation stresses lateral meniscus. Okay, this little hurt sign is not on the medial, it's because of the lateral. It's just showing you that you have pain at the knee. Okay, that's what confused me. So pain, so if you're doing the same thing, but this time you're moving it this way, okay, your palm was moving that way, right? And moving the leg that way, but this time the palm's moving this way. And with the calf, your other hand, you're pushing it this way, and you have pain at the medial. Uh, okay, pain popping on the external and valgus force is medial meniscal tear. So medial side, and you're able to do this. It's because of medial meniscal tear. Okay, so external rotation stresses medial meniscus. Easiest way to remember, you just remember line, like lamp. We had lamp up here, and now here we have lime. So lateral meniscal tear gets uh, what do you say, exhibited by internal rotation, I guess, and medial meniscal tear is elicited by external rotation. That's the word, elicited. Okay, so again, lateral meniscal tear is elicited by internal rotation, and internal rotation is this way. Okay, the heel goes outwards, the toes come inwards, while you're pushing medially from the medial to lateral side, right? So you have lateral meniscal tear. And for this, okay, you're pushing the heel uh, inwards and the toes outwards, so that's the external rotation, and you're pushing the leg inwards, and that you have medial meniscal tear. So whichever side you're pushing medial, then you have medial meniscal tear, and if you're pushing it lateral side, you have lateral meniscal tear, because that's what they're going to use in the question stem. That's how they're going to explain it. Okay, so I think I got it. We'll move on. Okay, ankle sprains. These are easy. Don't get intimidated by them. Uh, all the attachments are in the name. So anterior talofibular ligament is the most common ankle sprain overall. So that's talus and that's fibula, right? So talofibular. Let's look at talo. That's talus right there. That's fibula. So this one is anterior talofibular ligament, right? Most common ankle sprain overall, right there. It's classified as a low ankle sprain. This is a low ankle sprain over here. Okay, it's due to over inversion, right? So it's going, your toes are going inside or inwards, and supination of foot. Okay, so it's the same thing. Supination. It's when you're, bring your palm upwards as supination. So you're doing the same with your soles. You're bringing it inwards. That's supination of the foot. Okay. So always tears first. Anterior talofibular ligament. This is the one you gotta remember for low ankle sprain. Okay, most common one, and it's between talus and fibula, right there. Then you have anterior inferior. So anterior inferior tibiofibular. So that's between tibia and fibula. So that's this one right here. Anterior inferior tibiofibular ligament. Why is it inferior? Because there are also other ligaments up here, and that would be known as anterior superior tibiofibular ligament. Okay, so anterior inferior tibiofibular ligament, most common most common high ankle sprain. Okay, high ankle sprain is between tibia and fibular ligament. Okay, and that's it. Why? Because the head of fibula is down here, and head of tibia is up there. So the tail of tibia and head of fibula, or did I say that the opposite? Whatever. So the fibula is planted into the talus, whereas tibia is just attached for the sake of attachment. So that's why the sprain over here is can happen. Okay, and that's why it's this ligament and not somewhere down here. Okay, so just remember that anterior talofibular is always tears first, most common one, and it's called the low ankle sprain. And then you have high ankle, which is higher, between tibia and fibula. Okay, and that's it. Signs of lumbosacral radiculopathy: parastasia and weakness related to specific lumbosacral spinal nerves, intervertebral disc, nucleus pulposus herniates posterior laterally. Okay, so let me just do this so it's easier to imagine what's happening. Okay, so this blue part right here is nucleus pulposus. Okay, and this is the annulus fibrosus, I guess, and we have the nerve coming in from these little foramens right here, and then this is equina propria. What? Okay. So because of the annular ligament right here, the anterior ligament, it's thick compared to the posterior one. So the chances are that if something happens and this compresses downwards, this is gonna, get squished. And if it gets squished, it's gonna go through the sides, right? But this membrane right here and ligament and whatever is really strong. So, and the ligament here is weak. So if there is compression happening, it's probably going to get leaked through out here. Okay, uh, like that. Okay, and when it does get leaked out, it's going to compress the nerves over there. Okay, so when that happens, you get paresthesia and weakness related to specific lumbosacral spinal nerves. Intervertebral disc nucleus pulposus herniates posterolaterally through the annulus fibrous outer ring into spinal canal due to thin posterior longitudinal ligaments. So you have thin posterior longitudinal ligament and thicker anterior longitudinal ligament. Okay, so the anterior ones are thicker along midline of the vertebral bodies. Nerve affected is usually below the level of herniation. Okay, so if it's L3 and L4, it's the L4 nerve that gets affected. Okay. Why? Because we read before somewhere, or not, I don't know. Uh, until like C7, the nerves correspond to the vertebral bodies uh, above. So like if it's between C4 and C5, then between that it's gonna be C4. Sorry, C5 on top, right? But after C7 and before T1, or C8 and before T1, I don't remember how many. I think C7 is the last one, right? So after that, you get it corresponds to the one above. So below C1, C7 you have C7, and then below uh, nerve. Sorry, and below T1 you'll have T1 nerve. Below T4 you'll have T4 nerve, right? And below L4 you'll have L4 nerve, right? Below L5 you have L5 nerve, like that. That's what they mean. Nerve affected is usually below the level of herniation. Uh, you'll have a positive straight leg sign. Okay, so when you try to do that, it's gonna hurt. When you try to pull the leg forward and straighten it out, so they won't be able to do that. Sort of like sciatic nerve pain, right? Uh, then you have contralateral straight leg raise, reverse straight leg raise. So everything is gonna elicit pain, no matter which way you move the leg. Okay, disc level herniation at L3 and L4, and L4 gets affected. It's this part that gets weakness of knee extension and decrease in patellar reflex. So dermatome affected over here. Then you have L4 to L5. L5 is over here, gonna affect this dermatome. Weakness of dorsiflexion. Difficulty in heel walking. Alright, so you won't be able to pull this one, the toes upwards, right? And this downwards, so you won't be able to do that. Problem over here, you won't be able to do patellar reflex. And then you have L5 and S1. S1 goes from here to here. This is important because only S1 goes over here, and like out of all the sacral nerves, S1 only shows up here, and then there's S2 as well that I think does the anal sphincter winking and the front as well. We'll do the dermatomes I think in CNS, so it'll come up there. If you don't want to bother memorizing here, it's fine. Actually, you should, because This is not what they won't go into details over there with this. Okay. So when you have S1, the weakness of plantar flexion, right? So plant is you're planting the foot down. Flexion is that. Uh, so dorsal, or is the dorsum of the foot is on top of the foot, and plantar aspect of the foot is the bottom of the foot, because you plant your feet down, right? So weakness of the plantar flexion, difficulty in toe walking, uh, decrease in Achilles reflex, right? So uh, L4 to S3, L4 to S3, they all both get affected. So you might see overlapping of symptoms here because of that. Okay, over here you see L4. I don't think this is that important, but just so you understand, after L5 and between S1, this protrusion, if this gets affected, it's going to be the S1 that gets affected. If it's the protrusion is, or this herniation is between L4 and 5, it's the L5 that gets affected. Okay. Uh, Neurovascular pairing. Nerve and arteries are frequently named together by the bones regions with which they are associated. Okay. Nerves and arteries are frequently named together by the bones and regions with which they are associated. The following are exceptions to this naming convention. Okay, so location, nerve, and artery. So location, axilla and lateral thorax. You have long thoracic nerve, and the artery going along with it is lateral thoracic. Around the surgical neck of humerus, you have axillary nerve going, and the artery is called posterior circumflex artery. Mid shaft of the humerus has the nerve, radial nerve, and the artery that goes from there is deep brachial. This is an important one. That one you need to remember. The radial and deep brachial. Okay. So deep brachial goes from along with the radial nerve. Then so they'll be like, okay, so you can't do this because of this nerve, right? So they'll give you symptoms of radial nerve injury, and then they'll ask you, what else is a problem? What could another structure that could have gone damaged or something like that? So it's going to be deep brachial artery. Distal humerus cuboidal fossa. Okay, that's front of your elbow. Median nerve goes from there, and the artery that goes from there is brachial artery. Popliteal fossa is tibial nerve, that's back of your knee, and popliteal artery goes from there. Posterior to medial malleolus, that's tibial nerve, and posterior tibial artery. Okay. No, I haven't come across any questions for these except for this radial one, so that's the one I told you about. But they could ask any of these if they wanted to. But overall, they don't ask uh, hard anatomy questions. They ask you something you should already know. Okay, action potential. So motor neuron action potential to muscle contraction. This is really important concept. They test you on everything in here. Okay. T-tubules are extensions of plasma membrane in contact with the sarcoplasmic reticulum, allowing for coordinated contraction of strident muscles. Okay, so T-tubules are extension of plasma membrane. Okay, these are the T-tubules that they're talking about. Okay, in contact with the sarcoplasmic reticulum. This is the sarcoplasmic reticulum. Okay, allowing for coordinated contraction of strident muscles. Okay, so you have a muscle here. This is a whole muscle, and you have the nerve attachment to it. Okay, so what happens? You have myelin sheath here with the action potential coming in, right? Depolarization's happening. Uh, Calcium is coming in, right? Because why? Because potassium is going to go out. Axon, acetylcholine vesicles are releasing acetylcholine, and acetylcholine receptors are getting attached to acetylcholine, or acetylcholine is getting attached to the receptor. And this whole thing is called the motor end plate, right? Uh, and when this happens, it's gonna depolarize this. Okay, so action potential opens presynaptic voltage gated calcium channels, including acetylcholine release. Okay, so that causes that. Remember, snare protein attaches to this and attaches to the end of the nerve for to allow it to release acetylcholine. Not important here. It's just I'm trying to remind you of the snare protein that gets cleaved in tetany and botulinum. And tetany, it affects the acetylcholine, right? No, GABA, and then in botulinum, it affects the acetylcholine vesicles. Uh, Postsynaptic acetylcholine binding leads to muscle cell depolarization at the motor end plate. Okay, so postsynaptic acetylcholine binding leads to muscle cell depolarization at the motor end plate. So now this is action potential happening that's depolarizing this, right? Then depolarization travels across the entire muscle cell and deep into the muscle via T tubules. So it goes along the whole muscle and deep into the muscle through the T tubules. Okay, it's the one that go inwards. Okay, so and this whole thing is T tubule. This whole thing is T tubule. This is not a T tubule. Okay. Okay. So then you have membrane depolarization induces conformational change in the voltage-sensitive dihydropyridine receptor, or DHPR, and is mechanically coupled ryanodine receptor, or RR. Okay, so this is ryanodine receptor with the dihydropyridine receptor. They combine the two, right? DHPR and RR. They attach the two. So calcium then released from the sarcoplasmic reticulum. When this happens, uh, calcium gets released from the reticulum into the muscle fiber. So calcium released from the sarcoplasmic reticulum buffered by calciquitrin into the cytoplasm. Calciquitrin. I don't think I remember that. So after that happens, what's next? Okay, so now we have calcium in the cytoplasm, right? So now that the calcium has been released, number 5, we have tropomyosin, which is blocking myosin binding sites on the actin filament. Okay, let's have a few things. Actually, wait. Let me just make a few of these. Okay. Okay. So tropomyosin is blocking myosin binding sites. Okay. Okay. Let me make a few more. Okay, so this is going to be covering that up. Okay, let's try that again. So tropomyosin is blocking myosin binding sites, so those are these little dots. Okay, on the actin filament, that's the purple stuff. Okay, so the purple or maroon big circle is actin. Okay, and then this these sites are the myosin binding sites. It's where the myosin is going to attach, and tropomyosin is attached to it, covering it up. It's blocking those things. Okay. So released calcium binds to the troponin C. Okay, so tropomyosin has a receptor on top of it. Okay, so this is the receptor, and you have calcium coming in. Let's make that this color. Okay, so calcium comes in, attaches to this. So when that happens, this thing moves aside. Okay, so released calcium binds to the troponin C or TNC, shifting the tropomyosin to expose the myosin binding sites. Okay, so that's what's happening here. The calcium's coming in, it's binding to the TNC site on the tropomyosin. Okay, and then when that happens, the tropomyosin moves out of the way to expose these blue little dots. Right, the blue little dots are the myosin binding sites. Cool. These are actin. Okay, so that's all you need to know for now until the next step. Then what happens? Myosin wants to bind to the actin, right? At the actin, myosin binding sites on the actin. So myosin head binds strongly to actin. This is called the cross bridge. Okay. So the head of the myosin. Let's draw myosin. Let's make that. I don't know. Nope, that's not gonna make sense. Okay, so we have myosin like that. I don't know why it's like that. Actually, just me. It looks like a little sperm. This thing right here. Okay, that is attached to ADP and PI, right? ADP and low PI as well. ADP and PI. Cool. So this thing, after this moves aside, this thing comes in and attaches to this. Okay. When it attaches to this, what happens is, hold on. So I gotta do this. ADP and PI. Okay. So when this attaches to this, the ADP comes and PI actually gets released when the attachment happens, when the phosphate group gets released. Okay, so myosin head binds strongly to actin, PI is released, initiating power stroke. So when PI is released, uh, what happens is a power stroke. Okay, and this is the power stroke right here. So let's see what happened here. It attached, this is myosin, and this is called the cocked position. Okay, it's like cocking a gun. Okay, so after that, it's attached to this binding site. The cross bridge has happened. PI gets released. When PI gets released, there is a power stroke. Okay, and this power stroke is what causes the contraction. Okay, so during the power stroke, force is produced as myosin pulls on the thin filament. Okay, actin is a thin filament, myosin is a thick filament. Okay, so instead of thin, you can just read that as it pulls on the actin filament. Okay, this is the actin filament or the thin filament, and this is myosin or the thick filament, right? So there's a cross bridge happening over here, you know, all these places. Okay. So again, during the power stroke, force is produced as myosin pulls on the thin filament. Muscle shortening occurs when with the shortening of H and I bands and between Z lines or Z lines, right? Uh, so right here you have the Z line or Z line. Here you have the M line. H band and A band is here, and these are the I bands. Okay. So why is this important? It's because these areas are the ones that are going to change, and this area right here is not going to change. It's something like that. Hold on, let's see. So muscle shortening occurs with shortening of H and I bends. Okay. So H bend is right here. That gets shortened, so this is going to come closer this way. And these get shortened, so this is coming this way, okay. Between Z lines, okay. So hi, I'm wearing shorts. Okay. H, I, and Z, they get shortened. The A band remains the same length. Okay, so this length right here, the A band, that's the one that doesn't change in size. And they test you on that. Okay, the A band remains the same length. A band is always the same length. ADP is released at the end of the power stroke. So now that this has completely been done, okay, contracting, the ADP gets released, and ATP then gets attached to this again, and it becomes cocked again, reloaded. Okay, so let's see. Binding of the new ATP molecule causes detachment of myosin head from actin filament. Calcium is resequestered, right? So the calcium gets resequestered, as in it goes back out into the sarcoplasmic reticulum. Okay, ADP hydrolysis into ADP and PI results in myosin head returning to high energy position or cocked or reloaded. The myosin head can bind to a new site on actin to form a cross bridge if calcium remains available. Reuptake of calcium by sarcoendoplasmic reticulum or calcium ATPase, also known as SERCA, uh, and that causes muscle relaxation. Okay, very important. This is the important part that they usually test you on, but they will ask you about these things too somewhere. Okay, you should know that. Looking at this, you should be able to figure out which one is which filament. So these are the light ones or light chains or thin filaments or actin, right? So that's what these are called. The dark lines you're seeing is the Z line, right? It's because it's being attached to this, and that's why it's showing dark. It's showing it's a little dark there. The thin one is actin, and then the thick ones are the myosin ones. Okay, and a little line you're seeing in the middle is called the M line, and the white and the line both are called the H band, and the A band is right here. So then they'll ask you, okay, so they'll probably just label all these. So this is A, this is B, this is C, uh, this is D, and then they'll just ask you, okay, so during a contraction, one of a researcher noticed one of these things got changed. Which one of these things stay unchanged or something like that, and you should be able to figure out which one does. And so this one gets short, H, I, and Z, right? So that's H right here, I is this thing, and Z is this line. Okay, the line doesn't get short, does it? It does. Okay, so Z line gets short, H and I as well, and this one doesn't get short, the A band. Cool. Sarcomere is from a Z line to Z line. Okay. And yeah, done with that. How much time? 7. Okay. Type of skeletal muscle fibers. Muscle fiber type grouping commonly occurs due to reinnervation or denervated uh, muscle fibers in peripheral nerve damage. So you have type 1 and type 2. Okay. So type 1 skeletal muscle, its contraction velocity. Hold on, let me see if I have notes on this. Okay, so the notes I have is just, soleus and paraspinal. These ones are type 1, so the ones that uh, work your anti-gravity muscles or anti-gravity position. And then you have triceps and biceps, or pectoralis or pecs. Uh, those are type 2. So contraction velocity is slow for these ones. Okay. Fiber color is red. Predominant metabolism is oxidative phosphorylation. Sustained contraction. It leads to the sustained contraction. Mitochondria and myoglobin is increased in these type. Okay. Type of training, it's endurance training. Notes, I think I slowed red ox. Okay. So type 1 is slow. Fibers are red. Predominant metabolism is oxidative phosphorylation. Mitochondria and myoglobin is increased in these cells, and it's if you want to train it, it's called endurance training. That's when it's used up. Type 2 are fast. Contraction velocity is pretty fast with that. Fiber colors are white. Predominant metabolism happens through anaerobic glycolysis. Mitochondria and myoglobin is decreased in these. Okay. Type of training, weight and resistance training or sprinting. And think 2 fast white antelopes. Don't really need these to help you out, remember. Just remember looking at, type 2, too fast, too furious. So type 2 is fast. Paul Walker is white in it, right? Vin Diesel seems white as well. So white, you can be racist here, it's fine. Predominantly metabolism, anaerobic glycolysis. Okay. I don't know how you're gonna remember that, but just remember you don't need oxygen to do these. Okay. To create ATP, you can create this way, and that's why they get tired a lot, because you get a lot of lactic acid buildup right through anaerobic glycolysis. Maybe that will help you remember that. Type 2 is that. Also, type 2, everyone's beefed up. They have triceps and biceps and everything. So anaerobic for that. Mitochondria and myoglobin is reduced in that, and type of training. They all lift weights over there. That just leaves type 1. 1 is too slow, right? It's red. Oxidative phosphorylation. It's sustained contraction. Increase in mitochondria, and type of training is endurance. Okay. Normally in the question stem, they'll tell you that they dissected a muscle out of a animal, right? They dissected a muscle out of animal, and then they applied some signal or stimulated the muscle somehow, and what they saw was that they saw some kind of acidic buildup. So that would be lactic acid buildup, because it's type 2 muscle. So they'll ask you what type of muscle is it. So they'll name all the type 2 muscle. They'll name triceps or something, biceps or pecs, along with paraspinal, soleus, and like whatever the red muscle fibers are, right? And then you have to pick the one that you remember. Okay, this one is uh, the one that you would use for weightlifting and stuff. Okay, and similarly for this one as well, it would be paraspinal anti-gravity muscles. Uh, would be this one. Okay. Let's take a break here, and then we'll come back to this. On to skeletal muscle adaptation. Okay. Atrophy and hypertrophy. Remember, trophy, the bigger the size of the trophy, the better. So hypertrophy is the size, and atrophy is no size or no trophy. A is absence, right? So myofibrils, when there's atrophy, what happens to myofibrils? They decrease removal via ubiquitin proteasome system, and myonuclei, it decrease due to selective apoptosis. And hypertrophy, you have increase in myofibrils. Okay. Addition of sarcomeres in parallel. Okay. So myofibril is just that sarcomere, and sarcomere is this, right? Actin and myosin in parallel. So you add lines of that here, and that's how you get hypertrophy. Myonuclei, what happens to that? That also increases fusion of satellite cells, which repair damaged myofibrils absent in cardiac muscles. Vascular smooth muscle contraction and relaxation. Uh, we already know this, right? It's the same thing. CGMP. When you have CGMP, NO comes in, activates CGMP. CGMP then activates the myosin light chain phosphatase, right? Uh, so it takes away the, I guess, it takes away the P to cause relaxation, right? So it comes in with the phosphate group. So phosphatase A's cleaves the P out to relax the cause the relaxation, right? Okay. So that's myosin light chain phosphatase. For contraction, the calciums come in, make the calcium calmodulin complex, which then activates the myosin light chain kinase to add the protein phosphate group to it to cause the contraction. Okay. So calcium causes contraction, nitric oxide causes relaxation. Okay, and important to know, this is L-type voltage gated channel for calcium. Okay, depolarization, cool. Here you have agonists like acetylcholine or bradykinin coming in, activating the calcium. Calcium then activates the synthesis of NO from L-arginine to NO, right? And then you get NO diffusion into the smooth muscle cell, doing this whole thing. You need to remember this, how relaxation occurs and how contraction occurs. Muscle proprioceptor, specialized sensory receptors that relay information about muscle dynamics. Muscle stretch receptors and Golgi tendon. Okay, these are your reflex ones. Okay, over here, and this one is about other stuff. So we'll go through it and see if we understand it. Muscle stretch receptor pathway 1. It goes to 1A or 2 type 1 or 2 fibers from muscle spindles. Okay, so increase in length and speed of stretch will cause information to go through the dorsal root ganglion, right? So this is the dorsal root ganglion right here. Okay. Activation of inhibitory interneuron and alpha motor neurons. Okay, so the red ones are the inhibitory ones, I guess. Okay. a fiber to antagonist, and then there's the green one right here. Okay. This leads to simultaneous inhibition of antagonist muscles, prevents overstretching, and activation of agonist muscle, so contraction. Okay. So let's talk about, a biceps and triceps. When you're trying to lift a dumbbell or do a bicep curl, right? And then try to make it fancy. Okay. Let's give them a bicep curl. It's a dumbbell, and we'll make the dumbbell pink or purple, whatever. Okay. So he's pulling this way, right? So what's happening? These muscles are getting stretched, right? And these muscles are getting flexed or contracted, correct? Okay, so these muscles are gonna get inhibited by the red fibers, and this muscle is gonna get uh, agonist intervention, right, or signal. So what they're saying is that when these fibers send signals that it's trying to do this, uh, without going through to the brain, why these ones, the reflex itself is going to do this, so your brain does not interfere with this whole mechanism. Okay, so when there's increase in length and speed of stretch when you're lifting it up, and that you know how there's a contraction just by reflex, that's because of this. Via dorsal root ganglion, activation of inhibitory interneurons and alpha motor neurons. Okay, so that's why you don't break your arm, because there's inhibition of that. Okay, because triceps are getting stretched this way, right? So by reflex, they would try to go this way, stretch that way when they get contracted triceps, right? Because it's attached to uh, this thing right here, and it goes that way. So to prevent that, so you're able to, lift it this way and do your action. These get inhibited. Okay, that's all they're saying. And yeah, so increase in length and speed of stretch lead by via dorsal root ganglion, activation of inhibitory interneurons and alpha motor uh, neurons, simultaneous inhibition of antagonist muscles, preventing overstretching, and activation of agonist muscle, uh, causing contraction. So location innervation is body of muscle, type 1A and 2 sensory axons. Okay. Activated by increase in muscle stretch, responsible for deep tendon reflex. Okay, so yeah, so that reflex right there, this would be bicep brachii, I guess, but this thing doesn't make sense by itself. This is not what they're talking about. They're talking about reflex, but this is just so you understand what I was trying to say. Okay, let's get rid of that, and let's bring in biceps. Oh, sorry, deep tendon reflex. So when you have a hammer, right? So okay, and you strike it at the tendon right here, right? So what's happening? There's stretching happening, right, of the fiber, right? There's increase in length of this ligament, and speed of stretch is had there as well, right? So when that's happening, these are the agonist muscles, right? So they get contracted, right? So they're going to contract. That's why your muscle, uh, What's going on? This tendon is attached to this, right? So it's going to pull this way. So that's why your leg goes out and does a kick when you strike it with this over here, because there is increase in length and speed of stretch, right? And to avoid overstretching it, right, uh, you also inhibit the antagonist muscles. Okay. Okay, so increase in muscle stretch responsible for deep tendon reflexes. Cool. Let's see what Golgi tendon is. This is about the tension. Okay. Uh, okay. So increase in tension via dorsal root ganglion, activation of inhibitory interneurons, inhibition of agonist muscles, reduce tension uh, within muscle and tendon. So tendons. So I guess the example I gave before, it would go for this one. We can use that for here. Uh, Tendons, type 1B sensory fibers, that's where it goes. Increases muscle tension. It's activated by that Golgi tendon organ, okay? So you have increase in tension over here. So say you're trying to, I don't know, lift weight or something, right? You're doing a squat. Okay, so dude's coming in with knees like that, and he's like that, and then he's holding barbell, right? Barbell over there, and he's doing the squat. Okay. So that's going to increase the tension on the muscles, right? So muscles can only get contracted so much before, your ligament tears or you damage yourself, right? So prevent that damage, and not so that you don't go over the limit your body can handle. uh, there's this reflex or this mechanism that happens, and it's called the Golgi tendon organ. So increase in tension will then, through the dorsal root ganglion, this thing, activate inhibitory interneurons. Okay. So the so basically, if its biceps are the ones doing the curl, it's going to activate the triceps, like that. So whatever inhibitory neurons are for this, uh, that's going to get activated. So activation of inhibitory interneurons, okay, and inhibition of agonist muscles. So these muscles are going to get inhibited. So it reduces tension within the muscle and tendon that way. Okay. Uh, let's see if there's a better example of that somewhere. Okay. Sudden weight change causes muscle to extend, stretching the muscle spindle, right? So when you throw that stuff here. So muscle spindles trigger a reflex to maintain tension on the muscle. Okay, so as soon as you have that happening, it's gonna create this. So that's how that works. Okay, but which one is that? Okay. Actually, we don't need to bother. Just memorize it. Uh, for muscle stretch receptor, it's the increase in length and speed and stretch, right? Uh, they don't ask about this. What they ask about is this, the Golgi tendon organ. Okay, so Golgi tendon organ gets activated with increase in tension. What does it do? It activates the inhibitory interneurons and inhibits the agonist muscles. Okay, inhibits the interneurons and activates the inhibitory interneurons and inhibits the agonist muscle. This is what you need to remember. That's it. Uh, it's activated by increase in muscle tension, whereas this one, muscle Stretch receptor, it's this one, and they are both use dorsal root ganglion, and the brain does not interfere in this mechanism. Okay. uh, Bone formation, endochondral ossification, bones of axial skeleton, appendicular skeleton, and base of skull. Cartilaginous model of bone is first made by chondrocytes. Osteoclasts and osteoblasts later replaced with woven bone and then remodeled to lamellar bone. Okay. In adults, woven bone occurs after fractures, and in Paget disease. Uh, Defective in achondroplasia. Okay. So this is, I think, what Peter Dinklage has, right? Okay, so that's what achondroplasia features are. Those are macrocephaly, um, frontal posing, mid-face hypoplasia, uh, something trident hand. So that's just, these two fingers and these two fingers and this thumb. So that and genovarus. Okay, that's bowing off tibia. Again, so it's bone of axial skeleton, okay, appendicular skeleton, and basal skull. So these are the ones that get affected. Everything else is okay. So axial skeleton, you need to know what that is. That's just that, right? Uh, I guess it's this blue part. Okay. Axial skeleton is the blue, and the appendicular skeleton is the purple. Okay, so now we know that. So bones of the axial skeleton, appendicular skeleton, and base of skull. Okay. Cartilaginous model of bone is first made by chondrocytes. Okay. In normal human, this is what happens. Cartilaginous bone model of bone is first made by chondrocytes. Then the osteoclasts and osteoblasts, that's, the crushing bone and the building bone ones, later replaced with woven bone and then remodeled to lamellar bone. Okay. So in adults, woven bone occurs after fractures, okay, and in Paget's disease. This is important that you get that in there. We'll read about that too. Defective in achondroplasia. So this does not happen in achondroplasia. Okay, so you don't have chondrocytes, I guess. Membranous ossification, bones of calvarium, facial bones, and clavicle. Woven bone formed directly without cartilage, later remodeled to lamellar. Okay, so membranous ossification occurs in these areas. That's calvarium, facial bones, and clavicles. So these ones don't get affected in achondroplasia, right? The woven bone forms directly. It doesn't go from chondrocyte to woven bone. So you get woven bone right away uh, without the chondrocytes, and then they turn into lamellar bone, just like this one. Okay, so endochondral ossification has 3 steps. Membranous ossification has 2 steps. Okay. Cell biology of bone. You have osteoblasts, osteoclasts. Okay. This is really important. You understand which is which and all that. And okay. So in osteoblast, the way I remember it is that osteoblast has a L, right? And uh, rankle is part of that. Okay, so osteoblast has a L and that. We don't talk about this, so we ignore it. Just don't look at it. Okay, so builds bone by secreting collagen and catalyzing mineralization in alkaline environment via ALP. Differentiates from mesenchymal stem cells in periosteum. Periosteum, right? So it differentiates from mesenchymal stem cells in periosteum. Okay, everything here is important, so we'll go over it again. Osteoblastic activity measured by bone ALP, osteocalcin, and propeptides of type 1 collagen. Okay, so it builds bone, right? B for building bones by secreting collagen. That's how it does it. And catalyzing mineralization in alkaline environment through ALP. Okay, so yeah, mineralization is when it's building. Okay, demineralization is when it's crushing it. Okay, so it differentiates from mesenchymal stem cells in the periosteum. Uh, how do you measure it? You measure it through ALP and type 1 procollagen. Osteoclast, it dissolves or crushes bone by secreting H and collagenases. Okay. C for crush, right? So it breaks down the bone. Okay, so bone by secreting H, so it makes it acidic, right? Acidic. Um, so opposite of this, so the building of the bone stops in acidic environment. And collagenases, right? Because this one secretes collagen, so this one breaks down the collagen because it has A's in it, so it breaks down the collagen. Differentiates from a fusion of monocyte and macrophage lineage precursor. Okay, that's important. These ones come from the macrophages. So when you have this whole thing happening, this thing is gonna form from macrophages, and that's important because this one doesn't come from that. This one comes from mesenchymal stem cells, so that means this is always going to be there. Okay, uh, this has to convert from this for this to have any action. Rank receptors on osteoclasts are stimulated by the rank L or rank ligand expressed on osteoblasts. Uh, OPG, osteoprotegrin, a rank L decoy receptor, binds rank L to prevent rank L interaction. This reduces the class osteoclast activity, right? So let's do that. Let me just make a little bit of stuff here so we can talk about it. That's gonna be that. Okay, so yeah, I think that's it. Why can't I pick it up? Oh, it's because it's inside of this. That sucks. Okay, so what they're saying is that this, how does this happen, right? Activated osteoclast. It's when it gets this signal coming from osteoblast, going through the rank L for osteoblast, right? Going to rank, and then through that thing attachment, it goes in here, and then it causes differentiation into activated osteoclast. Okay, so normally what you have are is called osteoprotegrins, right? I'll draw that out. Let's make them this color. Uh, and this is my osteoprotegrin. So what this does is it blocks this, and it blocks this, right? So this thing cannot, you know, bind to this. So if this doesn't bind to this will not be able to go here because it gets stuck here. This thing is blocking it. Okay, so this signal is getting blocked now. So that's why you don't get any osteoclastic activity, and therefore you have decreased osteoclastic activity because of that. Important, very much. Um, the differentiation, this thing right here, I think it's NFKB that does that. Let me see if I can find it. Okay, right here. Okay, that's not gonna help us. Sure, that'll work. Okay, so you have hemopoietic stem cell, right? Uh, with the M colony stimulating factor and PU differentiating into osteoclast precursor, right? So this thing, the green thing that I was holding, is called the NFKB or necrosis factor KB, or I don't know what it stands for, but that right there. Okay. Uh, you have, yeah. So you have osteoblast right here. It says hemopoietic stem cell, but think of it like a macrophage, right? So multinuclear osteoclast right here, rank to rank L coming in. Okay. So when you have this, you will have low OPG, right? So these are OPGs, osteoprotegrins. Uh, that's the name of it, right? So when you have low of that and that to that ratio, you have increase in osteoclast formation and activity. Okay. So that's osteoblasts, bone marrow, stromal cell, osteocytes. Okay, and osteoprotegrin is attached to that. So that's this thing attaching to rank L. The purple thing is rank L. So it stops the attachment of rank to it. Differentiation. Now NFKB cannot come in here, right? So if it doesn't do that, that's because osteoprotegrin competitively binds to rank L and prevents its binding to rank. So in these situations, you have high OPG and rank L ratio. So you'll have decreased osteoclast formation and survival. Okay. Uh, they haven't said it here, but another thing that increases osteoclastic activity is interleukin 1, inflammatory cells, right? Interleukin 1 and corticosteroids as well, I think. Yeah. Okay, so corticosteroids and interleukin 1. Parathyroid hormones at low intermittent levels exerts anabolic effects, building bone on osteoblasts and osteoclasts indirectly. Okay. Chronically increase in PTH levels, that's primary hyperparathyroidism causing catabolic effects, osteitis, fibrosa cystica. That's the bones, thrones, stones, groans, and psychiatric overtones. Remember from uh, endo. Just quick. This thing: stones, thrones, bones, groans, and psychiatric overtones. Primary hyperparathyroidism. Okay. Back to this. Okay. So what it's saying, when this is low, at low or intermittent levels, it exerts anabolic effect. Okay. So if you have low PTH, that's gonna build bones. Okay. On osteoblasts and osteoclasts indirectly. However, when you have increase in PTH, what does that do? it wants more calcium in the serum, right? Where does the calcium come from? It comes from the largest storage of calcium in your body, the bones. So it's gonna increase in PTH levels will cause catabolic effects. So if it's in the bone, you need to, demineralize the bone to release the calcium. So it increases osteoclastic activity then. Okay. Uh, Estrogen, it inhibits apoptosis in bone forming osteoblasts and induces apoptosis in bone resorbing osteoclasts. Okay. Causes closure of epiphyseal plate during puberty. Estrogen deficiency, sorry, estrogen deficiency, surgical or postmenopausal, will increase cycles of remodeling and bone resorption. This increases risk of osteoporosis. Okay, so what does estrogen do? It inhibits apoptosis in bone forming osteoblasts and induces apoptosis of bone resorbing osteoclasts, right? So it builds bone and it decreases osteoclastic activity. Estrogen, that's what it's known for. Um, so after menopause, when estrogen reduces, that's why in older women there's an increased risk of osteopor- uh, osteoporosis. Uh, I think there was a study where doctors uh, prescribe synthetic estrogen or some kind of estrogen pills to women to reduce this risk, but it doesn't work. I don't remember uh, who did the study, but just something to know. Not something that will be tested on, obviously. Okay, so when you don't have estrogen, what's going to happen? This is going to reduce, right? And this is going to increase osteoclast, and that's why you have that. However, in a young person who's not hit puberty yet, uh, so like a girl who's like say 6 or 7 or 8 years old, she will look like a mature woman. She'll develop secondary sexual characteristics much quicker until puberty. Okay, so the question stem's gonna have a mother coming in with a concern about her daughter who's looking more womanly, right? And she's concerned because of that. So then the doctor's gonna say what? That even though right now, and also she's gonna be taller than other girls in her class, so it could be that, or it could be this. So it, yeah, I think I came across both types of question, and then she asked the doctor, why is this happening? So the doctor is gonna say that even though right now she's tall for her age, soon she's gonna stop growing, right? Why? Because what does estrogen do? It causes closure of epiphyseal plate during puberty, right? So once that happens, then she's gonna stop growing if there are high amounts of estrogen in her system. Okay, and yeah, estrogen deficiency, however, that's this. We already talked about that. Will cause increased risk of osteoporosis. Cool. On to pathology. Musculoskeletal skin and connective tissue pathology. Overuse injury of the elbow. Important. They'll give you either of these two, and then you have to figure out which one it is. So in medial epicondylitis, so if you pull out your hand and the middle part, in anatomical position, the middle part is, the ulnar side. Okay. So if you just, pretend to do a golf swing, uh, you'll see repeated flexion and or idiopathic will cause pain near the medial epicondyle. Okay. So when you're doing that, I don't know how to show that. Actually, I'll just show you this. So a swing like that is gonna hurt this right here, right? Or right there. I don't know. I don't play golf. But why is it showing me shopping? Oh, did I press shopping instead of images? Okay, there you go. Okay, so right there is where it's gonna hurt. So that part. Cool. Repetitive flexion or idiopathic pain near the medial epicondyle. So now that you remember that, you should know what the backhand shot looks like for this. Okay, so it's going from that to this. Okay. Wow, they're getting really technical with these images. But just imagine this person going from this position, that's Predator, number one tennis player, going to this position, right? So that's backhand shot. Okay. So repetitively, you're doing extension, right? Or idiopathic, it could be. So you'll have pain near the lateral epicondyle. That's the radial side, right? And that's called lateral epicondylitis. Okay. So now I'll ask you, what about a person who's playing baseball? Which one is he more prone of getting? Medial epicondylitis or lateral? We'll search it up. It's medial, right? Because it has a similar action as this. Cool. Clavicle fractures, common in children and as birth trauma, usually caused by a fall on outstretched hand or by direct trauma to the shoulder. Weakest point at the junction of middle and lateral thirds. Okay. So looks something like this, right? It's flat here. It's like that, and then it's like so that's the clavicle. You can convert to 1, 2, and third. Okay, there's the medial. There's the lateral clavicle. Okay, so common in children and as birth trauma, usually caused by a fall on outstretched hand. Okay, or by direct trauma to the shoulder. The weakest point at the junction of middle and lateral thirds. Okay. So middle and lateral. So it's between this. So it's this area right here. Okay. Fractures at the middle third segment are most common. Okay. So if this is third, the middle third is this one right here. A fracture is more common in this area. Right, because this one is attached to something and this one's attached to something, so right in the middle is where the fracture is more prone to happening because there's no support there. Okay, presents as shoulder drop, shortened clavicle. This is important to know why you get a shortened clavicle. It's due to lateral fragments is depressed due to the arm weight and medially rotated by arm adductors, right? For example, pectoralis major. For this, they might not give you this, they might give you other muscles, so you need to know the attachments. For a clavicle. Okay. Do this one. Okay, so this is the medial. Wait, which one's the medial side? Oh, they didn't give you the attachments here. Okay. This is the superior view and this is the inferior view. So in the superior view, this would be the medial one, and this is the lateral side. Lateral, medial. Okay, so from the top and from the bottom. So from the top, this is where the sternohyoid bone is. This is where sternocleidoid is. Wait, that's sternocleidoid. This is sternoclavicular and intraclavicular ligament. Pectoralis major, the one they are talking about, is right here in the front. And this is the deltoid right here. This is the trapezius. This is acromion clavicular ligament. This is the deltoid. If you're looking at it from the bottom up, so this is the front now. So deltoid here. Over here you have subclavius, trapezium, and trapezoid. Posterior sternohyoid. The important thing to know here is deltoid is attached to the front, and sternocleidomastoid is attached here, and trapezius is at the back. Okay, those ones are you should remember along with pectoralis major. Okay, so medial end, lateral end, trapezius at the back, deltoid in the front, sternocleidomastoid in the medial 1/3 on the back, and pectoralis major in the medial and the middle 1/3 of the anterior aspect of the pectoralis major. Clavicle. Okay. Conoclavicular ligament, pectoralis major in the front, deltoid in the front as well, but on the lateral side. Trapezium, subclavius. Cool. So, because then they will ask you, it's laterally, it's medially anterior position, the clavicle. So which one is responsible for that? So that would be this. Okay. If there's injury somewhere else in here, then it's going to be going backwards, and that's because of sternocleidomastoid, right? Or if this one is this side is forward, it's because of deltoid, and if it's backwards, it's because of trapezius. Okay, so they can ask you like that, and then you should know which muscles attached where. Wrist and hand injuries, Guyon canal syndrome. Was the ulnar one, right? Ulnar goes to the hypothenar as well. So compression of ulnar nerve at wrist, classically seen in cyclists due to pressure from handlebar. May also be seen with fracture, dislocation of the hook of Hammett. I drove bikes as well, so when I used to drive them, I would get this as well. It would hurt my medial aspect of my palm, and that would affect this area. And then I would get tingling sensation and numbness in ulnar nerve aspect of the hand. Okay, just side note. May also be seen with fracture, dislocation of the hook of Hammett. With the outstretched hand, you fall and it dislocates or fractures your hook of Hammett. Hook of Hammett is for this, lunate was for this, right? So carpal tunnel syndrome, entrapment of median nerve in the carpal tunnel between the transverse carpal ligament and carpal bones. It's important that you remember the name of this ligament. It was reticularis something, right? Where'd it go? Okay. So flexor retinaculum. So it's important that you remember this transverse carpal ligament name. It's flexor retinaculum. Okay. Okay. Yeah, so entrapment of median nerve in carpal tunnel between the transverse carpal ligament and carpal bones causes nerve compression, which causes paresthesia, pain, and numbness in distribution of median nerve. Thenar eminence atrophies, but sensation spared. Because palmar cutaneous branch enters hand external to carpal tunnel. Okay. because palmar cutaneous branch enters hand external to carpal tunnel. So even though it's atrophied, you'll still feel stuff there, right? You'll still have sensation. Why? Because the cutaneous branch is outside of the carpal tunnel. It's suggested by positive Tinel sign, that's percussion of wrist causing tingling, and Fallon maneuver. 90 degrees flexion of wrist causes tingling. Okay, so when you ask them to flex this, they'll feel tingling over there. So that's a positive Tinel sign or tingling sign. Associated with pregnancy due to edema, rheumatoid arthritis, hypothyroidism, diabetes, acromegaly, dialysis-related amyloidosis may be associated with repetitive use. Okay. Uh, it's usually associated with someone who's working at the computer and they have their hands on the keyboard for a long time, right? Because so it's seen in them as well. Metacarpal neck also associated with pregnancy. You should know that's because of the edema. Okay. Rheumatoid arthritis and all this is I don't think they'll give you that in the questions then. They'll just say this person has been working for a long time and have a desk job or something. Metacarpal neck fracture, also called the boxer's fracture, common fracture caused by a direct blow with a closed fist, for example from punching a wall. Most commonly seen in the fifth metacarpal, okay, right there in the pinky, and yeah, it's because of that. This is important, not over here, but it's when you're trying to differentiate between this and appendix. Okay, so you need to know where that is, because you have similar symptoms, signs and symptoms as an appendix with this. Okay, it's going to be the lower right quadrant pain, or left. Which one is it? Right. Okay. So it's basically under here, under this iliopsoas ligament or muscle, sorry. Okay, and so when you stretch this, it's gonna hurt. Collection of pus in iliopsoas compartment may spread from blood, hematogenous, or from adjacent structures. For example, vertebral osteomyelitis, tuberculous spondylitis, also called Pott's disease, right? That's tuberculosis of bone, and pyelonephritis, associated with Crohn's disease, diabetes, and immunocompromised states. Staphylococcus aureus, most commonly isolated, but may also occur secondary to tuberculosis. Okay. So it happens because of this most commonly, but you can also see it be because of tuberculosis. Differentiation features between the two vary a lot, so it's easy to identify which one's which. Findings are flank pain, fever, flank bulge, and inguinal mass, right? So all of these seem like appendicitis as well. However, you have positive psoas sign. This is hip extension, exacerbates lower abdominal pain. And that's how you differentiate between appendix and this. Appendicitis happens because of which bacteria? Do you guys remember? It's B. fragilis. That's the one. Okay. Lab leukocytosis, imaging, CT, MRI will show focal hypodense lesion without the muscle pain. Okay. Treatment is antibiotics based on culture, CT guided percutaneous drainage, PCD, or surgical drainage. Okay. So if you have a right lower quadrant pain, you have to differentiate between this iliopsoas abscess, appendix, ectopic pregnancy, right, or infected ovary, something like that, or even PID, maybe, I don't know. There was also the other one, Crohn's, right, uh, and gallstone stuck in the ileum compartment, in the ileocecal compartment or valve, right? So all of these things you gotta figure out which one is which. At least between this one, if you do this, it pains more. So they'll be in fetal position, I guess. Okay. Uh, Common knee conditions. Uh, we should be good with this one. 5 minutes. I think we can finish. Unhappy triad. Common injury in contact sports due to lateral force impacting the knee when foot is planted on the ground, right? So it's planted, and then valgus. So valgus is L for lateral force coming in. Okay, so if lateral force coming in, then you're gonna get damage of MCL, right? And this one also consists of this, because lamp. So lateral lateral to anterior, right? So lateral to anterior, so it's this one coming in from the lateral to anterior. That's anterior cruciate ligament, and the medial cruciate ligament. I was gonna get that. Okay, and medial meniscus as well, attached to the medial cruciate ligament. However, lateral meniscus involvement is more common than the medial meniscus involvement in conjunction with ACL and MCL injury. Okay, presents with acute pain and signs of joint instability. Uh, Went over that pretty good. Should be good. Prepatellar bursitis. This is inflammation of the prepatellar bursa in front of the kneecap. Right, so it's right there. In front of the kneecap. Can be caused by repeated trauma and pressure from excessive kneeling, also called a housemaid's knee. Okay, so that's the patella. The bursa in front of it is called this. Okay, then there's another one that's also that happens on top, or it's called suprapatellar. I'll talk about that later, I think, or not. Okay, I'll tell you about that after the break. Popliteal cyst, also called Baker cyst. This is popliteal fluid collection over here in gastrocnemius semimembranosus bursa, commonly communicating with the synovial space and related to chronic joint disease, for example, osteoarthritis and rheumatoid arthritis. Okay, so right there. So it's associated with this. But if you have a cyst there, it's called the Baker cyst. Okay, it's gonna be associated, or collection is in the gastrocnemius semimembranous bursa. Okay, communicates with the synovial space. This is in front. This is called housemaid knee and prepatellar bursitis. Okay, so here we have patella femoral. This is ACL right here. That's destroyed. Right. That's LA. So lateral femoral condyle to you see a fibula here. So this is the lateral side. So that to the anterior side of the tibia. So that one right there. There's a tear right there. So that's ACL. This is the prepatellar bursa or bursitis. Okay, and this is the condyle. Uh, you gotta figure out which one's medial and lateral. So this is lateral, this is medial. Why? Because it says it right there. And popliteal arteries right there, and this is the popliteal cyst right there. Okay, so just before the break, I was talking about the suprapatellar. So I'll show you that. So that's where it is, the suprapatellar bursa, right? And this is where the prepatellar bursa is. So this is the housemaid knee. Over here, you get a cyst due to running or blowing the back of the knee. Okay, so that's how you end up with a cyst over here, right? See how it's attached to all the way here. So the collection can happen there. Okay, this is the quadriceps femoris tendon over here. This is the patellar ligament. This is deep infrapatellar bursa and subcutaneous infrapatellar bursa over there. That's it. Okay. Uh, Common musculoskeletal conditions. Costochondritis, inflammation of costochondral or costosternal junctions, may be due to minor trauma. Presents with pleuritic chest pain and focal tenderness to palpation. Most common in younger female patients, may mimic myocardial infarction, pleuritis, or pulmonary embolism. Treatment is uh, analgesics and stretching therapy. So for this one, the question is going to be like, this guy is coming in with chest pain, and you do an ECG, it's clear. You, the guy, you tell him to sit a little forward and backward, it still hurts. So it's not a, pericarditis. So that means it's gonna be something above the heart. It's not heart related. So above the heart you have is costochondral stuff. So inflammation of costochondral or costosternal junction. Okay, and that's how you figure out is costochondritis. Okay, it seems like a pleuritic chest pain and focal tenderness to palpation, most common in younger female patients. It looks like it's myocardial infarction or pleuritis or pulmonary embolism, but everything is normal. You'll have bilateral, equally, breath sounds, uh, and no ECG abnormalities and all that. Treatment is analgesics and stretching therapy. Decurvain tenosynovitis. This is the pain in thumb textures, right? Tenosynovitis. So remember we talked about the reticulum. What was it? Inferior. I keep forgetting. Flexor, because you flex the wrist. Okay, flexor retinaculum. This one is extensor retinaculum. Okay. This is extensor pollicis brevis, the one that goes to the thumb. Abductor pollicis longus, and inflamed tendon sheath. Okay. So decurvain tenosynovitis. This is non-inflammatory thickening of abductor pollicis longus and extensor pollicis brevis. These two. Okay. The one that extends the thumb and the one that abducts the thumb. Pain or tenderness at radial styloid. That's where it is. Positive for Finkelstein test. This is pain at the radial styloid with active or passive stretch of the thumb tendon. Increased risk in new mothers because they're lifting the baby from that, or in golfers, or in racket sport players, right? Because in both of these you're holding the stick with the thumb, putting a lot of pressure on the thumb, and even thumb texters, especially the people on game on phones, right? So it hurts right there. And the vein is for pain, right? We learned that in endo when we were doing thyroiditis. Dupuytren contracture. Uh, this is a pretty cool one. I'll show you a photo of that. This tendon right here, or that tendon right there, right? So this is called, this is due to calcification of this tendon causing contracture. So it's caused by fibroblastic proliferation and thickening of superficial palmar fascia. Okay, that's what it is, not calcification, but fibroblastic proliferation and thickening of superficial palmar fascia. Typically involves the fascia at the base of the ring and little finger. So this is the ring finger, right? So over there. Unknown etiology, most frequently seen in males more than 50-year-old of Northern European descent. Okay. Ganglion cyst. This is fluid-filled swelling overlying joint or tendon sheath, most commonly at dorsal side of wrist. Arises from herniation of dense connective tissue, usually resolves spontaneously. Okay. Uh, they ask you about this, they're gonna be like, the person had a cyst before and then like that. That's usually where it is. Okay. It was fluid filled. They will explain that, right? And they'll tell you where it was. If they tell you it's on the dorsal side of wrist, it's gonna be this or lipoma, but it's usually this that they're testing you on. Uh, Fluid filled swelling, overlying joint or tendon sheath, most commonly at the dorsal side of the wrist. Arises from herniation of dense connective tissue. This is the pathogenesis of that. Okay, so remember that. It's due to the herniation of dense connective tissue. Usually resolves spontaneously. So it will resolve by itself after a few days. Iliotibial tibial bend. This was coming from tensor fascia lata attaching to the tibia, right? Uh, Tensor fascia lata, iliotibial bend, and over here. So right here, this is the area where it pains. So overuse injury of lateral knee that occurs primarily in runners. Pain develops secondary to friction of iliotibial bend against lateral femoral epicondyle. So when they're running, this thing keeps getting rubbed against the bone, and that causes this pain, and it's called the iliotibial band syndrome. Sorry. Limb compartment syndrome. This is increase in pressure within fascial compartment of or facial compartment of limb. There's venous outflow obstruction and arteriolar collapse. This leads to anorexia, necrosis, and rhabdomyolysis. Acute tubular necrosis. Causes include significant long bone fractures, for example, tibia, reperfusion injury, animal venoms. It presents with severe pain and tense swollen compartments with passive stretch of muscles in the affected compartment. Okay, increased serum creatinine kinase and motor deficits are late signs of irreversible muscle and nerve damage. So for this, uh, didn't tell you about it. So there are two compartments, well three, but mostly it's two anterior and posterior compartments of thigh. Okay. So this is the anterior compartment, and this is the deep or posterior compartment that usually that they talk about because the vessels go from here. There's also superficial posterior compartment and lateral compartment as well. And this would be your bone, the tibial bone, and this is your fibular bone. Okay, so that's what they're talking about. Okay, swollen muscle compresses blood vessels and nerves in the leg, right? So here and here. Uh, so leg swollen, tight, pale, and shiny compartment syndrome. Okay, so again, increase in pressure within the fascial compartment of limb. So it could be any of these compartments that will block the venous outflow, right, and arterial collapse. This leads to anoxia, or you know, absence of oxygen, or ischemia, uh, necrosis, and then rhabdomyolysis. So you'll have increase in CK. because of this. Acute tubular necrosis, it leads to that. Okay. Causes include significant long bone fracture, like tibia, or reperfusion injury, or animal venom. Presents with severe pain and tense, swollen compartment with passive stretch of the muscle in the affected compartment. Increased serum, creatine kinase, and motor deficits are late signs of irreversible muscle and nerve damage. Pain, pallor, paresthesia, and pulselessness or paralysis. Okay. Medial tibial. So they'll just tell you that this person had increased swelling yesterday, and then today he has pain, pallor, and pulselessness in his foot. Right. So it's because of this. If they don't tell you there was swelling, it was something else. It's usually DVT then. And in DVT, they tell you that there's pain in the calves. Okay, medial tibial stress syndrome, also called the shin splints. Right, so that's in front of your leg in the tibia. Common cause of shin pain and diffuse tenderness in runners and military recruits. It's caused by bone resorption, that outpaces bone formation in tibial cortex. Okay. So it's getting reabsorbed much faster than there's bone formation happening. Okay, and that's why you get this shin splints. So slow it down, rest until this catches up. Plantar fasciitis. For this, you need to know the anatomy for the foot. Okay, so this thing right here, that's where it is. Area of micro tears. Okay. Inflammation of plantar aponeurosis, characterized by heel pain. Worse with first steps in the morning or after periods of inactivity. And tenderness, associated with obesity, prolonged standing or jumping, for example, dancers or runners, and flat feet. Heel spurs often coexist. Okay, that's you know little calcification or bony. It looks like a bone extending, right? So that's what it is. This is a ligament right there, and yeah, that's a heel spur, plantar fasciitis, and that. Cool. Then you have temporomandibular disorder, group of disorders that involve the temporomandibular joint and muscles of mastication, multifactorial etiology associated with TMJ trauma, poor head and neck posture, abnormal trigeminal nerve pain processing. Psychological factors presents with dull, constant unilateral facial pain that worsens with jaw movement, otalgia, headache, TMJ dysfunction, for example, limited range of motion. In this, they just tell you that the person, it hurts on one side of the jaw when they're eating or chewing food, and it's going to be this. Okay. Uh, and yeah, they test you on this right here, trigeminal nerve pain processing. That's it. Pretty straightforward. Child musculoskeletal conditions. Uh, so radial subluxation. Okay, subluxation. So this is, you know, when a person picks up a child with like that, right? The chances are that this radius is gonna get slipped out of its connection or its thing, right? Like that. From this angular ligament, it's gonna slip out, and that's when you get radial head subluxation. Okay. It's also called the nursemaid's elbow. Common elbow injury in children less than 5 years, caused by sudden pull on the arm, leads to immature annular ligament, slips over head and radius. Injured arm held in slightly flexed or pronated position. Okay, so after it's injured, when you put it down, it's going to be slightly flexed and pronated position. Okay, why does it happen? It's because of immature annular ligaments slipping over the head of radius. Okay, so this thing slipped. Osgood-Schlatter disease. I remembered like shatter, right? Also called traction epophytis. Overuse injury caused by repetitive strain and chronic avulsion of the secondary ossification center of proximal tibial tubercle. So right there. Occurs in adolescence after growth spurt. Common in running and jumping athletes. Presents with progressive anterior knee pain. So yeah, that's basically what that is. See if there's any. Sometimes it gets detached and you see a little bit of bone in the x-ray split from it too. So like that, uh, right? It's broken off from here. You can see it over there, and that's usually the x-ray type of x-ray they'll show you, so you can figure it out. So see how it's shattered bone, fragment of the tibial tuberosity. Okay. And yeah. So also called traction epophysitis. Uh, just remember traction and you'll figure it out from there. Overuse injury because of running and jumping, and yeah, that's it. Where does it attach? It attaches to the tibial tuberosity. So if it deattaches, that's called Osgood-Schlatter disease. Patellofemoral syndrome. This is patellar. This is femoral. So overuse injury that commonly presents in young female athletes as anterior knee pain. It's exacerbated by prolonged sitting or weight bearing on a flexed knee. Okay, it's when you're doing a squat, right? That's when it hurts. Okay. Development dysplasia of the hip, abnormal acetabulum development in newborns. Risk factor is breech presentation, results in hip instability and dislocation, commonly tested with Ortolini and Barlow maneuvers. This is when you're manipulating the hip and it reveals a clunk sound, right? So let's see if that's in here. Okay, so okay, Barlow, he did it again. Call Dr. O. Okay, so this doctor is back in. Okay, so examiner adducts the hip while applying the posterior uh, force on the knee to promote dislocation. So they promote dislocation by doing that, and then when they pull it back out, it goes back in. So examiner abducts the hip, while applying anterior force on the femur to reduce the hip joint. Okay, so inwards downwards or upwards outwards. Okay, confirmed via ultrasound. X-ray not used until 4 to 6 months because cartilage is not ossified. Then you have leg calf Perthes. Uh, this is an important one. It's idiopathic avascular necrosis of femoral head. Okay, it commonly presents between 5 to 7 years with insidious onset of hip pain that may cause child to limp. More common in males, 4:1 ratio. Initial X-ray often normal. Okay. Insidious onset of hip pain that may cause child to limp. So they'll go into details later for this one. Uh, Slipped. Also, there was another place where we came across this Eva necrosis of femoral head. It was in one of the storage diseases. Let me just look at that. Gauchers, that's the one. It was in Gauchers. Cool. Okay. Then slipped capital femoral epiphysis classically presents in an obese young adolescent with hip, knee pain, and altered gait. Increased axial force on femoral head. So this will cause epiphysis displaced relative to femoral neck. It looks like a scoop of ice cream slipping off a cone. Okay, and that's actually what it looks like, even an X-ray. And they'll give you an X-ray and they'll ask you what's happening. Okay, so you see how that thing is getting slipped off, right? But it's actually this thing going upwards. So due to the breakage over there, it looks like the ice cream cone is getting slipped off from the cone. Okay, this is fine. The fracture is over here for this one. So this one slipped off. You can see the breakage over there. Um, and they put in the nails to fix it. So a stable one is like that, and an unstable one would be like that. Okay. So slipped capital femoral epiphysis. Okay, it classically presents in obese young adults or adolescents with hip or knee pain and altered gait. Increased axial force. That's axial force is up and down. Will cause epiphysis to displace relative to the femoral neck. It's diagnosed through via X-ray. Common pediatric fractures. That's green stick fracture, incomplete fracture extending partway through width of bone, following bending stress. Bone fills on tension side, compression side intact compared to torus fracture. Bone is bent like a twig. Okay, so that's what the green stick fracture is. Okay, incomplete fracture extending partway through the width of the bone, following the bending stress. Bone fails on the tension side. Okay, so that's the tension side, so it's failed over there. Compression side intact. So this is the compression side, so that's intact. Compared to the torus fracture, we'll learn about that one. Bone is bent like a green twig. Okay, so if you were to bend it like that, let's see if there's photo. Okay, so that's a green twig fracture, or green stick, sorry, fracture. Torus or buccal fracture. Axial force applied to immature bone, cortex buckles on compression, concave side, and fractures. So right there. Tension is convex. So now it's over here. Wait, tension is convex. Okay. And tension side remains solid. Okay, so this is tension side. Okay, so that. See if there's one for that. Okay. So it's popping out convex is tension, then that's torus fracture. And then if the tension side breaks, then it's green stick fracture. Okay. Achondroplasia, that's failure of longitudinal bone growth, endochondral ossification causing short limbs. Membranous ossification is not affected, so large head relative to limbs. Remember, it was skeletal, axial, and appendiceal skeleton, and the base of the skull. And those are the only ones that are affected. The other ones are not, so you get normal head compared to the body. Constitutive activation of fibroblast growth factor receptors (FGFR3) actually inhibits chondrocyte proliferation. More than 85% of mutations occur sporadically, autosomal dominant with full penetrance. Okay, homozygosity is lethal. It's associated with increase in paternal age, most common cause of short-limbed dwarfism. Osteoporosis. Uh, this is important, how it's made or how it happens. So trabecular or spongy and cortical bone loss mass despite normal bone mineralization and lab values. So you have normal serum and phosphate values, most commonly due to increase in bone resorption, that is increase in osteoclast number and activity, uh, related to the decrease in estrogen levels and old age, can be secondary to drugs, for example, steroids, alcohol, anticonvulsants, anticoagulants, thyroid replacement therapy, or other conditions, for example, hyperparathyroidism, hypothyroidism, multiple myeloma, malabsorption syndrome, and anorexia. Diagnosed by bone mineral density measurement by DEXA, dual energy X-ray absorptiometry, at the lumbar spine, total hip and femoral neck, with a T-score of this, by a fragility fracture, for example, fall from standing height, minimal trauma at a hip or vertebra. None of this is important. What is that even with a low fall, they're gonna break the bone. It's because of osteoporosis. What happens in osteoporosis is important. So this thing right here, the first paragraph. Okay, on-time screening recommended in females more than 65 years old. Prophylaxis is regular weight-bearing exercise and adequate calcium and vitamin D intake throughout adulthood. Treatment is bisphosphonates, teriparatide, SERMs, rarely calcitonin, denosumab, a monoclonal antibody against Rankel to stop the osteoclastic activity. Okay, that's denosumab. Okay. It can lead to vertebral compression fractures. It's acute, causing acute back pain, loss of height, kyphosis. Also can present with fractures of femoral neck and distal radius. It's called a Colles fracture. Okay, quickly what that looks like. So that's what that looks like, or right there. Cool. So this is a normal intervertebral disc, normal intervertebral foramen, and then you have vertebral compression fracture. So then, because of osteoporosis, this goes in, restricted intervertebral foramen, and if you have enough of that, you'll have kyphosis, right? Then there's also something called osteopetrosis. This is hardening. Instead of osteoclast, this is hardening. So failure of normal bone resorption due to defective osteoclasts. So you'll have thickened, dense bone that are prone to fracture. Okay. Mutations, for example, carbonic anhydrase 2, impair ability of osteoclasts to generate acidic environment. Okay. Because remember, this is the one that converts H2O and carbon dioxide and combines the H with H bicarbonate. Sorry, H. It makes H2HCO3, right? And that was carbonic anhydrase. So this one, I guess, would split the other stuff to make H plus HCO3. So it can't do that anymore. And in fact, if you can't have hydrogen ions, you can't have acidic environment. So if you don't have acidic environment, you won't have the osteoblastic activity because it requires alkaline, right? Through the ALP that it uses. Okay, so wait, I said that opposite. Sorry, if you don't have acidic environment, you don't have osteoclastic activity, right? Because then you end up with alkaline, and osteoblast functions in alkaline environment. Yeah. Okay. It leads to pancytopenia, extramedullary hematopoiesis. It can result in cranial nerve impingement and palsies due to narrowed foramina. X-rays show diffuse symmetric sclerosis, bone and bone, stone bone. Bone marrow transplant is potentially curative as osteoclasts are derived from monocytes. Okay. This is what it will look like. That's what they'll show you in the X-ray for osteoporosis. Okay, let's look at that. And they'll say it's very fragile. Yeah, they fell and they broke the hip bone or something like that. And when they did the X-ray, it looks like this. Okay. What is this? Healthy infantile osteoporosis. Okay. But yeah, it's gonna be shining, right? Because almost all the light gets reflected, or X-rays. Osteomalacia and rickets. This is defective mineralization of osteoid osteomalacia and cartilaginous growth plates. Rickets only in children. That's what it's called in children, and it's osteomalacia in adults, or yes, most commonly due to vitamin D deficiency. X-rays show osteopenia and pseudofractures in osteomalacia. Epiphyseal winding and metaphyseal cupping and fraying in rickets. Children with rickets have pathologic bow leg genu bead-like osteochondral junctions, ricketic rosary, or craniotibus, soft skull. Okay. Uh, since this is an easy topic, they don't usually ask you about this or test you on it. But if they do, just remember this whole thing right here. So decrease in vitamin D and decrease in serum calcium will increase PTH secretion, right? Why? Because vitamin D does what? It reabsorbs calcium and phosphorus from intestine and reabsorbs calcium from the renals, while phosphate just leaks out because of PTH, right? So increase in PTH does what? It increases serum calcium. How? It takes it from the largest storage of calcium in your body, which is bones, So when it does that, and it thrashes, it's phosphate thrashing hormone, right? So it decreases serum phosphate. So when it does that, it causes this to happen: defective mineralization of osteoid or cartilaginous growth plates. Okay, so hyperactivity of osteoblasts will lead to ALP because it requires alkaline anyways. So that's how it is going to stimulate the alkaline environment. So you'll see that in serum, increase in ALP. Osteitis deformans. This is also called the Paget disease of bone. Common localized disorder of bone remodeling caused by increase in osteoclastic activity, followed by increase in osteoblastic activity that forms poor quality bone. Serum calcium, phosphorus, and PTH levels are normal here, and that's an important point to note. There is, however, increase in ALP, right? Why? Because of this, right? So there are three stages actually to this. Early stage is known for the osteoclast activity, and then intermediate stage is known for the osteoclastic and osteoblastic activity, and late stage is osteoblastic. When they give you in a question stem, it could be any one of these, so don't just go on ALP, so it's this, but it's losing this something, so it's not osteoblast, it's osteoclast. It's not. If it's increase in ALP, it's going to be osteoblast, right? uh, Mosaic pattern of woven and lamellar bone. This is important. It's osteocytes within lacunae in chaotic juxtapositions. Long bone chalk stick fracture, increase in blood flow from increase in atriovenous shunts, may cause high output heart failure, increased risk of osteosarcoma. Uh, Head size can be increased due to skull thickening. Remember, this is also, head size or glove size was for acromegaly or gigantism, one of the other, right? Increase in growth hormone. But it can also be used for this as a buzzword. So head size can be increased due to skull thickening. Hearing loss is common due to skull deformity. Stages of Paget disease is early destruction or lytic phase, which is osteoclasts. Uh, then intermediate or mixed, which is osteoclast plus osteoblast, and late, which is sclerotic or blastic, which is because of osteoblasts. It may enter quiescent phase. Treatment is bisphosphonate. Right, these are your dronates. Avascular necrosis of bone. So this is the one with the leg calves perthes one. The avascular necrosis of head of the femur. Infraction of bone and marrow, usually very painful. Most common site is femoral head, watershed zone. Right? Why is it watershed? Because it's supplied by the terminal branches of two different arteries, and both of them are half-assing the supply, right? So there's the watershed. This branches from the obturator artery. This branches from the circumflex artery. So medial one goes to the back, and the lateral one goes to the front. Okay, it's important because they'll ask you about this, and then they'll give you both of these, and then they'll test you on it. Infraction of bone and marrow, usually very painful. Most common site is femoral head, watershed zone. It's due to insufficiency of medial circumflex femoral artery. Causes include glucocorticoids, chronic alcohol overuse, sickle cell disease, trauma, SLE, the bends, casion decompression disease, leg calves perthes disease, and Gaucher disease, and slipped capital femoral epiphysis. Okay, I looked that one up, so now it should be cemented in our heads. Slipped capital femoral epiphysis. Cool. Circumflex artery over here, obturator branch over there. Lab values and bone disorder. Okay, So let's try to do it the way we usually do it without looking. Don't look. So we remember it this way, right? Okay, so osteoporosis, what's happening to serum calcium? It's gonna increase? No, stays the same. Phosphate stays the same. ALP, it's gonna decrease, or yeah, no, stays the same. PTH is gonna do what? Stay the same? Okay. So everything stays the same in osteoporosis. Decrease in bone mass. Okay. So it's natural, right? Because of estrogen, there's inhibition of disinhibition of osteoclasts, and yeah, and it kind of reduces the osteoblastic activity, right? Okay, osteoporosis. What happens to serum? We know everything stays the same for this. They said, or decreases. Did they say? Oh wait, no, they said that for this. Okay, I think I got the two confused. Okay, I was thinking of this one. Adults. Okay, let's go. So osteoporosis, this decreases. Phosphate decreases or stays the same. ALP is going to increase. Okay, stays the same. Then this is going to stay the same as well. Okay, so you have dense brittle bones, calcium decrease in severe malignant disease. In Paget's, what happens? It stays the same. Phosphate stays the same. ALP stays the same. No, increases. Okay, so okay, and PTH stays the same. Abnormal mosaic bone architecture. So osteitis deformans, or this, right? Over here, ALP is the only thing that increases. Okay. Osteitis fibrosa cystica, primary hyperparathyroidism, calcium increases, phosphate decreases, ALP, what's gonna happen? Decreases, increases, okay. Um, okay. PTH increases. Sorry. Brown tumors due to fibrous replacement of bone, subperiosteal thinning, idiopathic or parathyroid hyperplasia, adenoma, carcinoma. Okay. Secondary hyperparathyroidism, that's because of increase in calcium. No, decrease in calcium, right? Uh, what's going to happen to phosphate? It's going to increase. What's going to happen to ALP? It's going to increase, and PTH increases. It's often as compensation for chronic kidney disease, decrease in phosphate excretion, and production of activated vitamin D. Uh, Let me read this one again. Brown tumors due to fibrous replacement of bone, subperiosteal thinning. Okay. And often compensated for this. Okay. Osteomalacia and rickets. That happens due to decrease in vitamin D. So you have decrease in calcium, decrease in phosphate. ALP stays the same or increases. Okay. ALP increases, right? And PTH, I guess, increases, right? Soft bones vitamin D deficiency also causes secondary hyperparathyroidism. Hypervitaminosis D, increase in that, increase in that, decrease in this, or no change. Okay. And PTH decrease. caused by oversupplementation of or granulomatous disease like sarcoidosis. Remember, the macrophages have 1 alpha hydroxylase activity, converts calcidiol to calcitriol, activated vitamin D. Okay, one more time. Osteoporosis, everything stays the same, decrease in bone mass. Osteopetrosis, calcium might decrease, but almost everything stays the same as well. In Paget's, only the ALP increases. Osteofibrosis or primary hyperparathyroidism, that's bones, groans, thrones with psychiatric overtones, that one, right? So that happens because of increase in PTH. So you get stones because of calcium, right? So that's going to increase. PTH is going to increase, so that's going to increase that. It's going to thrash the phosphate and increase in ALP. Secondary hyperparathyroidism, that's due to decrease in calcium because of compensation for CKD. So decrease in phosphate excretion, right? So when you have decreased excretion of phosphate, you have increase in PTH, right? And that's going to cause... Okay, never mind. So here they said compensate for this, so decrease in excretion and production of activated this. Anyways, osteomalacia, vitamin D, that's easy, Okay. Primary bone tumors, metastatic disease is more common than primary bone tumors. Benign bone tumors that start with O are, hold on. Okay. More common in boys. Okay. Let's bring this one up here. And let me check my notes if I have any notes on these. Okay, I do, but I can't read my notes. Okay, let's go through it. So first one is malignant tumor. Nope. First one is osteochondroma. Okay, so osteochondroma is where? Right there. So that's what it looks like. It's most common. So any bone tumor that starts with O are more common in boys. Okay, most common benign bone tumor, males, less than 25 years old. Location is metaphysis of long bones. Okay, this is the metaphysis right there. This is your epiphysis, metaphysis, and this would be your diaphysis. Okay. Characteristic is lateral bony projection of growth plane, continuous with marrow space. Okay, and it's covered by cartilaginous cap. Rarely transforms to chondrosarcoma. So that's A. This would be chondrosarcoma. Let's bring these up there too. Okay. So there are like two names for this. One is osteocomonoma because it's common, right? And another name for that is chondro is cartilage, right? So osteocartilage homa, I guess. I don't know. Okay, these are from Dirty. Again, Dirty Medicine. So yeah, because it's covered by cartilaginous cap, so they'll tell you that in the description in the questions tab, and you should get it from that it's an osteochondroma. Okay, so and this happens in metaphysis. Okay, so this a benign tumor and a malignant tumor. Only two things happen in metaphysis. One of them is osteochondroma, and another one is osteosarcoma, but that's a malignant one. Okay, then we're on to osteoma. Okay, this is you pronounce it like, imagine a person who's into yoga, right? And they say Om like that. And when they're doing yoga, they're in like a garden and they're peaceful, right? So they say Osteoma, right? So that should remind you of this guy is, or this person is in a garden doing yoga, and osteoma. Why? Because location is several facial bone, but it's associated with Gardner syndrome. Okay, that's why. And Gardner syndrome was in GIT. Remember, it's the one where you get polyps, hamartomas polyps, right? Osteoid osteoma. This is a pretty easy one to figure out, because why? Because you just draw two O's, so that's one O, right? Let's make it brown, and then you draw another O, and make it clear. And now you put in there, and you have a donut, right? And so 1 O for osteoid, 1 O for osteoma. It makes a donut, and that's what it looks like. It looks like a little hole, right? So it happens in adults less than 25 years old. It starts with O. So males more than females. Location is cortex of long bone. Uh, so this is the cortex of the long bone, and happens there, right? And it looks like a donut and diaphysis. Okay, cortex of the long bone. Presents as bone pain, worse at night. That is relieved by NSAIDs. This is important because this is how you differentiate between this and this as well, if they don't give you a picture of x-ray or something. So bone mass with radiolucent osteoid core less than 2 centimeters. Okay, and that's also a differentiating feature. So one that is relieved by NSAIDs, and it's less than 2 centimeters. Osteoblastoma is larger than 2 centimeters, and it does not respond to NSAIDs. Histology is similar to osteoid osteoma. Okay. And that. So if they tell you it's at the metaphysis and it's benign, it can only be this, okay? Because that's the only one that happens there. Okay. With the osteoma, you say Om because it's associated with Gardner's syndrome. And just so you know what that looks like, osteoma. Okay. So that's what it looks like, osteomas on the face. Okay. Like that. And that, and that. Okay. So another thing you should know about this is where it happens. So surface of facial bone. Okay, and osteoma, cortex of that. Okay, I'm gonna move on now. Osteoblastoma, did that already. It's similar to osteoma. However, it's larger than 2 centimeters and it does not respond to pain. Okay. So how would you remember that? Cannot blast it with pain meds. Okay. Because there's blast in it. I just made that up. Okay. A small donut is better than a bigger one because you don't want to get the calories, I guess. So remember that way. On to chondroma. For chondroma, if you just look at what it is, it's easier to remember. It's like thorns in the fingers. Like that. Okay, so it forms stuff on your hands. The bones on your hands. Okay, or like that. Okay, so where does it happen? Medulla, small bones of hand and feet. It's a benign tumor of cartilage. Okay, so chondroma is chondro again. That's just cartilage, right? And oma is benign tumor. So benign tumor of cartilage of small bones and hands and feet, fingers. Giant cell tumor. That's hold on. They don't have that here. 20 to 40 years old. Epiphysis. It happens there. Giant cell tumor right there. Okay. We didn't come across it. Okay. Epiphysis long bone, often in knee region. Locally aggressive benign tumor. Neoplastic mononuclear cells that express rank L. And reactive multinucleated giant osteoclast-like cells. Osteoclastoma. Okay, so giant cell tumor is of osteoclasts, right? So you get the soap bubble appearance on X-ray, okay? Because there's osteoclastic activity. Because what does it do in giant cell tumor? It expresses rank L on the osteoblast, right? Osteoblast will then give this and attach it to osteoclasts. Because not all the OPG can control. Like there's only limited amount of OPG in your system, right? And then it's striking a balance with the rank L. But then when you have a tumor that's increasing rank L, OPG can't keep up with all the rank Ls. So then now the rank L is going to start binding to osteoclasts and activating it and, differentiating osteoclasts into activated osteoclasts. So that's why you then start getting osteoclastic activity, which seems like an soap bubble appearance because of that. Okay. Osteosarcoma. This one you remember like osteosuncoma. Okay. Because it has a bursting sun appearance. Okay. Its epidemiology is again it's O, so it happens in males less than 20 years old. It accounts for 20% of primary bone cancers. Less common in older adults, usually second to predisposing factors such as Paget's bone infarcts, radiation, familial retinoblastoma, and Li-Fraumeni syndrome. Remember, this was the Sabla syndrome. Metaphases of long bone, often in knee region. So in Sabla, B was for bone. Okay. So it happens in here, metaphysis, malignant one. So they'll tell you in the question, Sam, there's a growth in the metaphysis of the bone. It's benign. If it's benign, it's this. It's malignant, then it's this. osteosarcoma, osteochondroma. Okay, often in the knee region. Characteristic is pleomorphic osteoid producing cells, malignant osteoblasts. Presents as painful enlarging mass of or pathologic features. You get the Codman triangle, so that's this triangle right there. Okay, this is usually the one that they do though. So from elevation of periosteum or sunburst pattern on X-ray, think of osteocod, bonefish swimming in the sun. Okay, so see how it looks like a sunburst appearance. So that's the one for osteosarcoma. It's aggressive, primary usually responsive to treatment, surgery, chemotherapy, poor prognosis for two secondary causes. Okay. Chondrosarcoma. This is most common in adults more than 50 years old. Medulla of pelvis, proximal femur, and humerus. Tumor of malignant chondrocytes, lytic, more than 50% cause cases with intralesional calcification, endosteal erosion, cortex breach. Uh, this one, they don't really test you on it, so it's okay if you don't memorize this. Medulla, pelvis, proximal femur, and humerus. There's nothing to test here, so I don't know what they can ask. They didn't even bother giving an image for that. So we'll just move on. Make this smaller. Maybe let's get rid of that. Let's get rid of that. Okay, Ewing sarcoma. This is an important one because of its association with the genetics. So, most common in white patients, generally male, less than 15-year-old. Diaphysis of long bones, especially femur, pelvic flat bones. Anaplastic small blue cells of neuroectodermal mesenchymal origin, resembles lymphocytes. F. Okay, that. Okay, so up till then, it's okay if you don't remember. Just remember that it happens in diaphysis, round cell lesions, right? That's the important part in Ewing sarcomas. It differentiates from conditions with similar morphology. For example, lymphoma, chronic osteomyelitis by testing for translocation between 11 and 22. Okay, so fusion protein, Ewing sarcoma, FL11. So this translocation is really important. They'll tell you that there's growth in the bone, and when they check the DNA for it, there was translocation in 11 and 22. So 1122 is equal to 33, and 33 was the number for Patrick Ewing's jersey. If you don't know who he is, then it's not going to help you a lot, right? But 11, 22, you know, just think of it like age from 11 to 22, and then soon enough you'll be 33. Okay, fusion protein EWS FL11. Onion skin periosteal reaction, they might give you that. Aggressive with early metastasis, but responsive to chemotherapy. Okay, important for the translocation for this one. Okay, and that it happens in diaphysis. Okay, that's what it looks like. You can go to lungs. Okay, Ewing sarcoma. Okay, so anaplastic small blue cells of neuroendocrine differentiation from conditions with similar morphology. For example, you have to differentiate between lymphoma and chronic osteomyelitis and Ewing sarcoma, right? By testing for this translocation 11 and 22, there's a fusion protein of this onion skin periosteal reaction and that. Okay, cool. Quick revision of that: osteochondroma, osteocomonoma, because it's the most common one; osteocartilaginosoma, because of chondro is cartilaginous. It's the one that happens in metaphysis. Okay, osteoma, oma, because you're doing yoga in a garden. Uh, right. So Gardner syndrome, that's surface of facial bone. Then you have osteoid, osteoma, two O's, one in each other, doing the donut. It looks like a donut or a hole, right? It does not. It's not bigger than 2 centimeters. Sorry, and it responds to NSAIDs. The one that doesn't, you can't blast the pain with. You can't blast the pain with pain meds. It's the osteoblastoma, right? It's larger in size, more than 2 centimeters, and unresponsive to NSAIDs. This also happens. This happens in vertebra. Then you have chondroma. Chondroma is cartilage in the fingers. Uh, Giant cell. That's giant cell of osteoclast. So you have osteoclastic activity, doing the soap bubble appearance. Osteosarcoma is osteosuncoma. You will see a sunburst appearance, right? Or Codman's triangle, right? Chondroma, Ewing. Chondroma, you can just ignore it. Uh, Ewing sarcoma, translocation 1122, onion skin periosteal reaction. Uh, diaphysis is where it happens, pelvic and flat bones. Okay, on to osteoarthritis and osteorheumatoid arthritis. Osteoarthritis versus rheumatoid arthritis. Okay, so for osteoarthritis, the pathogenesis is mechanical wear and tear destroys articular cartilage, uh, degenerative joint disorder, which leads to inflammation and inadequate repair. Chondrocytes mediate degradation and inadequate repair. Okay. Okay. Chondrocytes mediate degradation and inadequate repair, right? So let's look at this while we do that. Okay. So it happens because of normal wear and tear, um, right? It destroys the articular uh, cartilage. So that's the articular cartilage over there, right? This cartilage thing right here. Um, Inflammation with inadequate repair. Chondrocytes mediate degradation and inadequate repair. So then, when it doesn't rebuild, you get osteoarthritis because of that. Predisposing factors are age, female, obesity, and joint trauma. In a question stem, this is how they will present it: that there is pain in weight-bearing joints after use. For example, at the end of the day, okay. So this is the buzzword right here. If there's joint pain or weight-bearing pain, at the end of the day, it's osteoarthritis because it hurts after using it. And this one is gonna be in the morning. We'll look at that after. Uh, it improves with rest. Okay. Asymmetric joint involvement. Knee cartilage loss begins medially, so bow-legged. No systemic symptoms. Joint findings: osteophytes, bone spurs, joint spacing narrowing asymmetric, subchondral sclerosis and cysts, synovial fluid non-inflammatory WBC less than 2000 millimeter cube. Development of Heberden nodes at DIP and Bocard's node at PIP, and first CMC and not the MCP, right? So that's carpal, metacarpal, uh, MCP. Okay, so let's take a look at those first. Okay, so this is where rheumatoid is happening. That's osteoarthritis. That's gout. Psoriatic arthritis is over there. Ankylosing spondylitis over there. Okay, but what we are looking at is this. So osteophytes, that's these stuff right there. Okay. Uh, Joint space narrowing. So in normal, you have some space here, right? But then there's narrowing of that on this side. Okay. Uh, Subchondral sclerosis and cysts. Synovial fluid non-inflammatory. Okay. That's important. Development of Heberden nodes. I guess let's search for that then. Okay, there you go. So what happens over here and here, but not over here. That's what they said, right? So at distal interphalangeal joint and Bocar's node at proximal interphalangeal joint, and the first carpal metacarpal. Okay, but not at metacarpal phalangeal joint, right? So it doesn't happen here, and that's the differentiation factor. Okay, BIP and this. So it's gonna look like that and that, but the knuckles are gonna be okay over here. And yeah, so it can be like that, like that. This is osteoarthritis there. Okay, and carpal metacarpal joint. So that's the toe. It is not the toe. I was mistaken. It's this part. Okay, so for the thumb, it's gonna happen over there. Okay. Okay, so here you see the collapse of the space, right? There's narrowing of the space over there, like that. It's okay. They won't talk about this that much. They might in the questions then, but if they show you the photo, it's going to be easier because that's how you differentiate it. It happens over there, whereas on this side, it's going to be at MCP, PIP, and wrist, but not at DIP, right? So if it's at DIP, it's this one. If it's not at DIP, it's this one basically, or it's if it's at MCP. Okay. The treatment for this is activity uh, modification, acetaminophen, NSAIDs, intra-articular glucocorticoids. Okay. Okay. So done with that, and we'll look at this now. All right. Before we go on, let's look at this. So there's a thickened capsule, thin and fibrillated uh, cartilage over there, osteophytes, loose bodies, subchondral sclerosis, and subchondral bone cysts. Right. So you see it over there. There. This is for rheumatoid, I think. Right? E. No. Oh, that's the PIP, right? Okay. but PIP also happens on in here too, right? So um, gotta look out for the MCP for that one. Okay. Okay. On to this rheumatoid arthritis. So it's autoimmune, inflammatory. What's that? It's autoimmune, inflammatory, right? So C, looks like that. At PIP and MCP, it happens. Autoimmune inflammation induces formation of pannus. This is proliferative granulation tissue, which erodes articular cartilage and bone. Okay, this was normal wear and tear. Okay, so you don't have any autoimmune or immune stuff or cells over here. Over here, you have immune cells doing things. Okay, and usually it's just complex antibody and antigen complex, right? That does this. It gets settled in the joints and then it does inflammation from that. So inflammation induces formation of pannus. This is pannus. Okay. Uh, Synovial proliferation, hypervascularity, dense inflammatory infiltrate. There's increase in synovial fluid, eroding cartilage and bone erosion. Okay. Which erodes articular cartilage and bone. Okay. On this side, we have inadequate repair. Okay. On this side, it's not about the repair. It's about the pannus formation. Okay. There's increase in synovial fluid on this side, uh, eroding cartilage and bone erosion. Okay. So predisposing factors are the female, HLA-DR4, 4 room to room, tobacco smoking, positive rheumatoid factor, immunoglobulin M antibody that targets IgG and FC region in 80%. Anticyclic citrulline peptide antibody. This is more specific. This one is the one you have to remember because you'll remember this one. IgM targets IgG FC region, but you'll forget about this one. So remember that it's anticyclic citrulline peptide body as well, antibody as well. Okay. Presentation is pain, swelling, and morning stiffness, right? Whereas in the morning it's uh, better here and it gets worse with use. Over here it gets worse with rest and gets better with use. Okay, so lasting more than 1 hour, improving with use. Symmetric joint involvement, systemic symptoms like fatigue, fever, weight loss, extra-articular manifestations common. So what they mean by that is that extra-articular manifestations include rheumatoid nodules, fibrinoid necrosis with palisading histiocytes in subcutaneous tissue and lungs. Uh, that is pneumoconiosis and Kaplan syndrome. Interstitial lung disease, pleuritis, pericarditis, anemia of chronic disease, neutropenia, splenomegaly, Felty syndrome, AA amyloidosis. Remember, AA is for inflammation. Sjogren syndrome, scleritis, and carpal tunnel syndrome. All of these things. Joint findings are erosion, juxta-articular. So this is what they're gonna show you in the question stem, by the way. So that's how they're gonna present it. The joint findings are going to be erosion, juxta-articular osteopenia, soft tissue swelling, subchondral cysts, joint space narrowing, symmetric, and the deformities are going to be cervical subluxation, ulnar finger deviation. This is important. They tell you that it's ulnar deviation, finger deviated. What they mean by that is that it's the fingers are going laterally towards the ulnar side, like that. Okay, so that's ulnar deviation. That's what it looks like. Okay. This one also has nodes on the uh, knuckles over here, right? You can see it in this one too, the Bocard nodes or whatever, right there. Right. So it's ulnar deviated. It also has swan neck or boutonniere, right? So boutonniere is like a gun, right, from all the times because of its shape like that. So it could be like that or like this or the ones we just saw. It involves the MCP, PIP, and the wrist. Okay, it doesn't involve DIP or the first carpal metacarpal joint. Okay, treatment is NSAIDs again, similarly like this one. Uh, Glucocorticoids, similar to this one. Disease modifying agents, methotrexate and sulfalazine. Biologic agents, for example, TNF alpha inhibitors, right? Because this is the one that causes inflammation. So what happens is the antigen antibody complex, after it fights off the infection, it gets uh, deposited in the joints, and wherever it gets deposited, it causes reaction, right? And that reaction is the reason why you get rheumatoid arthritis. The reaction is inflammation. Uh, and inflammatory cells are interleukin 1, 6, and TNF alpha, right? Anti-inflammatory are interleukin 10 and uh, TGB, uh, sorry, tumor growth factor, TGF beta, and interleukin 1, 6, and TNF alpha recruit interleukin 8 and 12. Okay. Uh, so now let's compare the two. Uh, there's a thickened capsule here, whereas here you have, and normally you have joint capsule and synovial lining like that, right? But here you have pennus, synovial proliferation, and this and this. They'll talk about this for this one, that there is increase in synovial fluid, and that's for rheumatoid arthritis. You can think of it like the membrane has increased permeability due to the inflammation, right? That's what it does. But here it's normal because there's no inflammation here due to immune deposits. It's just inflammation because of the debris. There's eroding cartilage here. Here you have thinned or fibrillated cartilage, right? You have bone erosion here. You have osteophytes here, loose bodies, subchondral sclerosis, and this. It's important to know where it's happening in which joints. So for this side, it's DIP and PIP, not MCP, and you have it at CMC as well, the first point, carpal metacarpal joint. That's the thumb one. On this side, it's only on the MCP and PIP and the wrist. This one, it gets worse with use, so it's better in the morning. This one gets worse with rest, so it's worse at morning and better at night. Okay, the joint pain. And yeah, moving on to gout. The findings for gout are acute inflammatory monoarthritis caused by precipitation of monosodium urate crystals. Uh, this is important. Okay, in joints. Risk factors are male sex, hypertension, obesity, diabetes, dyslipidemia, alcohol use. Strongest risk factor is hyperuricemia, which can be caused by under excretion of uric acid, right? Actually, let's look at that too. Hmm, where'd it go? I don't know what I saved it as now. Let's just find it from here. Yeah, this thing. Okay. Okay. So under excretion of uric acid, so this is uric acid, this is how it's made, right? From hypoxanthine to xanthine to uric acid, and then it gets water soluble by urate oxidase and becomes allantoin, and then it goes out. So uh, the way you get gout is when you have under excretion of uric acid, uh, right? So when you last longer in the body. So 90% of the patients, it's this. Largely idiopathic, potentiated by renal failure, can be exacerbated by alcohol and certain medications, for example, thiazide diuretics. Okay. Overproduction of uric acid, 10% of patients. This is Lesch-Nyhan syndrome. Okay, so when you have this, the hypoxanthine does not go back, right? So it makes more xanthine, right? And here it does not go back, so it makes more xanthine on this side as well. So when you have increased amount of hypoxanthine and xanthine, you'll have increased amount of uric acid being made, right? So overproduction of uric acid, 10% of patients this is Lesch-Nyhan syndrome. PRPP access, that's this one right here, right? Increase in cell turnover, for example, tumor lysis syndrome and von Gert's disease. Remember this? It's the one where you have increased amount of calcium and potassium and all that stuff. What is it? This thing right here. Decrease in calcium and increase in potassium, increase in phosphate, increase in uric acid, right? Creates this and this and this and that. Okay. Uh-oh, I forgot the page now. There it is. Okay. All right. So again, that increase in turnover, tumor lysis syndrome, and von Gertz disease. That's the storage disease, right? It's the one where the kid is has a fatty liver, hypotonia, and it's more severe than Corey's. Right? Crystals are needle-shaped and negative bifringent under polarized light. This is important. This is how to differentiate this between this and the pseudogout. This one, okay, because that one is positive. So what do they mean by bifringent under polarized light? So yellow under parallel light. So if you put a light on this, right, the ones that are parallel to the rays of the light are going to show up yellow, and the ones that are perpendicular to the light is going to show up blue. So this is perpendicular, this is parallel, right? So if this is parallel, that means this is perpendicular, because this is perpendicular to the yellow one as well. So that's how you know that. In case they don't tell you, uh, or give you a description of the photo and just give you the photo, that's how you figure it out. So, or you can just memorize that. If you see yellow and blue, it's gonna be uh, gout, and it's made up of monosodium urate crystals. Okay. Uh, the crystals are needle shaped and negative bifringent. Okay. Serum uric acid levels may be normal during an acute attack. Okay. So you don't need to have increased amount of uric acid. So if they tell you that the person's has all these symptoms, but then the uric acid level is normal, so you're gonna be like, wait, it can't be gout because this is normal. But this is important because you can have an acute attack where the serum uric acid level is normal. Okay. Symptoms. Also, that thing was what? It's monouric crystal in joints. That's what it looks like. Okay. Asymmetric joint distribution. Joint is swollen, red, and painful. Okay. This is important. It's swollen, red, and painful. It's also warm. They also give you that. Okay, and that's important. Classical manifestation is painful. Metatarsal, uh, MTP, metatarsal phalangeal joint, I guess. Metatarsal phalangeal joint. Okay. So classic manifestation is painful MTP joint of a big toe or podagra. Tophus formation. So that's called a tophus formation. Well, look at that. Often on external ear, olecranon bursa, or Achilles tendon. Okay. So right there, or right there. Okay. They do give you this that it's on the elbow or on the big toe. Okay. It's usually going to be the elbow or the toe, but it could be the knee as well. So often on external ear, olecranon bursa or Achilles tendon. Acute attack tends to occur after a large meal with food rich in purines, for example, red meat or seafood. Trauma, surgery, dehydration, diuresis, sorry, or alcohol consumption. Alcohol, that's beer more than spirits. Metabolized, metabolites compete for same excretion sites in kidney as uric acid. So that leads to decreased amount of uric acid secretion and subsequent buildup in blood. Treatment is acute NSAIDs, that's endomethacin, glucocorticoids, and colchicine. Okay, important one. Uh, Colchicine is for acute. Okay, and what about chronic? So for chronic, you give allopurinol or febuxostat. So they inhibit the conversion of hypoxanthine and xanthine into uric acid. Uh, so it inhibits xanthine oxidase. Okay, so xanthine oxidase inhibitor, allopurinol, and febuxostat. These are for chronic. It's important to remember that this is for chronic. Colchicine is the one for acute. Or if they don't give you colchicine, it's gonna be NSAIDs or glucocorticoids. Okay. Then we have something that's called pseudogout or calcium pyrophosphate deposition disease. This was again one more time monosodium urate crystals. Okay, and this is calcium pyrophosphate deposition disease. So that's what it looks like. It doesn't look like straight sticks, right? It looks like you know, crystal meth crystals. But yeah, formerly called pseudogout, deposition of calcium pyrophosphate crystals within the joint space occurs in patients more than 50 years old, both sexes affected equally, usually idiopathic, sometimes associated with hemochromatosis, hyperparathyroidism, and joint trauma. Okay, pain with swelling and acute inflammation. Okay, so what's important here? So deposition of calcium pyrophosphate crystals within the joint space. Uh, this is okay. That's not going to give you much. You It's usually idiopathic, sometimes associated with hemochromatosis, hyperparathyroidism, and joint trauma. That's still not going to give you much. Pain and swelling with acute inflammation. That still doesn't give you much. What gives you is this thing over here. So right there. So let's keep going. Pain and swelling with acute inflammation, pseudogout, and or chronic degeneration, pseudoarthritis. Most commonly affected joint is the knee. Okay, that's important. The knee one happens with pseudogout. This doesn't happen in the knee, right? The gout. It happens in the elbow. Where was it? The elbow, the toe, right? The big toe or podagra. Olecranon bursa, Achilles tendon, and external ear. This one happens at the knee. Okay, most commonly affected joint is the knee. Chondrocalcinosis, that's cartilage calcification on X-ray. You'll see that. Uh, so if they give you that along with the symptoms, then you should be able to pinpoint it down to this. Um, Crystals are, they'll explain this, and this is how you figure it out. If you see rhomboid, you know that rhomboid is the crystal meth one, and the sticks are the one that's this. Okay, crystals are rhomboid and weakly positive, bifringent under polarized light. They usually give you this in the thing, and it's basically giving you the answer there. Blue when parallel to light. Okay, that's it. You don't see yellow. Acute treatment is NSAIDs, colchicine, and glucocorticoids, just like this one. But however, for chronic, you give colchicine as well. The blue piece of CPPD, blue when parallel, positive bifringence, calcium pyrophosphate, and pseudogout. Uh, Important to know the difference between these two. Okay, and yeah, it's made of calcium pyrophosphate. Onto systemic juvenile idiopathic arthritis. This is systemic arthritis seen in less than 16-year-olds, usually presents with daily spiking fevers, salmon pink macular rash, arthritis, commonly 2 plus joints, associated with anterior uveitis, frequently presents with leukocytosis, thrombocytosis, anemia, increase in ESR, increase in CRP. Treatment is NSAIDs, steroids, methotrexate, and TNF inhibitors. So again, uh, just like with other idiopathic things, usually this is not going to be asked because to pick this one, you have to rule out everything else. Okay, and you have to do that under 40 seconds. So usually they don't, this is not going to be the answer. They want you to pick the one that, you know the they'll give you buzzwords for and stuff like that. But if nothing else works, then it would be this, but that's very rare because all of this um, points to something or the other, right? And usually they don't give you all of this along with other stuff, because they just don't. Because this looks like husk, doesn't it? uh, and then this looks like anterior uveitis. That looks like, I don't know, bacterial infection or something. The one with anterior uveitis. We haven't done the ophthalm yet, so it'll come there. Okay, Sjogren syndrome. Sjogren syndrome is where everything is dry, right? Dry eyes, dry tongue, uh, dry lacrimal duct, salivary duct. Okay, Sjogren's. It's an autoimmune disorder characterized by destruction of exocrine glands, especially lacrimal and salivary, by lymphocytic infiltrates. Predominantly affects females 40 to 60 years old. Okay. Findings are inflammatory joint pain, keratoconjunctivitis sicca, decreased tear production, and subsequent corneal damage. It leads to gritty and or sandy feeling in eyes. So that's the one where it's like because of dry eyes, right? Xerostomia, that's decreased saliva production. Leads to mucosal atrophy, fissuring of the tongue. Okay, that's the fissures you see. Those is because of dry tongue. So dry eyes, dry tongue. Presence of anti-nuclear antibodies. This is important. So you'll see ANA positive. That's how they write those. Okay. ANA positive rheumatoid factor can be positive in the absence of rheumatoid arthritis. Okay. And so if they give you a presence of rheumatoid arthritis, but then they tell you that it's negative for anti-citrulline uh, peptide or whatever, what was it? Anticyclic citrulline peptide antibody, then it's not going to be rheumatoid arthritis. If they give you anything negative for this or negative for this, they're telling you that it's not rheumatoid arthritis. So don't try to connect it and overthink it. It's very simple. Okay. So presence of ANA, RF can be positive in absence of rheumatoid arthritis. Uh, Anti-ribonucleoprotein antibodies, that's SSA and SSB. So that's easy, Sjogren syndrome A, Sjogren syndrome B. But it's also known as anti-Ro and anti-La. And that's usually the one that they use. They don't use the SSB and SSA because that would be too easy. So anti-Ro and anti-La. Bilateral parotoid enlargement. Okay. You can just think of it because having a, dry salivary glands or decreased salivary production, everything's going to get built up into this, the parotoid glands. Okay. Anti-SSA and anti-SSB may also be seen in SLE. Okay. But with this one, they'll give you that there's a butterfly rash or butterfly malar rash, right? Common primary disorder of secondary syndrome associated with other autoimmune disorders. That's rheumatoid arthritis, SLE, and systemic sclerosis. Complication is dental caries, mucosa, right, because of dry mouth. So that's how you get caries. Mucosa associated lymphoid tissue, that's MALT lymphoma, right? May present as parotoid enlargement. Increase in risk of giving birth to baby with neonatal lupus. This is important uh, that you remember that for like a PD question. Focal lymphocytic cialdinitis on labial salivary gland biopsy can confirm diagnosis. Okay, so focal lymphocytic cialdinitis on labial salivary gland biopsy. So if they give you something like this, they don't. You'll see this, you won't. Okay. Septic arthritis. S. aureus, streptococcus, and Neisseria gonorrhea are common causes. Usually unilateral, affected joint is swollen, red, and painful. Synovial fluid purulent, WBC more than 50,000. Treatment is antibiotics, aspiration, and drainage, with or without debridement, to prevent irreversible joint damage. Disseminated gonococcal infection. STI that presents as either purulent arthritis, for example, knee, or triad of polyarthralgia, tenosynovitis, and dermatitis or pustules. Okay. So for septic arthritis, even though it's S. aureus and streptococcus, it's usually this one that they're asking about. Okay, they'll give you that. Either they'll tell you that it's gram negative, that was isolated, or there's diplococci in culture. So somehow they'll point towards this. But if they don't say anything and they only, they give you just this, that there's knee pain, and the pain migrates to somewhere else and then somewhere else, like migratory arthritis, it's gonna be this as well, Neisseria gonorrhea, because this one has much more, like many more symptoms than these are explained. Okay, so septic arthritis, you need to know how to figure out that septic arthritis. So it's this, that the joint is swollen, red, and painful, and it's usually going to be warm. Okay, synovial fluid purulent. So you'll have WBC. So WBC tells you that it's an infection, right? Also, the fever will tell you that as well. Uh, yeah, and usually I think they also tell you that the dude's gone hiking or something, and then he comes back to confuse you with like Lyme's disease or something like that. But keep this in mind. Okay. Seronegative spondyloarthritis. So this is when you don't have any infection like these. So arthritis when there's bacteria is called septic arthritis, but when you have arthritis because of non-bacterial reasons is called seronegative spondyloarthritis. So arthritis without rheumatoid factor, remember that comes from infection. So without rheumatoid factor, so no anti-IgG antibodies. Remember IgG, FC antibodies, and their IgM. Strong association with HLA B27. This you have to remember. This HLA, this is the most important one. HLA B27, and that's always going to be associated with ankylosing spondylitis. MHC class 1 serotype. Subtypes pair share variable occurrence of inflammatory back pain associated with morning stiffness, improves with exercise. This is important. This line right here, associated with morning stiffness and improves with exercise, right? Uh, it kind of sounds like it's rheumatoid arthritis, doesn't it? Because that's what we read over here, that uh, there's morning stiffness and it improves with use, right? So it's similar, but then they'll tell you that it's negative for rheumatoid factor. Okay, and that's when you start thinking about, okay, so it could be spondylitis or HLA-B27. Okay, so subtypes are pair, shares variable occurrence of inflammatory back pain because it's associated with morning stiffness and improves with exercise, associated with peripheral arthritis and enthesitis, that's inflamed insertion sites of tendons like Achilles, right? So it might seem like a plantar fasciitis, right? Dactylitis, so sausage fingers, and uveitis. Okay, so it's important to remember it's negative for bacterial culture. So if it's like that, it only leads to these three things. Okay. Uh, so it's associated with skin psoriasis and nail lesions, asymmetric and patchy involvement, dactylitis, and penicillin cup deformity on DIP on X-ray. Okay, so that's the penicillin cup deformity. Oh, that right there. Sorry. Right, it looks like you put a pencil in a glass of water, and then you know how it goes straight down, and then it moves this way, and then goes straight down. So that's what that is. Penicillin cup deformity, and that's associated with uh, penicillin cup. So P for psoriatic arthritis. P for P. Penicillin cup and psoriatic. It's seen in fewer than one-third of the patients with psoriasis. Ankylosing spondylitis, that's symmetric involvement of spine and sacroiliac joints, leads to ankylosis, joint fusion, uveitis, aortic regurgitation. Okay. This is usually the one that they'll give you, that there's lower back pain. So then you're gonna have to differentiate between this, multiple myeloma, uh, benign prostatic cancer. These three things. Okay, so uh, the finding or the buzzword is bamboo spine. That's vertebral fusion, and that's what it looks like. This is normal. Well, it's not. So let's go look at a normal one too. Okay, so this is a healthy spine, and this is ankylosing spondylitis. So you have inflammation at the joints, and then it ends up like that. Okay, so what it looks like is like a bamboo. So let's look at what bamboo looks like. Okay, so it looks like that, right? That's a bamboo, so it looks like that, bamboo spine. Okay. Uh, Important to remember, bamboo spine happens in ankylosing spondylitis. Okay. Costovertebral and costosternal ankylosis may cause restrictive lung disease. Remember, because restrictive was happening even with kyphosis. So it gets affected with due to the shape of the spine. So costovertebral and costosternal ankylosis, um, right? So that's the ribs and the sternum, and this is the ribs and the spine. So if those get fused, you don't have the or the, what do you call that? The little things in the middle. I'm skipping on the word right now, but these things. So you won't have any margin or like any buffer or any cushioning to move around. So it's gonna be all solid. So your lungs are gonna be restricted when it's trying to inflate. Right. So moderate degrees of reduced chest wall expansion to assess disease severity. More common in males with age of onset, usually 20 to 40 years old. Remember, it's associated with HLA-B27. That's MHC class 1 serotype because it's one letter, so MHC1. Okay, and one is CD8 association. Okay, inflammatory bowel disease, that's Crohn's disease and ulcerative colitis, which are often associated with spondyloarthritis. Okay, inflammatory bowel disease, Crohn's disease, and ulcerative colitis are often associated with spondyloarthritis. So it can show up in a GIT question as well. It doesn't, just letting you know. Reactive arthritis, they don't usually complicate a question with like 2 3 diseases at once. They just want you to they just want to see if you know what things are associated with what. So they'll basically feed you the answers, right? They'll tell you that the person has lower back pain and restrictive movement, forward movement or backward movement or whatever, probably forward movement, and has the decrease in RV, TLC, and FRC, and all that stuff too. They could give you that. That's restrictive. So, or they might just give you a photo of a bamboo spine, and that's just telling you the answer, right? So it's just about remembering and associating things with other stuff. For IBD, they usually just test you on malabsorption diseases because Crohn's disease affects the epithelial lining or endothelial lining of the ileum, and ileum is where you get you reabsorb like bile, uh, B12, and if you don't absorb bile, you're soon gonna run out of bile, right? And then you will start getting uh, vitamin A, D, E, and K malabsorption and deficiency. So it's like that. That's how they uh, will associate it like that. Okay. So in Crohn's, they might tell you what is the cause of megaloblastic anemia in Crohn's, right? It's because in Crohn's it's affecting the ileum, and you're not getting B12, and B12 deficiency leads to megaloblastic anemia. So like that. So it's like a two-step thing. They usually only go with 2 steps. They don't go through like 3 steps or 4, right? Reactive arthritis, classic triad. That's conjunctivitis, urethritis, and arthritis. This is an important one, okay? Because this seems similar to septic arthritis, but it's not, okay? So you can't see because of conjunctivitis, you can't pee because of urethritis, and can't bend my knee because of arthritis, okay? Can't see, can't pee, can't bend my knee. It's associated with infection, so these ones are associated with infection, okay? Unlike these ones. Uh, okay, associated with infection by Shigella, Campylobacter, E. coli, Salmonella, Chlamydia, or Yersinia pedis. Okay, so for this one, they'll just straight out give you this stuff that the person has redness in eye, uh, CRP is increased. Uh, let's see, and there's a joint pain, and the person's uh, creatinine is increased, right? So there's increased amount of creatinine, or they have that just tells you there's something wrong with the kidney, or urethritis. You know, they'll just give you burning pain in the urine or while micturition or whatever. I don't know. Not burning pain during micturition because that's for gonorrhea, right? But you know, they'll just give you something that indicates all of these three, and then you know that it's going to be reactive arthritis because of that. It's hard to figure out in a question stem when they you have to rely on these things. Um, but yeah, usually they give you that there's culture positive, right, for whatever it was, and then it's this. So you need to know about all of these. This was like this happened. This is a coma shaped, right? And it happens due to uh, undercooked meat and poultry. E. coli is just that. Salmonella, that. Chlamydia, that. And Yersinia pedis is the black plague one. The vector is a fly, and rodent is the carrier. Okay. SLE, that's the butterfly malar rash. Okay. So SLE, or systemic lupus erythematosus, it's systemic remitting and relapsing autoimmune disease. Organ damage primarily due to type 3 hypersensitivity reaction, and to a lesser degree a type 2 hypersensitivity reaction. Okay. Associated with, so type 3 is antigen antibody complex, and this is antigen antibody reaction. Associated with deficiency of early complement proteins, for example C1q, C4, and C2, that leads to decrease in clearance of immune complexes. Okay, remember the complex system? That's the one with MAC, where C5 to C9, you need that to deal with gonorrhea or Neisseria infections, right? So part before C5 was this stuff that you need for to not have this. So associated with deficiency of early complement proteins, decreased clearance of immune complexes, classic presentation, rash, joint pain, and fever in a female of reproductive age, increase in prevalence in Black, Caribbean, Asian, and Hispanic population in US. Okay. Liebman-Sachs endocarditis, LSE in SLE. This is the one where you had it in the heart without, what was it? We'll go look at that. Infective endocarditis, right? Nope, right here. This is the one. So non-bacterial thrombotic endocarditis, right? So SLE over there. That's where we read that. Okay, Liebman-Sachs endocarditis. Lupus nephritis. This is glomerular deposition of DNA and DNA immune complexes. Okay. Can be nephritic or nephrotic, causing hematuria or proteinuria. Right. We'll do that in renal. Most common and severe type in diffuse proliferative. Common cause of death in SLE is renal disease. This is the most common. And then infections, cardiovascular disease, accelerated CAD. Lupus patients die with redness in their cheeks. Okay. In an anti-SSA positive patient, uh, positive pregnant patient, there's increased risk of newborn developing neonatal lupus. This leads to congenital heart block, periorbital, diffuse rash, transaminitis, and cytopenias at birth. So you need to know about this one. Okay, and DNA anti-DNA immune complexes. That's the one you need to know for SLE. Okay. Another thing, if they even talk about malar rash or redness in cheeks or anything, this is what they're usually hinting towards, other than Coxsackie, the hand, foot, mouth disease, or no, sorry, parvovirus, the slap cheek disease. That's the one. Sorry. Uh, Rash or pain. Rash, so it's gonna be malar or discord. It's usually malar. Arthritis, non-erosive. Serositis, for example, pleuritis or pericarditis. Hematologic disorders, for example, cytopenias. Oral nasopharyngeal ulcers, usually painless. Renal disease, photosensitivity. Anti-nuclear antibodies, that's ANA again. Immunologic disorders, so you have anti-dsDNA or anti-Smith or SM, and anti-phospholipid. Okay, if it's anti-phospholipid syndrome, it's gonna be because of they'll present it like a woman gets pregnant and has like three miscarriages, so she's worried about another one, right? Uh, so you're gonna think of probably like erythroblastophetalis or something, but then they'll tell you that she's Rh positive, or so, and the baby is also Rh positive, so it's not gonna be that. So then it's gonna be this thing, and usually that thing only happens if it's like the first or second. But if they say that she has had like 2, 3 miscarriages, it's gonna be antiphospholipid syndrome. Uh, Neurologic disorders, for example, seizures and psychosis. Okay. Mixed connective tissue disease, features of SLE, systemic sclerosis, and or polymyositis. Associated with anti-U1-RNP antibodies. It's speckled ANA. Anti-U1-RNP. They don't test you on this. Not high yield. Okay, so antiphospholipid syndrome, this is what it is. So primary and or secondary autoimmune disorder, most commonly in SLE, diagnosed based on clinical criteria including a history of thrombosis, arterial or venous, or spontaneous abortion, along with laboratory findings of lupus anticoagulant, anti-cardiolipin, and anti-beta-2 glycoprotein 1 antibodies. For this one, you'll this is also the test that we do for VDRL. Okay. Yeah, so that's the one we use for VDRL. So if it's positive, then you gotta do a syphilis specific test, which is FTA ABS or ELISA, I think. Okay. Okay, so they told you right here. Anticardiolipin antibodies can cause false positive VDRL or RPR. Okay, so lupus anticoagulant can cause prolonged PTT, that's play table tennis, so intrinsic factors. That is not corrected by addition of normal platelet-free plasma. Okay, treatment is systemic anticoagulation. Because why? Because this whole thing is because of thrombus in arteries and venous veins, right? Okay. So for reactive arthritis, it's not that these will come out positive because you'll have a negative bacteria culture. What happens is it's because of the immune complexes as well for reactive arthritis. Okay, just wanted to add that. And here it's because of the bacteria culture, bacterias, active bacterial infection. This is not active anymore. It's just the immune complex that's doing this. Okay. Polymyalgia rheumatica. Symptoms are pain and stiffness in proximal muscles, for example, shoulders, hips. Uh, this is the buzzword. Okay. Pain and stiffness in proximal muscles. These are your shoulders and hips. Okay. Often with fever, malaise, weight loss. Does not cause muscular weakness. More common in females more than 50 years old, associated with giant cell arteritis or GCA, okay, or temporal arteritis. This is a vasculitis. We'll read about that right here. Findings are increase in ESR, increase in CRP, and normal CK. This tells you it's an inflammation, right? This tells you there's increase in hematocrit, and normal CK tells you that there's no muscle loss or anything damaging the muscle or any kind of that thing. Treatment, rapid response to low dose glucocorticoids. Fibromyalgia, most common in females 20 to 50 years old. Chronic, widespread musculoskeletal pain associated with tender points, stiffness, paresthesias, poor sleep, fatigue, cognitive disturbance. Sorry, it's called the fibrofog. Normal inflammatory markers like ESR. Treatment is regular exercise and antidepressants. TCAs, SNRIs, neuropathic pain agents like gabapentin. This is the buzzword tender points. So at some points, there's pain, right? It's widespread musculoskeletal pain associated with tender points, stiffness and paresthesia, poor sleep. This is usually the one they use, poor sleep and fatigue. And they also tell you about the fibrofog, cognitive disturbances. They won't say cognitive disturbances, they'll tell you what that is. Right. So that would be like this: short-term memory loss, problems with abstract concepts, attention deficit, slowed information processing. I feel like I'm going through this thing. Okay, so you forget things more often and all that stuff. So that's going to be your fibrofog. Okay, although you'll have normal inflammatory markers like ESR, CRP, CK. Okay, this is important one right here. So polymyositis or dermatomyositis. Before we do that, polymyalgia rheumatica is proximal muscle pain and stiffness in shoulders and hip. Fibromyalgia, you have the fibrofog, poor sleep and fatigue, and most importantly, widespread musculoskeletal pain with tender points. This is the buzzword: stiffness, paresthesia. Okay. Polymyositis and dermatomyositis, non-specific. Anti-nuclear antibodies, again here, ANA positive, increase in CK, Specific is positive for anti-Jo1. This is what you have to remember. Histidyl tRNA synthase. So you'll figure out that it's polymyositis or dermatomyositis, but then you'll forget what it's actually called because you'll be looking for this one. It's actually histidyl tRNA synthetase. Okay, so anti this, or it might even just say anti tRNA synthase, and it's still correct. Positive for anti-SRP. This is signal recognition particle, and positive for anti-Me2 or helicase. Okay, so you have to know what they are and what other names they have for this thing. So one more time, it's positive. The markers are positive, non-specific for ANA and CK. Specific are anti-Jo1 or histidyl tRNA synthase or anti-tRNA synthase. Positive anti-SRP, that's signal recognition particle, and positive anti-Me2, which is helicase. Okay, so if you have positive these, that means it could be either polymyositis or dermatomyositis. So how do you differentiate between these two? Right here, polymyositis, progressive symmetric proximal muscle weakness. So again, for this, it's similar to this thing, right? However, it's gonna have these markers instead of these, right? Characterized by endomysial inflammation with CD8 T cells, that's cytotoxic T cell. This is the patho for this. This is what they're gonna ask you, or they'll ask you this and give you all the other ones. Okay, endomysial inflammation with CD8 T cells most often involves shoulders. Okay, dermatomyositis, clinically similar to polymyositis, but also involves Gottron papules. That's these things. So they'll say there's rash on the dorsal aspect of the hand, or back of the hand, right? Let's look at a few more of those. Okay, those things, they look painful. Photodistributed facial erythema. These are called heliotrope violaceous edema of the eyelids. Okay, let's look at those. Okay. Okay. So heliotrope edema of the eyelids, shawl and face rash. That's this thing, right? So it's like where you wear a shawl. Look at that shawl and face rash right there. They're using the same photo. But anyways, if you don't know what a shawl is, it's these things. So where you would wear that, and then they also wear it on the face, right? So over there, and there, right there. Okay. Mechanic's hand. So there's thickening, cracking, irregular, dirty appearing marks due to hyperkeratosis of digital skin. Increased risk of occult malignancy, perimysial inflammation, and atrophy with CD4 T cells. Okay. Yeah, that's it. So majority of the things, if they give you any of this, it's gonna be dermatomyositis, because you can see most of the things are to do with skin, right? This is on the skin, this is on the skin, this is on the skin as well. Okay, so everything that seems like it's on the skin is going to be dermatomyositis. Everything that's to do with muscle and inner stuff is going to be polymyositis, right? symptomatic muscle pain, weakness, and muscle inflammation with the CD8 T cells. Most often involves the shoulders, right? That's going to be my polymyositis. However, they have the same markers. So if you have the markers, you zone it down to this, and then you circle it down to which one depending on the type of symptoms they have. So if it's skin stuff, it's dermat. If it's muscle stuff, it's polymyo. Okay. Myositis ossificans. Heterotopic ossification involving skeletal muscle, for example, quadriceps, associated with blunt muscle trauma, presents as painful soft tissue mass. Imaging is eggshell calcification. Histology, metaplastic bone, surrounding area of fibroblastic proliferation, benign, but may be mistaken for sarcoma. They do ask about this, so let's see. Heterotopic ossification involving skeletal muscle, right? So that's like a bone and muscles kind of thing, right? So let's see what that looks like. A bone growth over there, right? And the muscles there, and one more right there. Okay, so it's heterotopic ossification, that's just bone formation, involving skeletal muscles like quadriceps, associated with blunt muscle trauma, right? Like a hammer got hit. They hit it with a hammer or something. Okay. It presents as painful soft tissue mass. Imaging is eggshell calcification. Okay, pretty easy if you just know what this is, right? Histology is metaplastic bone surrounding area of fibroblastic proliferation. Benign, but may be mistaken for sarcoma. So, you know. However, for sarcoma, that's not going to be painful, right? Because usually cancers are not painful unless they're bone cancers. That's true. So, I just contradicted myself. Okay, so that. On to vasculitis. If you can figure out it's a vasculitis disease, then it's easier from there because each one is unique. Each one of these, and there are ways to figure out which one's which. Okay, so let's start with giant cell arteritis. It's known for jaw claudation. So the way I remember this is how Dirty helped me remember it. He said it. You call it giant or GCA, right? So GCA for giant cell arteritis, and also jaw claudication, and A was for something else, but for now let's just do jaw claudication arteritis. Okay. It happens mostly in females. Okay. More than 50 years old. It's unilateral headache. So when you see unilateral headache, it's either going to be about something about migraine or this. Okay. It's usually this. Possible temporal artery tenderness and jaw claudication. So they'll say when they're chewing, it hurts. Okay. On one side. So if they have a headache and this, it's usually, if they say jaw claudication, it's this. That's the buzzword. May lead to irreversible blindness. So usually they'll say they have headache, unilateral jaw claudication, and temporary blindness or transient blindness sometimes, which can lead to irreversible blindness later on, due to anterior ischemic optic neuropathy. Okay, it's associated with polymyalgia rheumatica. That's this thing right here, right? Uh, Most commonly affects branches of carotid artery, focal granulomatous inflammation. So that's there. Let's bring this up. Right, so carotid artery is considered a large vessel. Okay, that's why these two are, that and that is giant cell arteritis. So most commonly affects branches of carotid artery, focal granulomatous inflammation. Okay, increase in ESR, interleukin 6 levels correlate with disease activity. Treat with high dose glucocorticoids prior to temporal artery biopsy to prevent blindness. This is important. This is what you treated with high dose of glucocorticoids, okay, to suppress this. Because again, interleukin 6, 1, and TNF alpha are inflammatory cytokines. Okay, so you give it a high dose of glucocorticoids prior to temporal artery biopsy to prevent blindness. Okay. Uh, Takayasu arteritis. Okay. It's usually Asian, female, less than 40 years old. Okay. So for this one, it was about, think about, since this sounds Japanese, you can think of someone who's a samurai named Takayatsu, and he has a sword, and in a fight, he takes off arms of people with the sword. So one arm is gone. So you will have a different pulse, actually no pulse in the arm, right? So that's how you connect it to pulseless disease. Usually Asian female, less than 40 years old. It's an Asian, right? And that's the Asian name, but they usually don't give you that. Pulseless disease, weak upper extremity pulses, fever, night sweats, arthritis, myalgia, skin nodule, and ocular disturbances. Okay, so the thing about this is that you'll have different pulse on upper extremity compared to the femoral or pedal pulses. Granulomatous thickening and narrowing of aortic arch. Okay, and proximal great vessels. So that, okay, that and that. So because of this right there, or clinking of this, it's gonna give you a different pulse. Okay, treatment is glucocorticoids. Both of these are your giant cell vasculitis. So one, you have to figure out if it's a vasculitis or not. If it is, then you got to figure out which one it is, right? So if it was part of the large cell, it's going to be one of these two. Then for median vasculitis, it's these. This is the one where they smoke, and uh, after smoking they walk and stuff, and then they start getting blackening extremities. Okay, and if they stop smoking, it goes away. So Berger disease, thromboangiitis obliterans. So there's thrombo, so the blackening happens because of increase in coagulable state, causing thrombosis in extremity and small vessels, or medium vessels, sorry, right? Heavy tobacco smoking history, males less than 40 years old, intermittent claudication may lead to gangrene. Okay. Uh, Auto amputation of digits. Superficial nodular phlebitis, Raynaud's phenomenon is often present. Segmental thrombosis vasculitis with vein and nerve involvement. Treatment is smoking cessation. So it's usually someone who's doing something like walking, and they have a history of smoking, and then they realize their toes are going black, and they come to you because they're concerned. And Yeah, so that's Buerger's disease. That's the classic presentation of it. Kawasaki disease, that's crash and burn Kawasaki, right? Crash and burn on a Kawasaki. If you don't know what a Kawasaki is, it's a Ninja Kawasaki bike. Pretty cool. These bikes. Okay. So again, it's Asian. So usually Asian children, less than 4 years old. Bilateral non-exudative bulbar conjunctivitis, rash. This is an easy one to figure out because of this right here. When they're talking about Kawasaki, they'll always give you strawberry tongue as a buzzword. Okay. Uh, so yeah. Conjunctivitis, rash, polymorphous desquamating adenoma, cervical, strawberry tongue, oral mucositis, hand foot changes, edema, erythema, and fever. Formerly called mucocutaneous lymph node syndrome. Don't need to worry about that. Crash and burn on a Kawasaki. So C for conjunctivitis, and all on and on. Majority of time, this is all you need because this will give it away. Right. What else causes red tongue? It was this and riboflavin, and there was something else too. Riboflavin was magenta tongue, not strawberry tongue. It'll come to me after. May develop coronary artery aneurysm, thrombosis, and or rupture can cause death. Okay. Treatment is IV immunoglobulin and aspirin. Usually don't give this in a kid, right, because of Reye's disease. But Kawasaki is the only exception where you give it because you can risk Reye's disease over here because this is much worse. This is Pan, okay, and again, Dirty Medicine sets it up pretty nicely. He's like, okay, so think of a story. You're going to your spouse, and it's your anniversary, and you're trying to figure out what to give it to them, right? So you come in with a pearl necklace, okay, and that's the plan A, and then you have plan B as well, okay. Now plan B is something else, doesn't matter what. So uh, plan B is for B for hepatitis B. Pan is polyarthrosis nodosa, and the plan to give pearl necklace because it looks like pearl, string of pearl, right here, appearance, string of pearl appearance. Okay, so it works because I've done questions just thinking about that, and it helps. Okay, so polyarthritis nodosa, usually middle-aged males, so it's a guy who's deciding to give. Okay, hepatitis B seropositivity in 30% of patients, right? Uh, Fever, weight loss, malaise, headache, all of these things. GI, abdominal pain, and melena. All of these are very vague. They don't really point down to this, right? So they have to give you something that points towards this, and those are the buzzwords. Okay. So one giveaway is that it's hepatitis B seropositivity. Okay. Hypertension, neurologic dysfunction, cutaneous eruption, and renal damage. So it's basically everything you can think of except for the CVS symptoms and recipe. Typically involves renal and visceral vessels, but not pulmonary arteries. Okay, that's important. And this is also important because it seems like we'll do this like in renal, but I think there was another place where this came as well. Oh, it was sclerosis cholangitis. I think that's where it was, right? I'll check that out. I'm just not sure if it was primary or not. Uh, Colon, okay. Right, so it was this onion skin alternating dilation and beating. Yeah, so beating effect is happening here as well. Okay, so that's what that was. Primary sclerosing cholangitis. Cool. Okay. But that was beating, and this is string of pearl appearance, and that's what they'll give you. Or they'll just show you something like this, and if it's in the renal arteries, it's your PAN B or panarteriosus nodosa, right? Uh, this literally gives it away that if you know this is the buzzword, then you don't have to think of other stuff. It's a medium vessel vasculitis. Okay. So typically involves renal and visceral vessel, not pulmonary arteries. Uh, so different stages of transmural inflammation and fibroid necrosis. This is why you get the string of pearl appearance. I'll explain that. Innumerable renal micro aneurysms, okay, and spasm of arteriogram appearance. So treatment is glucocorticoids and cyclophosphamide. Uh, I think this is the one that causes uh, hemorrhagic cystitis, and you solve it with Mesna, right? Hemorrhagic cystitis. Uh, where'd it go? Oh yeah, this is also beads on a string right here, right? That's also where we saw that. Okay, so why do you get this beads on a string effect? It's because first there's inflammation, right? So uh, inflammation causes increased vascular permeability and all that stuff, and cytokines, inflammation, and all that, right? And then it gets resolved and solved and all that stuff, and then there's scarring or fibrosis, right? Or fibrinoid uh, necrosis. Okay, so there's fibrinoid necrosis because of that. So you get that over there and that over here, uh, and in an X-ray, it looks like that, and it looks like a ball, or not X-ray, but a scan. Sorry, right? So it looks like a ball, and that's where the beating appearance comes from. So beating and with normal vessels looks like a string of pearl appearance. Okay, and that's where that comes from. So you need to remember this: different stages of transmural inflammation with fibrinoid necrosis. Okay. Then you have small vessel vasculitis. Uh, okay, so Behet's syndrome, increased incidence in people of Turkish and Eastern Mediterranean descent. Okay, so when you read it, I pronounce it probably wrong, but I pronounce it Behet, so it sounds Middle Eastern and Mediterranean or Turkish. Okay, so Behet syndrome, and then recurrent aphthous ulcers, genital ulcerations, uveitis, erythema nodosum, can be precipitated by uh, HSV or parvovirus. Flares last 1 to 4 weeks. Immune complex vasculitis associated with HLA-B51. You need to remember HLA-B51 for this, and I don't have a mnemonic for this, but you can probably make a story that Behet is a place in Turkey or Eastern, Middle Eastern or something, and their patients have herpes, okay, and or a DNA virus. They both are DNA viruses, so parvovirus or herpes, and flares last around 1 to 4 weeks. Okay, and since everyone has it, everyone having sex with each other, giving them genital ulcerations, uveitis, erythema nodosum, F ulcers. This is just normal ulcers in the mouth. Okay. Either way, come to Ajali B51. So if you take a flight down, it's gonna be in the terminal or gate B, terminal 51, right? Or terminal B, gate 51, right? And it's immune complex vasculitis. It's a small cell vasculitis. Okay. Then you have cutaneous small cell vasculitis or cutaneous small vessel vasculitis. Occurs 7 to 10 days after certain medications, penicillins, cephalosporins, sulfonamides, phenytoin, allopurinol, or infections. For example, HCV and HIV. Okay, palpable purpura. This is a buzzword for two things, so this is one of them. Okay, no visceral environment. Immune complex mediated leukocytic uh, vasculitis. Late involvement indicates systemic vasculitis. Okay. This is an important one too. They test you on this. So it occurs 7 to 10 days after medication. So they'll tell you that as well. That 10 days ago, the person was here for some kind of infection and was administered penicillins or something like that, right? Uh, or has a history of HCV or HIV or something. Okay. uh, and then they started having palpable purpura. So this is a buzzword for this, and Hanlock-Schlein. Hanlock-Schlein. Uh, which one is that? Immunoglobulin A1, right? This one. Okay, so that's it's when you have palpable purpura on the buttocks of a child. Okay, so palpable purpura on buttocks of a child or leg of a child. Over here, it's nothing like that. It could be anyone and anywhere, but there's no visceral involvement. Okay, so immune complex mediated leukocytoclastic vasculitis. Late involvement indicates systemic vasculitis. Okay, so one, you gotta figure out it's a vasculitis, right? Uh, and then you figure out which one it is. And small cell vasculitis. Okay. Okay, so we looked at that, we're on to this one. Okay, what was F? Oh, didn't look at F. Okay, so wait, this is LED. So may develop coronary artery aneurysm, like that. Okay, thrombosis and rupture cause that. Okay, I think I messed up the things, but it looks like that when they show it in the thing, in a scan on a test. So let's look at a few more of those. Okay, so it looks like that, string of pearl, or this, right? This you can just tell that it's pen polyarthris nodosa, so that's what it looks like. Okay, they won't give you something like this, but if they do, you gotta zoom in and then look at those. Okay, over here, this one's a little tough to see, but it has a couple of them. Okay, vasculitis. Small cell vasculitis continued. This is eosinophilic granulomatosis with polyangiitis. Mostly everything you need to know is in the name. Okay. Uh, so eosinophils are, you know, associated with asthma, sinusitis, just asthma actually. Okay. You can have sinusitis, skin nodules, or purpura, peripheral neuropathy for wrist and foot drop, causing wrist and foot drop. Can also involve heart, GI, kidneys, posse-immune glomerulonephritis, formerly called Churg-Strauss syndrome. Okay, uh, these don't help now because they changed it to this, and this is what they will have in the options. They won't say Churg-Strauss anymore. Why? Because he was a German scientist who did experiments and stuff. I think that's the story. Why they changed all these names. Let me just make sure. James Strauss. Oh, Russian. Was a Russian, and together has given name to Strauss, known as this. Okay, so not German, Russian. My bad. Uh, granulomatous necrotizing vasculitis with eosinophilia. Okay. This is what they'll give you: MPO-ANCA or P-ANCA. That's myeloperoxidase. Something, something, something. You need to know what the full form of this is, because they'll give you a full form. They won't say ANCA. Okay, so it's anti-neutrophilic fill on cytoplasmic antibodies. Okay, anti-neutrophilic fill cytoplasmic antibody, or P-ANCA. So both of them, it's important that somehow you remember that MPO ANCA and P ANCA with increase in immunoglobulin E. You already know immunoglobulin E does what? It stimulates eosinophils, right? So that's an easy one. But yeah, so that, and then you come bring it back because it has granulomatous. It is granulomatosis, necrotizing vasculitis. So that's polyangiitis with the eosinophils. Okay. So they'll give you all of this, and you won't remember, or you'll zone it down to this or circle it down to this. But when they give you this is the buzzword, MPO ANCA and P ANCA. This is buzzword for this. Okay. You'll see this again in renal when we are doing nephritis and nephrotic syndromes. Okay, but eosinophil granulomatosis with polyangiitis. So you take out eosinophils, then you have granulomatosis with polyangiitis. Why did we do that? Because the buzzword for this is PR3 ANCA or C ANCA. Okay, and for this you remember it like make a face, right? It was some doctor who was teaching this, who uses this, and that's what dirty medicine was referencing. So you draw that, and then you draw, you know, a person. Okay, and then since this was known as Wegener's granulomatosis, it's not anymore. So back then you would say pronounce it, instead of Wegener's you would pronounce it with Wegener's with a C because of C ANCA. But this still works. Why do you say it like that? Because it goes through the nose, the lungs, and the kidney. If you drew the C, so if you draw a C, it's going through the nose. So now I have to draw the nose, doesn't I? Okay, so draw a nose there. uh, 2 lungs. Hold on. Let's make that the eye, because now I'm into this. Okay. Let's give him a tongue. And 2 lungs and 2 kidneys. Okay, so when you draw a C, it goes through the nose, the lungs, and the kidneys. Okay, the C. I don't know, make it work. I just juxtaposition the lung. Okay, enough time wasting. Back to this. Upper respiratory tract infection, that's what you get. So perforation of nasal septum, not infection, okay. So perforation of nasal septum, chronic sinusitis, otitis media, and mastitis. Okay, so that's why you're up here, upper respiratory tract. And then you have lower respiratory tract, so in the lungs, hemoptysis, cough, dyspnea. And for the renals, you have hematuria or red cell cast. So if you have anything in the questions tab that they're pointing to upper respiratory tract, one of these things and one of these things, lower respiratory tract by telling you that he has a cough or dyspnea, or it's going to be dyspnea usually, and renal, and they tell you that there's blood in urine or red cell cast. Then you remember this photo, you have upper, lower, and this, so it's C, Weckner's, which is granulomatosis with polyangiitis. There are only 2 granulomatosis with polyangiitis. One of them is eosinophilic, and in eosinophilic you would have increase in immunoglobulin E, whereas that's not true for this one, right? And also that one is PNCA, CNCA, MPONCA, and this one is CNCA, right? So triad is focal necrotizing vasculitis, necrotizing granulomas in lung and upper airways, and necrotizing glomerulonephritis in the kidney. Pier 3 ANCA and C ANCA, antiproteinase 3. Chest X-ray is large nodular densities. Treatment is glucocorticoids in combination with rituximab and cyclophosphamide. Right, cyclophosphamide again, hemorrhagic cystitis, you treat it with mesna, and rituximab was monoclonal antibody for CD20. Okay, don't confuse the two, keep it separate. Right, this one it involves the heart, GI, and kidneys, whereas this one involves upper, lower respiratory tract and renals or kidneys. Okay, you have Henlock-Schlein, or also known as Henoch-Schlein, sorry, and immunoglobulin A vasculitis. Okay, most common childhood systemic vasculitis. Hold on, I just want to make sure who this guy is now. I think this is the German one. Name looks German. Nope, nope. What kind of doctor do you see for purpura? Yeah, German doctor. Okay. So that's the German one. So immunoglobulin A vasculitis, the buzzword here is this. They will give you this for sure, because that's how they expect you to understand that it's immunoglobulin A vasculitis. Okay. So most common childhood systemic vasculitis often follows upper respiratory infection, or yeah. Classic triad is hinge pain, so arthralgias, stomach pain, that's abdominal pain associated with intussusception, and palpable purpura on buttocks or legs. Okay, so this is vague. This is vague. right? It's associated with intussusception as well. However, this one is specific to this one, so this is what they will have to give you. Formerly called Henoch-Schlein purpura, vasculitis secondary to immunoglobulin A immune complex deposition. It's associated with IgA, nephropathy, that's Berger disease. This is not the same as this Berger disease. Okay, or if you want to be fancy, Buerger disease. Okay, where was I? Before I went to Buerger disease. Treatment is supportive care and possibly glucocorticoids. Okay, this is usually the one, unless they give you specific ones. Glucocorticoids ever for all the vasculitis. Okay, now if you can't remember anything, go with glucocorticoid. Yeah, so you remember palpulor is for Henoch-Schlein, but then you won't remember its actual name now. So it's immunoglobulin A vasculitis, and that's the thing. That's purpura. Forgot to look at H. This is this and that. Doesn't matter. Not gonna help you. So let's move on to microscopic polyangiitis, necrotizing vasculitis commonly involving lung, kidneys, and skin with pauci-immune glomerulonephritis and palpable purpura. Okay. Hold on. Forgot to add something here. So this is IgA deposition in the artery, right? Over here, the way they will show you in the presentation is going to be they have hematuria, palpable purpura, and arthralgia. Okay, didn't really add much to that then. And it follows URI. That's usually with B19, so parvovirus, or Cas5 and gas. I don't know. I can't read that now. I don't know what I wrote there. But you'll have GI pain, type 3 hypersensitivity. This is type 3 hypersensitivity, right? Because of immune complex deposition. Okay. And on to this now. So necrotizing vasculitis involving lung, kidney, and skin with pauci-immune glomerulonephritis and palpable purpura. Presentation same, they won't give you this because this is reserved for this, the buzzword. Presentation similar to granulomatosis with polyangiitis. Okay, so that's this one, the Weckner's, but without nasopharyngeal involvement. Okay, so lungs and kidney. So no granulomas there. They just told us it's similar to that. MPO-ANCA and P-ANCA. Okay. So heart and what was it? MPO-ANCA is for heart, GI, and that. Never mind. And P-ANCA. So J. That's what it looks like. Good luck with that. Anti-myeloperoxidase. Treatment is cyclophosphamide and glucocorticoids. Okay. They do test you on this, but basically they'll give you all the symptoms of this, but so you'll be expecting C-ANCA, but then you don't get C-ANCA, you get MPO-ANCA or something. So that's when you pick microscopic polyangiitis. Okay. They do test you on it, but I think it's really rare because when they involve something like this with the kidneys, it's usually for nephritis that they're going with. Glomerulonephritis that they're testing you. For vasculitis, they'll test you on these three, and these two, usually. Okay, mixed cryoglobulinemia, often due to viral infection, especially HCV. Okay, triad of palpable purpura, weakness, and arthralgia. May also have peripheral neuropathy and renal disease, for example, glomerulonephritis. So, cryoglobulinemia, HCV, and cryoglobulins are immunoglobulins that precipitate in the cold. Vasculitis due to mixed immunoglobulin G and IgM immune complex deposition. Okay, so cryoglobulins are immunoglobulins that precipitate in the cold, right? Vasculitis mixed with IgG, IgM, and immune complex deposition. So if it's a vasculitis and they tell you it's HCV, then remember C is for cryoglobulinemia mixed. And you'll see palpable purpura, weakness, arthralgia. Not really helpful because this is similar to this, so they won't give you that. I don't think they test you on this either, unless they tell you that there's Raynaud's when he's out in cold or something like that. Then that's when you think of this. Okay. Onto this. Let's take a break and then we'll continue from there. So, neuromuscular junction diseases. Neuromuscular junction diseases with myasthenia gravis and Lambert-Eaton myasthenic syndrome. So let's do myasthenia gravis first. Frequency is most common NMJ disorder, neuromuscular junction disorder. Pathophysiology is that there are autoantibodies to postsynaptic acetylcholine receptors, right? So you have acetylcholine receptors right here, right? This is the muscle and this is the postsynaptic neuron. So calcium comes in, activates the release of acetylcholine vesicles to release acetylcholine into the presynaptic cleft, and then or postsynaptic cleft, and then attached to the receptors. So if you have antibodies against the acetylcholine receptors, what do you get? You don't get the attachment of acetylcholine to the receptor, leaving the acetylcholine out there in the cleft. Okay. Clinical, what you will see is there will be fatigue, right? Fatigable muscle weakness, ptosis, diplopia, proximal weakness, respiratory muscle involvement, dyspnea, bulbar muscle involvement, dysphagia, difficulty chewing. Okay, the buzzword here is drooping of eyelids. Okay, because normally at the end of the day, or it could be during the day too, the eyelid is drooping because they're getting fatigued, right? Okay. So dysphagia, difficult chewing. They can give you any of these, but usually the buzzword is drooping of eyelid. Okay. Myasthenia gravis. Okay, so like that, or like that, right? Okay. It's associated. It's associated with thymoma and thymic hyperplasia. Uh, this is important. They'll give you symptoms of that. But usually, if they just give you that there's drooping of eyelid, it's gonna be this. Acetylcholine esterase inhibitor administration. This reverses the symptoms, like pyridostigmine for treatment. Okay. So when you give acetylcholine esterases, right? So since you have so much acetylcholine in the cleft, all the acetylcholine esterases are going to get used up. So if you give more, it can take care of the excess acetylcholine, right? So you won't get the symptoms associated with that. Wait, no, sorry. I got that wrong. So if you have acetylcholine esterase, it kills off that, right? Acetylcholine. But now there's a competitive inhibitor, the antibodies. So how do you overcome the antibodies? You give more acetylcholine, right? So you prevent the breakdown of acetylcholine by giving inhibitors of the breakers, or acetylcholine esterase inhibitors. Okay, so that will leave more acetylcholine. So that will uh, that will end up competitively uh, going for the receptor against the antibodies, and that's why you get improvement with that. Okay, there is Lambert-Eaton myasthenic syndrome. This is pretty uncommon. It's the antibodies to presynaptic uh, calcium channel, which leads to a decrease in acetylcholine release. So L comes before M. You don't need to know that if you just remember this. Or there's Eaton Center in Canada, in Toronto, and Toronto's in Canada, so calcium channel, if you want to remember it that way. But you do you. Okay, so a decrease in calcium channel. So what happens is there's antibody against this, right? So what calcium normally comes in and activates this, right? Uh, the release of acetylcholine into the cleft. But if there's antibodies against the calcium channel, calcium cannot come in and depolarize this and uh, cause this release, right? So that's not going to happen. So that's why it's called myasthenic syndrome. So the clinical symptoms are proximal muscle weakness, anatomic symptoms, dry mouth, constipation, and impotence. Okay. Hyporeflexia, and improves with muscle use. Okay, so this is what they'll give you in the question stem, that they have been they're usually tired in the morning, but at the end of the day they feel better. uh, it's because of the release of calcium that has accumulated inside, that's able to release acetylcholine at the end of the day, because calcium, even though they're antibodies, there's a lot of calcium as well, so it competitively, or it just comes in basically a little bit, and at the end of the day it accumulates inside, so it's able to do its action when it's depolarized. uh, yeah, and over here it's worse with muscle use, so they're better in the day, during the morning. Here they're better during the night. Okay, that's the difference between the two. This one was associated with thymoma, this one's associated with small cell lung cancer. And if you give ACE inhibitors, acetylcholinesterase inhibitors, it's not gonna have much effect to it, right? So minimal effect because of that. Uh, Another thing you need to know about is botulinum. That has a similar. It's over here, right? So what that one does is it inhibits snare. It cleaves the snare protein. So you have little things that are called the snare proteins here. Okay, so they go and attach to this, and when they attach to this, that's how you get the release of acetylcholine out, right? But what snare proteins do is they come in, you know sorry, botulinum toxins do, they come in and they cleave this. Okay, and when they cleave this, then snare protein can attach to these vesicles, and that doesn't happen, the acetylcholine will not be released. Okay, and that's how you get botulinum, or botulinum tox syndrome, or and that's how Botox works as well, right? Okay. uh Review: Lambert-Eaton syndrome was is pre acts antibodies are against presynaptic calcium. This is, however, you need to know this, that is type 2 hypersensitivity reaction, right? Antibody antigen reaction. So both of them are type 2 hypersensitivity reactions. This one's associated with small cell lung cancer. This one is postsynaptic acetylcholine receptor antibody against that, type 2 hypersensitive reaction, and thymoma. And botulinum is it affects the release of acetylcholine. It is heat labile enterotoxin, and in babies it's usually because of contaminated honey, and in adults it's because of contaminated canned foods. Okay. Raynaud's, it's decrease in blood vessels to skin due to arteriolar small vessel vasospasm in response to cold or stress. Color change from white ischemia to blue, which is hypoxia. Okay, so you see blue over there. Okay, so white is ischemia and blue is hypoxia, to red, which is reperfusion. Most often in fingers and toes, it's called Raynaud's disease. When primary idiopathic, Raynaud's syndrome with uh, idiopathic. Raynaud's syndrome when secondary to a disease process such as mixed connective tissue disease like SLE or CREST. Uh, so remember CREST, C for calcinosis, R was for Raynaud's, E was for esophageal dysmotility, S was for sclerodactyly, and T for telangiectasia. Okay. It's limited form of systemic sclerosis. Digital ulceration, critical ischemia seen in secondary Raynaud's syndrome, treat with calcium channel blockers. This is important. So what happens is when they go into the thing, the small vessels, they vasospasm due to the cold. Okay. And when they vasospasm, the blood is not able to carry forward, and that causes ischemia. And if it lasts longer, then ischemia turns into cyanosis. Okay, like that. So if they reheat it like under hot water, or like just they're in a warm environment, it gets reperfused then. Okay, and this is associated with SLE and CREST syndrome. If it's primary, it's idiopathic, so they're not going to test you with that. Again, idiopathic is, you have to rule everything else out before you pick idiopathic reason, right? So they're going to test you with SLE or CREST syndrome. With CREST, it's systemic sclerosis that they usually test you with. So what is systemic sclerosis? Let's read it. Scleroderma, systemic sclerosis. That's what it's called. It's thickening. Usually the buzzword is thickening of stuff. Okay. So triad of autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. Okay, so when you have collagen deposition with fibrosis, anywhere where you have collagen, it's going to be thickening because of fibrosis, right? So commonly sclerosis of skin, manifesting as puffy, taut skin, right? And that's what they'll give you. Without wrinkles and fingertip pitting, they'll give you that as well. Can involve other systems, for example, renal, scleroderma, renal crisis. Treat with ACE inhibitors, pulmonary, interstitial fibrosis, pulmonary hypertension, GI and decrease in peristalsis and LES tone, dysphagia and heartburn. So this is where you get the esophageal dysmotility from, right? Cardiovascular as well. 75% female, or two major types. Okay. So there are two major types. One of them is CREST syndrome, and the other one is diffuse scleroderma. So in diffuse scleroderma, you have widespread skin involvement, rapid progression, early visceral involvement, associated with anti-SCL for scleroderma, 70 antibody. This is important to know, but so is this. So you need to know both of these are positive markers for diffuse scleroderma. Okay, anti-DNA topoisomerase 1 antibody. Remember topoisomerase 1 inhibitors, what they were called? It was at the ones that had CAN in it, right? And topoisomerase 2 had sites in it. That's what it ended with. Okay. And what does it do? It cleaves the DNA and avoids getting supercoiling and all that stuff. So associated with anti-SCL70 antibodies and anti-DNA topoisomerase 1 antibody and anti-RNA polymerase 3. Okay, need to know that too. And then there's limited scleroderma. This is limited skin involvement confined to finger and face. Okay, so only to finger and face. Also with CREST syndrome, that's calcinosis, anti-centromere antibody, okay, and Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. It's more benign clinical course. Okay, I guess you need to know this to differentiate from here. Okay, because this one was anti-SCL70 and this is anti-centromere antibody. Okay, calcinosis cutis, that's this. Let's look at a few more pictures of that. Okay, that, and let's do systemic sclerosis. Okay, so these are the type of things you'll see. Yeah, they'll show you a photo like this, and this is a classic presentation of sclerosis. Okay. Scleroderma, you need to know what, if you see something like this, and this is usually what they, a similar picture will be shown in like steps as well. That's what they use. So fingers like this and it's all red, it's gonna be scleroderma. Okay, and then they'll ask you about either this or any of this, or you know, something. Yeah, it's usually just that or that, but you have to figure out that it's scleroderma for that. Or they'll give you photos and all the symptoms, and then they ask you what is it. So you need to know it's either scleroderma, or they'll ask you to differentiate between diffuse and limited. Okay, and we're done with musk. On to skin. For this, I do have a mnemonic for the layers, because corny is also known as the horny layer. Okay, so horny and lucid grandma spins when she hears the bass. Right. Okay. What is it? Yeah, I'll do that later. Or you can just, memorize it. It's not that hard. It's corneum is also known as the horny layer. So corneum or horny, you need to know that to understand this. So horny and lucid, that's lucidum. Grandma, that's granulosum. And spins, that's spinosum. And when she hears the bass, for basal. Okay, so skin layers. Skin has 3 layers: epidermis, dermis, and subcutaneous fat. Hypodermis and subcutis. Epidermal layers. I don't like that, so I use mine. You don't need to know this. They don't test you on this. This is like just so you understand when they describe something in which layer it is and which layer gets affected. So that's why you would need to know this, but they won't test you on it. Okay, so the first layer is corneum, second layer is lucidum. Okay, so that layer, or you see striated right there. Granulosum is right there. Okay, little fatter cells. And then this is spinosum, you see dots. Okay, and then basal is the basement membrane. Okay, and then this is the dermis. Okay, for this, let's go through it, and then I have notes on this as well, so we'll look at that. Epithelial cell junction. Okay, so apical and basal, that's what that is. So for tight junctions, zonula occludens, or that right there. Okay, so you have claudin and occludin. It prevents paracellular. Actually, hold on, let me get the thing out. Download something. Okay, just keep that here. Okay. So tight junction, occlude and claudicate for blood-brain barrier. Okay. That's what you need to remember about tight junction. So these are the things that you need to know. So that's why I made the notes on it. So let's see, gap junction, a chemical connection between the gap, electrical. Okay, so chemical or electrical gap connection between the gap. Seen in CVS and bone, the gap has all kinds of chemical and electrical connections. Okay, so important thing here, tight junctions, zonula occludens. It has claudin and occludin. Okay, what do? They prevent paracellular movement of solutes. So you have solutes, okay, like Na, they prevent movement of those. It's composed of these two, claudin and occludin. They occlude the movement of solutes. And it's basically for blood-brain barrier. That's what it's used in. Majority of the time, that's what they'll use it for. I think it's also in the spinal cord, but it's definitely in BBB. Okay, adherence junction, belt desmosome, and zonular adherence. Okay, so this is the adherence. That's what it looks like, or it's right here in the layer below that one. Okay, so adherent junction is belt desmosome and zonular adherence. It has the adherent in the name, forms the belt, and that's in the name as well, belt desmosome. Belt connecting actin cytoskeleton of adjacent cells with cadherins, right? So cadherins has Ca in it and D, so that's for calcium dependent and adhesion proteins. So this is like the buzzword for that, and they'll give you that in the question stem, and that gives it away that they're talking about the adherent junction. Loss of E-cadherin promotes metastasis. So when you don't have this, there is rampant proliferation, and it goes through the basement membrane, right? Remember when we did the melanoma, what was it? Yeah, this one. So this thing right here, it goes through because of it spreads through because of yeah, right there. Okay, so invasive carcinoma, okay, so right here, this is what I'm talking about. So this is step 4. So right here, until now it was in the basement membrane, but now it's gone to cells have invaded the basement membrane using collagenases and hydrolysis, which are called metalloproteinases. And then the cell-cell contact is lost by inactivation of E-cadherin, right? So E-cadherin is gone now. So that's why there is, the cells are going downwards, and then they're gonna go in attached to the vessels, and then you have hematogenous spread from that, and that's called metagenesis, right? Okay, back to 486. Okay. Okay, what do I have for adherence? It anchors adjacent cells together with cytoskeleton. It's composed of ecadrin and actin, so that's important. Okay, I need some what intermediate support. I don't remember what that was for. I think it's probably something to do with that. But okay, so you need to, for adherent junction, you need to know ecadrin and actin, right? So there, and it helps connect actin cytoskeleton and adjacent cells through calcium dependent adhesion proteins. Desmosome is important, and so is hemidesmosome, so is gap junction. Okay, but why this? It's because it's involved in bullous vulgaris and the other one that we'll do in patho of this. Okay. Okay, so desmosome, it's right here. It has intermediate fiber filaments, and that's what that looks like under electron microscope. Okay. Spot desmosome, macular adherence. Okay, so that it looks like a spot. Structural support via intermediate filament interactions. Autoantibodies to, oh, there we go. So it was pemphigus vulgaris. So autoantibodies to desmoglin 1 and or 3. It leads to pemphigus vulgaris and bullous pemphigoid for hemidesmosome. Okay. So desmosome is pemphigus vulgaris and it's autoantibodies to desmoglin 1 and or 3. You need to know that. Okay, let's see what I have that for. Okay. Desmosome provides structural support via intermediate filaments. We saw that over here. It's composed of cytokeratin and desmoplankton. This is what they will give you when they're describing in the question stem that there's the sample is positive for cytokeratin or desmoplankton. I guess I don't know what was that. It's not in here. Okay. Pemphigus. It's similar to bullous, but yes, to Nikolsky sign. That's when you brush against the skin and it comes off. Okay, that's what Nikolsky sign is. We'll do that when we're doing vulgaris. And immunoglobulin G versus desmoglin. Okay, so and against the desmoglin, right? So it's antibodies. So immunoglobulin G against desmoglin, type 1 or 3. Okay. Need to know that. Mostly they're gonna question your knowledge against, if you know the difference between desmosomes and hemidesmosome when they're talking about these. So leads to pemphigus vulgaris or DP. Okay, gap junction. Next, right here, it's connection. What I have here is a chemical connection or a chemical or electrical connection between the gap. Okay, I remember that. So a channel proteins called connection permits electrical and chemical communication between cells. That's it. Then you have hemidesmosomes. It connects keratin in basal cells to underlying basement membrane. Okay, the autoantibodies will lead to bullous pemphigoid. Hemidesmosomes are down, so below, so bullous. That's how you need to remember. Bullous pemphigoid is for hemidesmosome. Pemphigus vulgaris is because of desmosomes. And what I have for that? It provides structural support via intermediate filament. Okay. That's similar to this one, right? This one also had intermediate filament. This one too. Connects keratin and basement membrane. Bullous pemphigoid is hemidesmosome type 2 hypersensitive reaction. That's antigen antibody reaction. And the antibodies or IgG are against hemidesmosomes. There's no Nikolsky sign here, and that's how you differentiate between these two if they don't give you anything else. Nikolsky sign is, we'll do that in the thing as well, but yeah, okay. Let me just show you what that is. When you brush it against the skin, right? So the skin comes off, that's called Nikolsky sign. Okay, you brush it off like that, or I guess they're not brushing it, they're just pointing to it. Okay, and then last we have integrants. Okay, so these are the integrants. You have fibronectin, laminin, and ECM collagen, and that's hemidesmosome though. Okay, so hemidesmosome, it's a membrane proteins that maintain uh, integrity of basolateral membrane by binding to collagen, laminin, and fibronectin in basement membrane. Okay. So membrane protein that maintains the integrity of basement membrane by binding to anything it can. So collagen, it'll bind to laminin, it'll bind to fibronectin in the basement membrane. Okay. Yeah, cool. Next. You need to know about this tight junction. That it's in blood-brain barrier, so that's where it'll pop up. Gap junction, you need to know what it transfers. This one occludes, and this one has a connection. Adherence, it's calcium dependent adhesion proteins, cytoskeleton and cadherence, right? And the most important one is that loss of it can promote metastasis. Okay. Then yeah, these two will look at it in patho anyways, so it's okay. Gap junction did it. Integrin, not important, but in case they ask, you should know what they do. They just anchor it to the basement membrane, right? And they bind to collagen, laminin, and fibronectin in the basement membrane. Okay. Next, exocrine glands. Glands that produce substance other than hormones versus endocrine glands, which secrete hormones. Okay. So exocrine secretes anything other than hormones, whereas endocrine would secrete only hormones that are released through ducts to the exterior of the body. Can be merocrine, for example, salivary or sweat glands, or epocrine, like mammary glands, or holocrine, that's sebaceous gland. Okay, I think that's a new topic they added. Yeah, they added that. So, secretory is salivary sweat glands, epocrine is mammary glands, and holocrine is sebaceous gland. Okay, oil, milk, water, right? Merocrine is water, epo is milk, and holocrine is oil. Dermatologic microscopic items. So lesion characteristics and examples. Macules are that. Where else did you see macules? Remember, huge spigger or whatever. Let me do that. We'll go. Actually, I'll just show you a photo here. Here. I don't know how you spell it. Apparently, it's so bad that Google can't figure it out either.
What are you trying to spell?
The huge, the stomach cancer.
Puke Jager?
Yes, that one. Yes.
It's P-U-P-E-U.
Yes.
You. I don't even know how to spell it. But it's
Okay.
with a J. It's Puce,
Is
and then the other is Jaeger.
oh yeah, yeah, yeah.
Jaeger
Let's see if
syndrome.
that comes up. Nope. Okay, I'll
I
find
know
it.
what you're talking about.
Uh, so it's
It's
gonna come.
PEU, easy.
Okay, thank you. Yes, there you go. Thank you. So that's where you see the macules. Thank you guys. Group effort. So Pusager right there. Okay. That's where you would see a macule. Okay. So it's flat lesions with well circumscribed change in skin color less than 1 centimeter, freckles, and labial macule. Okay. Patch is gonna be more than 1 centimeters, large birthmark. Usually that's not gonna show up. Papule does show up. It's gonna be elevated solid skin lesions less than 1 centimeter, also known as mole or nevus. Uh, and acne, right? Benign one is uh, called mole, and when it's malignant, it's called melanoma, right? Papule, wait, no, I think I'm wrong about that. Or was it? If mole gets malignant, it does cause some kind of cancer. I can't recall right now. Plaque is papule, and it's seen in psoriasis. Vesicle, this will show up, so you need to know that it's because of a plaque, but usually they tell you it's like a silvery sand kind of thing. Vesicle, small fluid containing blisters. So chickenpox, varicella, or shingles zoster. Uh, these are herpes simplex virus type 3. Bulla is large fluid containing blister that's more than 1 centimeter. So bullous pemphigoid, so that's F. Um, Partial is vesicle containing pus. Particular psoriasis, right? Veal is transient smooth papule or plaque. Hives, right? Scale. Yeah, this will show up for hives, uh, like that. And when that shows up, you need to differentiate between contact dermatitis and uh, dermatitis, like as in other rashes. Okay. The easiest way to figure it out for me is actually it has a classic presentation for let's see, poison ivy. It's gonna have a linear rash like that, okay, or like that, or like that. So if you have a linear rash, that's because of contact dermatitis. Because usually you have to differentiate it between type 4 and type 1, right, when it comes to allergies. So type 1, it's when you use a EpiPen. So anything you would use an EpiPen for is type 1, and you're not going to use EpiPen for poison ivy, so that's type 4. That works as well if you get in confusion. So that works. Scale is flaking off of striatum corneum, eczema, psoriasis, and small cell carcinoma. Okay. Eczema is important for what? It's for water. So water was for wasp gene, right? And thrombocytopenia, eczema, and recurrent infections. So that was Viscott Eldridge. That's the one. Westcott-Eldridge one. So eczema is important for that. You'll see it there. Crust is dry exudate and impetigo. Impetigo is important for honey crusted lesion. That's called impetigo. It's in let's see which one that was. It's in strep, right? Or staph. I think it's strep. Yeah, streptococcus. That's where you see it. Honey crusted lesions. Okay. So when they say that, I'll just show you what it looks like too. So it's going to be around the mouth, and that's what it looks like. It looks like honey colored and crusted lesions. Okay. I think, and usually the pictures, if you want to see it, they usually have the ones that are in Wikipedia. The ones that they use are the ones that they use in the questions, in question banks, QMix. Okay. Dermatologic macroscopic terms, lesions, characteristics, and examples. Disc keratosis, that's abnormal premature keratinization, that's in squamous cell carcinoma. Classic presentation of squamous cell carcinoma is what? Keratin pearls, right? So see keratin pearls in squamous cell carcinoma. Okay, another fact about that is that when you have carcinoma in the esophagus, it's not going to be squamous cell, it's going to be adenocarcinoma. That's the most popular one, unless they give you that there's a presence of keratin pearl or keratin or something like that, then you pick squamous cell. Hyperkeratosis, increase in thickness of stratum corneum, that's the horny layer. So psoriasis or calluses. Parakeratosis, retention of nuclei and stratum corneum, again, horny layer. Psoriasis and actinokeratosis, we'll learn about these. Hypergranulosis, that's increase in thickness of stratum granulosum, that's the granma layer. Where'd it go? Whoops, too far. Right there, so granma layer was the third one. And lichen planus happens over there. Spongiosis, eczema, eczematis, dermatitis. That's where it happens. So you'll see epidermal accumulation of edematous fluid in intracellular spaces. Okay. Acantholysis. This is separation of epidermal cells. So pemphigus vulgaris. And then you have acanthosis. This is epidermal hyperplasia, increase in spinosum. So horny and lucid granma spin. So that's the fourth layer. Acanthosis nigricans and psoriasis. Okay. Okay. This one actually forgot. This one is like seen in diabetes. Okay. Pigment and skin disorders, albinism. Normal melanocytes number with decrease in melanin production. So for this, actually, let me show you the tyrosine one as well. So right here is the one I'm talking about. Let's go back to 488. Okay. So albinism happens normal melanocyte numbers with decrease in melanin production, right? So this is melanin. So tyrosine deficiency of that will cause albinism, right? So it comes from tyrosine with biopterin, hydrobiopterin or BH4 will convert it to dopa, and then dopa converts it to melanin, and with the help of tyrosinase. So deficiency of that will cause albinism. Okay, keep that to the side. Due to decrease in tyrosinase activity or defective tyrosine transport, increase in risk of skin cancer. Okay. Then you have melasma or cholesma. That's acquired hyperpigmentation associated with pregnancy. Uh, so let's see what that looks like. Mask of pregnancy, or that right there. Okay. Or OCPUs, more common in patients with darker skin tones. Let's quickly look at what some other pictures of that. Okay, so looks like kind of like sunspots, but darker and more. Okay. More common in patients with darker skin tones. Vitiligo, that's these things. It's irregular patches of complete depigmentation. It's because of autoimmune disease. It's an autoimmune disease, vitiligo. Okay, so irregular patches of complete depigmentation caused by destruction of melanocytes. Uh, uh, Believed to be autoimmune. Okay, yeah, don't need that. Associated with other autoimmune disorders. Okay, so antibodies against melanocytes causes vitiligo, and they will probably explain it this way in the question stem, that there are irregular patches of complete depigmentation. So that should hint you to vitiligo. There's Waardenburg syndrome. This is patchy depigmentation of skin, hair, and irises that can be associated with deafness, caused by defects in the differentiation of neural crest cells into melanocytes. Okay, so Waardenburg. Uh, Again, patchy depigmentation. Okay, kind of sounds like this one as well, doesn't it? But this one is for skin, hair, and irises as well. So let's see what that looks like. For this one, they usually show you, yeah, so it's the one from, what's her name, from Cruella. The Cruella has this, right, from Disney. They'll show you eyelid or eyelashes, and it's gonna be, yeah, like that. And it's gonna be white, and they're gonna ask you what kind is it. So that's Waardenburg syndrome. Uh, yeah. Okay, seborrheic dermatitis, erythematose, well demarcated legs, with greasy yellow scales in areas rich in sebaceous glands, such as scalp, face, and periauricle ocular region. Sorry. Common in both infants, cradle cap, and adults. Associated with Parkinson's disease, sebaceous glands are not inflamed, but play a role in disease development, possibly associated with Malassezia species. Okay, let's look at a few more photos of that. Okay, so like that. This is the thing that they probably show you. It's gonna be under a scalp, right? It's uh, kind of like dandruff, but hardcore, right? So it's erythematous, well demarcated plaques with greasy yellow scales in areas rich in sebaceous glands such as scalp, face, and periauricle region, common in both adults and infants, and it's associated with Parkinson's disease. They're not inflamed, okay, but may play a role in disease development. It's possibly associated with this. Right? Uh, so all you have to do is use topical antifungal and glucocorticoids with that. Common skin disorders, acne. Uh, so multifactorial etiologies. So increase in sebum, androgen production, abnormal keratinocyte desquamation, Cutibacterium acnes, colonization of the pilosebaceous unit or comedones, and inflammation or papules, pastules, nodules, and cysts. You'll probably figure out if it's this, that it's acne. Uh, what they will ask you is the treatment for it. So it's going to be retinoids, benzoyl peroxide, and antibiotics. So when we were doing vitamin A, I told you about this, and isotretinoin. For isotretinoin, you need to do pregnancy test before you can prescribe it because it is a teratogen, or right. So, or you can just use retinol as a skincare routine to get rid of acne. Atopic dermatitis, eczema, type 1 hypersensitivity reaction, pruritic eruption, commonly on skin flexures, associated with other ectopic disease. So if they're gonna give you eczema, they're usually hinting towards something of this nature, not the other way around. They're not going to give you any of this and then ask you what it is, right? Okay, so it's type 1 hypersensitivity reaction, right? So you would use EpiPen for these. You use a pump for this, right? Pruritic eruption, common on skin flexures, uh, associated with other atopic disease. So there will be obviously increase in serum immunoglobulin E. Remember, it's involved in cross-linking, uh, and cross-linking causes degranulation and of mast cells. Mutations in filaggrin gene predisposes via skin barrier dysfunction, often appears on face in infancy. Uh, so let's bring these up here. Okay. So acne, we know that. Uh, so eczema is like that or like this. Okay. Let's look at a few more pictures of that. Okay, so that's eczema. Okay, that's eczema. Eczema. Okay. So what you saw was pruritic eruption, especially on skin flexures. So these are the skin flexures, like the knuckles, the lines in your fingers and knuckles. Okay. If you have like we call it stretch marks, it can happen there. Okay, or ankles again. Cool. Okay, that predisposes via skin barrier dysfunction. So you need to know this mutation in filaggrin gene. This is the pathogenesis of this, right? So that's what they're gonna go after, or they can go after this, but this one's too easy, so they won't test you on that. Okay. If they say it's a rash in antecubital fossa, they're talking about eczema. No, you won't have any other rashes there. Allergic contact dermatitis. This is type 4 hypersensitivity reaction, right? To contact with allergens like nickel or poison ivy or neomycin. Okay, so that's D right there, or neomycin E, like that. Here you don't see the linear pattern, right? But in this one you actually do. Let's see if we see it in nickel. So you can see like it's a little bit of line there, right? And if you were to, these are not nickel allergies. Okay. So see how you can see a line over there? It's like you can make out the border of it, right? So something like that. If you can figure out the borders or it's a linear pattern or something, it's going to be type 4, so hypersensitivity is what I mean. They're not going to test you on this one, they'll test you on these two. Melanocyte nevis. This is common mole. It's benign, but melanoma. Yeah, so I was right. It's melanoma if it goes malignant. Okay, so but melanoma can arise in congenital or atypical moles. Okay, so intradermal nevi are papular and F. Okay, so like that. Junctional nevi are flat macules. Okay, so junctional ones are flat, and papular ones are, intradermal. They'll test you on that, the difference. That they'll tell you that it's a benign melanocytic mole or something. However, uh, it's flat or papular, so which layer of the skin is it in or something like that, right? So intradermal if it's papular, and it's in the junctional if it's flat. Pseudofolliculitis barbae, so I guess it comes from barber, so something to do with haircuts. Foreign body inflammatory facial skin disorder characterized by firm, hyperpigmented papules and pustules that are painful and pruritic. Located on cheeks, jawline, and neck, commonly occurs as a result of shaving, primarily affects black males. Right, so this is when they go clean shave, many black men can't do that because they'll end up with this, uh, like that, and it's painful. Or yeah, this is more like it, right? So they usually go trimming, or just grow out the beard. Okay, it's called pseudofolliculitis barbae. Okay, it's called the razor bumps. Uh, that's what you see. So they're painful and pruritic. Okay, it's a foreign body, inflammatory facial skin, whatever. There's psoriasis. So psoriasis is H and I. Okay. Papules and plaques with silvery scaling. Let's see how much time I have. 7 minutes. I think we can make it. Papules and plaques with silvery scaling, right? So that's what I was talking about. They'll give you that if they want you to uh, guess that is psoriasis. Especially on knees and elbows. Okay, so you'll have silvery scaling, buzzword, on knees and elbow. Acanthosis with parakeratotic scaling. Nuclei still in stratum corneum. That's the first layer, right? Horny layer. Monroe microabscesses. Increase in stratum spinosum. Uh, okay, that's the fourth layer, and this is the third layer. Decrease in stratum granulosum. So once again, increase in stratum spinosum, decrease in stratum granulosum. Okay. Auspitz sign, that's pinpoint bleeding spots from exposure of dermal papillae when scales are scraped off. It's associated with nail pitting and psoriatic arthritis. Uh, you need to know what this is. Auspitz sign, that's pinpoint bleeding, right? So let's quickly look at what that is. Okay, so if you were to scrape this off, it's gonna bleed. Okay, so like that. Okay, so pinpoint bleeding spot from exposure of dermal papillae when scales are scraped off. Okay, that's if you scratch it, it's gonna bleed. It's called Auspitz signs. It happens in psoriasis. Psoriasis is silvery scaling plaques with silvery scaling, right? Let's look at a photo of that because they test you on all this. Okay, that's a silvery scaling. They might give you a photo of this. and then expect you to know that it's psoriasis. Okay. Rosacea, that's inflammatory facial skin disorder characterized by erythematous plaques and pustules, but no comedones. Okay, what are comedones? Technical term for blackheads. Okay. May be associated with facial flushing and response to external stimuli, for example, alcohol, heat. Complications include ocular involvement, rhinophyma, and bulbous deformation of nose. Okay, so J right there. Okay, so yeah, that. Seborrheic keratosis, this is important. They test you on that. It's flat, greasy, pigmented, squamous epithelium, epithelial proliferation of immature keratinocytes with keratin-filled cysts. Okay, that's important to know what it's made up of. It's keratin-filled cyst or horn cysts. Looks stuck on, right? It looks like a mole, but it's not a mole because mole is not black, like we read for this, right? That's what it is. Uh, so looks stuck on. If it's dried off, and you can actually just scratch it off actually if it's dried off. So looks stuck on. Lesions occurs on head, trunk, and extremities. Common benign neoplasm of older people or older persons. Lesser Trillette sign. This is L. Rapid onset of multiple seborrheic keratosis indicates possible malignancy. For example, GI adenocarcinoma. Right. If you have a gastric cancer, that's what this sign is. So a person is okay, he doesn't have any of these, but like 3 days later, when he takes off his shirt, he notices all these moles and gets freaked out. It's a sign of gastric cancer, and it's usually seen with a Virchow node, right? Subclavicular lymph node, lymphadenopathy over there, or enlargement of that lymph node on the left side, not the right, because left one is the one that drains the abdomen, and right one only drains the thorax on the right side. Okay. Vercu. I have 2 minutes. Warts caused by low risk HPV strains. Those are all the strains other than 16 and 18. Those are the cancer ones, right? Soft tan colored cauliflower like papule, epidermal hyperplasia, hyperkeratosis, choleocytosis. That's sign of cervical cancer. Condyloma echinometum on anus and genitals. You should Google it during the break. Urticaria is hives, periodic wheals that form after mast cell degranulation, characterized by superficial dermal edema and lymphatic channel dilation. This is just, itchiness, basically. But it's periodic wheal and degranulation, so that's what it looks like. And we made it. I'll see you. So that's papilloma, by the way, right? That's what you see. M was cauliflower-like papules. I'll see you in 10 to 15. Okay, vascular tumors of skin, angiosarcoma. So vascular is everything to do with vessels and more specifically capillaries. So tumors of the capillaries, uh, involvement or whatever. Okay, so angiosarcoma. Um, Angio is vessels, right? And sarcoma, so cancer of vessels or rare blood vessel malignancy, typically occurring in the head, neck, and breast area, usually in other older adults on sun-exposed areas. Okay, associated with radiation therapy and chronic post-mastectomy lymphedema. Stewart-Travis syndrome. This is cutaneous angiosarcoma developing after chronic lymphedema. Okay. Hepatic angiosarcoma associated with vinyl chloride and arsenic exposure. Okay, so hepatic angiosarcoma, if it's this, very aggressive and difficult to resect due to delay in diagnosis. Okay, that. Bacillary angiomatosis, benign capillary skin papules found in patients with AIDS. This is an important one. It's associated with Bartonella infection. That's the one that causes cat scratch disease, right? Caused by Bartonella infections, frequently mistaken for Kaposi sarcoma. Okay, that's so we'll look at this and that as well. Frequently mistaken for Kaposi sarcoma, but has neutrophilic infiltrates. So let's look at that. Uh, that's what it looks like. And yeah, so like that. Whereas sarcoma is like that. Okay. This is a darker color, and this is more red, right? Okay. Then you have cherry hemangioma. It's benign capillary hemangioma, commonly appearing in middle-aged adults. It does not regress, and it frequently increases with age. Okay, so that's this one. Let's see a few more pictures of that. Okay, so like that. Okay. Okay, so cherry hemangioma. Uh, glomus tumor. It's benign, painful red-blue tumor, commonly under fingernails. That's where they'll bring it up if they do. Arises from modified smooth muscle cells of the thermoregulator glomus body. Okay, Kaposi sarcoma. It's endothelial malignancy, most commonly affecting the skin, mouth, and GI tract and respiratory tract. Classically seen in older Eastern European males, patients with AIDS, and organ transplant patients associated with herpes type 8 and HIV. Lymphocytic infiltrate, unlike bacillary angiomatosis. So it has a lymphocytic infiltrate, whereas this has a neutrophilic infiltrate. Okay, that's the difference between the two, and that's how you differentiate between these two. So you need to know about that. If it's neutrophilic infiltrate, it's going to be bacillary angiomatosis. If it's lymphocytic, it's going to be Kaposi sarcoma. Okay, let's see again one more time. Okay, it's a little darker than the other one on the skin, like that, right? Okay, pyogenic granuloma. The important thing is that it's during AIDS, like when patients are there with AIDS and who have had herpes before, or type 8 can infect them. So it's usually going to be someone with a immunocompromised condition who have Kaposi sarcoma. Uh, and similarly for this as well, I guess, because that's how you get Bartonella infection as well. Okay, pyogenic granuloma, polyploid lobulated capillary hemangioma. Okay, that can ulcerate and bleed, associated with trauma and pregnancy. Trauma and pregnancy. Let's see. Okay. Okay, this one's also on the face. That one's on the face. That one's on the face. Okay, on the lips. Okay. So pyogenic granuloma, it's polyploid lobulated capillary hemangioma that can ulcerate and bleed, associated with trauma and pregnancy. So it's pyogenic. Okay. And then you have strawberry or infantile hemangioma. This is an easy one to figure out. If it's an infant and there's some kind of thing like that, it's going to be this infantile hemangioma. It's a benign capillary hemangioma of infancy. It appears in first few weeks of life, 1 in 200 births, grows rapidly and regresses spontaneously at 5 or 8 years old. Okay. Oh, that was so cute. Babies are cute. Okay. Done with that. Skin infections. So we just did vascular tumors, and now we're doing skin infections. Bacterial infections, right? Impetigo. This is skin infection involving superficial epidermis, usually from S. aureus or Streptococcus pyogenes. Okay. Highly contagious honey-colored crusting. So that's what it looks like. Let's bring that up. Okay, we already looked at photos of impetigo. Bullous impetigo, this has bulla and is usually caused by S. aureus. Right, so S. aureus is on the skin anyways, so if you have a bulla there, it's S. aureus. Erypsila, that's infection involving upper dermis and superficial lymphatics, usually from S. pyogenes. Uh, presents with well-defined raised demarcation between infected and normal skin. Okay. See a little more of that. Okay. That looks like a cellulitis. Uh, okay. So infection involving upper dermis and superficial lymphatics. That's the important part because that's how you'll differentiate with this. Usually from S. pyogenes presents with well-defined raised demarcation between infected and normal skin. Cellulitis is acute, painful, spreading infection of deeper dermis and subcutaneous tissues, usually from S. pyogenes or S. aureus. Again, and this is deeper dermis and subcutaneous, whereas this was upper dermis and superficial lymphatics. Often starts with a break in skin from trauma and another infection. Okay. Yeah, right there. Okay, and if you have an abscess like this, also known as boil, it's due to S. aureus. Collection of pus from a walled-off infection within deeper layers of skin. Offending organism is almost always S. aureus. Okay, to get rid of it, you would have to stab it with a needle and make a pathway for the pus to come out within 1 to 2 days, because after third day it gets walled off by macrophages and starts eating it up, right? So until the neutrophilic phase, you can, you know, uh, squeeze it out basically, because once macrophages come in, it gets it creates a granuloma type thing, right? Necrotizing fasciitis. This is deeper tissue injury, usually from anaerobic bacteria or S. pyogenes. Pain may be out of proportion to exam findings. Results in crepitus from methane and carbon dioxide production, right? That's S. pyogenes. So flesh-eating bacteria causes bulla and skin necrosis. Violaceous color of bulla surrounding skin. If that surgical emergency. So normally when they give you a photo like this, they're trying to have you differentiate between S. pyogenes or Pseudomonas, right? Because Pseudomonas also has it's called something else. Yeah, so something like that, like that. Usually it's black, the one they show. But if they give you blue green, then it's pretty easy to figure out, right? Yeah, so it's gonna look black like that, and they're trying to see if you can figure out that this is Pseudomonas or this is this as pyogenes. Okay. And then you have the shock. Sorry. TSS. Okay, this is SSS. Okay. Staphylococcal scalded skin syndrome. It's exotoxin destroys keratinocyte attachment and stratum granulosum only. Right, that's the third layer. Versus toxic epidermal necrolysis, which destroys epidermal dermal junction. So stratum granulosum is SSS, three S's, so the third layer. Characterized by fever and generalized erythematous rash with sludging of the upper layer of the epidermis. So G, okay, that's what it is. That heals completely. There is a positive Nikolsky sign, right? Because this happens because of the upper layer healing completely while the layer on the bottom, you know, it doesn't attach to the top layer, so it destroys the dermal junction. Yeah, so that's why you get positive Nikolsky sign, right? Is a separation of epidermis upon manual stroking of skin, commonly seen in newborns and children, adults with renal insufficiency. We saw what Nikolsky sign is. We'll look at this. Or Nikolsky, I keep pronouncing it wrong. Okay, toxic shock syndrome, that's what it looks like. Okay. Commonly seen in newborns and children or adults with renal insufficiency. So just people with renal insufficiency, I guess. That covers everyone. Viral infections. Herpes virus infection, HSV1 and HSV2, or skin can occur anywhere from mucosal surfaces to normal skin. These include herpes labialis, herpes genitalis, and herpetic whitlow. This one you need to know because that's what they'll give you. So it's like that for herpes. Everything else is pretty, you can figure it out from that. But this one is specific to this as well. So, and that's the one they give you a photo of. This is the cowpox one, right? Molluscum contagiosum, umbilicated papules. We did this in micro, right? It's like that. It looks like a papule with like low depression or dent in the middle. So umbilicated papule. It's caused by pox virus. While frequently seen in children, it may be sexually transmitted in adults. It's usually seen in milkmaids or the people who get milk from cows, and they have blisters in their hands, and the blisters are these, uh, like in a question stem. Varicella zoster. It causes varicella, chickenpox, and zoster or shingles. Varicella presents with multiple crops of lesions in various stages, from vesicles to crusts. Zoster is reactivation of the virus in dermatomal distribution unless it is disseminated. So that's type 3, right? Herpes virus, chickenpox, and zoster. You have various stages of healing. That's the buzzword for that. Hairy leukoplakia. It's on the tongue right there. Irregular white painless plaque on lateral tongue that cannot be scraped off. Uh, Epstein-Barr virus mediated occurs in patients living with HIV. Uh, okay, it's Epstein-Barr virus mediated. This thing, that's important. If you see that, it's because of EPV. It occurs in patients living with HIV. It is, yeah. So if you see that this person is HIV positive, and organ transplant recipients because they are on immunosuppressors. Contrast with thrush, which is scrapable. So this one is non-scrapable, right? And leukoplakia, which is precancerous. Okay. So that was skin infection. Now fungal or cutaneous mycosis. Tinea or dermatophytes. Clinical name for dermatophytes are cutaneous fungal infection. Dermatophytes include microsporum, trichophyton, and epidermophyton. Branching septate have septate hyphae visible on KOH preparation with blue fungal stain. It's associated with pruritus. So that's what it looks like. That up. Don't need it. Okay, so we're there. Okay. It includes microsporidium, trichophyton, and epidermophyton. That's okay. They usually test you on these. So tinea capitis, it occurs on head, scalp, associated with lymphadenopathy, alopecia, and scaling. Right. So right there. Tinea corporis, it occurs on body, usually torso, characterized by enlarging erythematous scaly rings, ringworms with central clearing. So that can be acquired from contact with infected pets or farm animals. Then you have Tinea cruris. Occurs in inguinal area, jock itch. Often does not show the central clearing seen in Tinea corporis. Okay. And Tinea pedis. This is there are 3 varieties. Athlete foot. There's interdigital, most common, and that's usually the one that they will give you. It's the most common. You have mucin distribution. That's on the side of your foot, and then vesicular type as well. That's these. Right. And then you have Tinea oncium. It's onchiomycosis. It occurs on nails. Okay. Tinea or pityriasis vesicular. That's caused by Malassezia species. Pityrosporum species, a yeast-like fungus, not a dermatophyte, despite being called tinea. Okay, so that's important to know. It's not a dermatophyte. Degradation, this is how it happens. They degrade the lipids. It produces acid that inhibits tyrosinase, right? That's the one that makes melanin, involved in melanin synthesis, which leads to hypopigmentation, like that. Okay, hyperpigmentation and or pink patches can also occur due to inflammatory response. Less pruritic than dermatophytes. It can occur any time of the year, but more common in summer, hot, humid weather. You'll see spaghetti and meatball appearance on microscope. This is the buzzword as well. They might tell you that it has a spaghetti and meatball. That's tinea or pityriasis vesicolor. Appearance on microscope, right? So that's meatballs and these are spaghetti. Treatment is selenium sulfide, topical and or oral antifungal medications. Okay. You need to know these at least and this one. So on the head, body, and feet, and probably jockish too. Okay. Autoimmune blistering or skin disorders. So pemphigus vulgaris, the and bullous pemphigoid. So bullous is below, so hemi, and this one was because of desmosome, right? Pathophysiology potentially fatal, most commonly seen in older adults. It's type 2 hypersensitivity reaction, IgG antibodies against desmoglein 1 and or desmoglein 3. It's component of desmosomes, which connect keratinocyte in the striatum spinosum. Okay. Morphology, gross morphology is flaccid intraepidermal bulla, caused by acantholysis. Hold on, let's actually have a look at this before we go on. Okay, so that and that, okay. Okay, so it's component of desmosome which connects keratinocytes in the striatum spinosum. That's the fourth layer. Gross morphology. It's flaccid intraepidermal bulla caused by acantholysis, separation of keratinocytes, a row of tombstones on H&E stains. Oral mucosa is involved and Nichols-Key sign is positive. So this is the defining feature between these two, right? If it's Nichols-Key sign positive, it's because of this, and it's due to desmosome antibodies against desmosomes. Okay. Immunofluorescence reticular pattern. Reticular means net-like or mesh-like, a pattern around epidermal cells. So like that, net-like right there. Okay, bullous pemphigoid. This is less severe than pemphigus vulgaris. Okay, let's see what that looks like. Okay, it's a bulla. Less severe than pemphigus vulgaris. Most commonly seen in older adults, type 2 hypersensitive reaction. This is also IgG antibodies, but against hemidesmosomes. That's epidermal basement membrane. Antibodies are below the epidermis. Okay, and this one was in the fourth layer or striatum spinosum, right, which connects keratinocytes. This one connects the basement membrane and epidermal basement membrane, or it's there. Okay, C right here. That's what it looks like. Tense blisters. C. Okay. Containing eosinophils. Okay. And this one was something else. Okay, no. I'm thinking of the vasculitis ones. Lymphocytic infiltrate for Kaposi and this for neutrophil. Okay. Oral mucosa spared and Nichols-Key sign is negative. So here oral mucosa is spared, here your oral mucosa is involved. Immunofluorescence is linear pattern at epidermal dermal junctions, like that. So if you have epidermis right here and dermis here, disrupted desmosomes in Pemphigus vulgaris, right? And you have intact hemidesmosomes. Here you have disrupted hemidesmosomes but intact desmosomes in this. Cool. So if you have a photo and they ask you where it is, just look at the basement membrane. That's where the hemidesmosomes are, or anywhere else will be your desmosomes. Epidermal lysis bullosa simplex, autosomal dominant defect in keratin filament assembly. It leads to cytoskeleton disruption that leads to epithelial fragility. Presents early in life with friction-induced skin blistering that primarily affects palm and soles. It heals without scarring. Skin biopsy is going to show intraepidermal cleavage. This is not really asked, so I guess they added this because I don't remember this one from before. Yeah. So it might be asked now, so I guess let's do that again. Let's see if there's a photo for that. Okay. Okay. So it's autosomal dominant defect in the keratin filament assembly. So this causes cytoskeleton disruption, which leads to epithelial fragility. It presents early in life with friction-induced skin blistering that primarily affects the palms and soles. Heals without scarring, and skin biopsy will show intraepidermal cleavage. Okay, other blistering skin disorders are dermatitis herpetiformis. That's from celiac disease, right? We read about it there. Okay, so that's what it's gonna show and looks like. Okay, there. It's pruritic papules, vesicles, and bullous, often found on elbows, knees, and buttocks. Deposits of IgA at tips of dermal papillae, right? Associated with celiac disease. Treatment is dapsone, gluten-free diet. Erythema multiforme, associated with infection. For example, Mycoplasma pneumoniae, that's the walking pneumonia one, and herpes simplex virus. Drugs, for example, sulfa drugs, beta-lactam, and phenytoin. It presents with multiple types of lesions, macules, papules, vesicles. Target lesions looks like target with multiple ring and dusky centers, showing epithelial disruption. So like that. Okay. Steven-Johnson syndrome. This is characterized by fever, bulla formation, and necrosis. This is the worst one out of these. Necrosis of skin at dermal epidermal junction. You have positive Nikolsky sign. High mortality rate. Typically, mucous membranes are involved. C and D. So these two. See how there's redness here and there's a little bit of skin over there. There's like buildup over there, discharge, I guess, and it's on top of this now. But I guess they're showing you the redness over here. Okay. Okay. Targetoid skin lesions may appear, as seen in erythema multiforme, usually associated with adverse drug reaction. Okay. Toxic epidermal necrolysis, that's TEN, okay, ENF. So it can lead to that. So I'll look at a few photos of that. Okay. Uh, fine. So 10 is more severe form of SGS, involving more than 30% of body surface area. 10 to 30% involvement denotes SGS TEN, toxic epidermal necrolysis. Okay. Lower extremity ulcers. These are venous ulcer, arterial ulcer, and neuropathic ulcers. Okay, so for venous ulcer, etiology is chronic venous insufficiency, most common ulcer type. Location is at gator area, that's ankle to mid calf. Okay, typically over malleoli. Appearance is irregular border, shallow, and exudative. Pain is mild to moderate. Associated signs are telangiectasia, varicose veins, edema, stasis, dermatitis, erythematous, eczematous patches. Arterial ulcers. Um, these are peripheral artery disease, for example, atherosclerotic stenosis. Location is distal toes, anterior shin, and pressure points. Appearance is symmetric with well-defined punched out appearance. Okay, like that. Pain is severe and it's associated with signs of arterial insufficiency, including cold, pale, atrophic skin with hair loss and nail dystrophy. Absent pulses over here. Okay. And then, so for arterial ulcer, that's how you know from venous ulcer. Okay, so these signs, and most importantly, they have absent pulses. Okay, neuropathic ulcer, it's peripheral neuropathy. This is diabetic foot. Bony prominence, that's where it happens, like metatarsal heads or heels. Appearance is hyperkeratotic edge with undermined borders. Pain is absent, and associated signs are claw toes or charcoid joints and absent reflexes. Okay. Miscellaneous skin disorders. Acanthosis nigricans, epidermal hyperplasia causes symmetric hyperpigmented thickening of skin, especially in axilla and or neck. So this is the one that's associated with diabetes, right? It's associated with insulin resistance, for example, diabetes, obesity, Cushing syndrome, and PCOS. Uh, Visceral malignancy, for example, gastric adenocarcinoma. So it's the darkening of the skin. Okay, it could be anywhere, not just underarms, back of the neck, on the face. Right? So back of neck. This. By the way, this formation of skin like this, it's due to what? There's a question like that they ask. Uh, right. So that it's because of increased amount of free fatty acid in your body that causes that. Okay. Visceral malignancy, for example, gastric adenocarcinoma. Actinic keratosis, this is important. And don't confuse it with seborrheic keratitis. Right? Where'd it go? Seborrheic keratosis. It's different than that. So this one was with like that, right? Like a mole. Okay. But the name sounds similar, but it's not. Okay. So this happens there. locations are here: head, trunk, and extremities, whereas that one only happens on the head. Okay, so it's pre-malignant lesion caused by sun exposure. So it's gonna be someone who works out in the sun like a farmer, uh, in the question stem, and then they'll tell you that he didn't use a hat that day, or he doesn't use a hat or sunscreen or something like that. Small rough erythematous or brownish papule or plaque, so B and C. Okay, so like that or like that. So it's on the head, right? Uh, Premalignant lesion caused by sun exposure. So we'll look at a few more. Actually, okay, it looks more like these, but on the forehead. So over there or like that they show. Okay, let's look like that. Not that. Like that. Okay, I think we got it. Small rough erythematous or brownish papules on plaques. Risk of squamous cell carcinoma is proportional to the degree of epithelial dysplasia. Okay. Erythema nodosum. So that would be the grade, right? What grade is it? And stages of how far deep is it, right? Erythema nodosum. It's painful, raised inflammatory lesions of subcutaneous fat, paniculitis, usually on anterior shins, often idiopathic but can be associated with sarcoidosis, coccidiomycosis, and histoplasmosis, TB, or streptococcal infection, leprosy, and inflammatory bowel disease. Okay, so like that and that for leprosy. Erythema nodosum, different than erythema marginatum, right? Or multiform as well. Acanthosis vulgaris, ichthyosis vulgaris. Okay, disorder of keratinization and resulting in diffuse scaling of the skin. Okay, so scaling of the skin. It's most commonly on the extensor side of extremities and the trunk. It manifests in infancy and early childhood. Lichen planus is all the P's. This is an important one and easy one to figure out because they'll tell you that it's pruritic, it's purple in color, and it's plaques. They usually give you those three. Polygonal planar papules as well. Okay. G and H. So sorry. These two. Mucosal involvement manifests as Wickenham stria or reticular white lines and hypergranulosis. Sawtooth infiltrate of lymphocyte at dermal epidermal junction. It's associated with hepatitis C. Okay, so 6 P's for lichen planus. Then you have Theriasis rosa or rosae. It's herald patch. Okay. Followed days later by other scaly erythematous plaques, often in a Christmas tree distribution on the trunk, and that's usually the buzzword that they use for this. Multiple pink plaques with colorate scale, self-resolving in 6 to 8 weeks. Let's look at more photos of that. Okay, so like that. They won't give you a photo, they'll just say it's a Christmas tree distribution on trunk. Okay, and herald patch, maybe. So that's I like that. Okay. Sunburn, it's acute cutaneous inflammatory reaction due to excess UV irradiation. Causes DNA mutation inducing apoptosis of keratinocytes. UVB is dominant in sunburn, UVA in tanning, and photoaging. Exposure to UVA and UVB will increase risk of skin cancer. Okay. Body surface area approximated by the rules of nines. The extent of a burn injury can be estimated by as a percentage of the body surface area. Uh, I don't think you have to memorize this because they don't test you on it. What they'll test you on is this stuff, but uh, we'll do it anyways. So 4.5, 4.5, 4.5, that adds up to 9. That makes a one leg, which is also 9. So the legs are 9, and abdo is 9 as well, torso is 9 as well. As the hands and the heads are 4.5, and that leaves the groin for 1%. Okay. So if they tell you, in case they ask, that left hand was involved and the torso and the head in burn, or then you just add those up. One hand, so that's 4.5. If it was both, then you would use 9, right? And then 9 for torso and 4.5 for that, so 18. Okay. uh Burn classification: depth, involvement, appearance, and sensation. I have note on this. Let me just open it up. I'm not sure if it's good or not. We'll read it. Let's just read it right now. So deep partial thickness burn. This will cause blister is formed from a collection of serous fluid between the dermis and epidermis. Due to damaged venules, it results in fluid extravasation through gaps between injured venules endothelial cells. Okay. Blanching it occurs due to release of histamine and other preformed vasoactive mediators from mast cells in minutes following a burn, leads to dilation of superficial skin and capillaries. So you need to know why blanching occurs. It's because of histamines and other preformed vasoactive mediators from mast cells in minutes following a burn, leads to dilation of superficial skin capillaries. And in deep partial thickness, the blisters, they are a form of collection of serous fluids between the dermis and epidermis. Okay, it's because of damaged venules. It results in fluid extravasation through gaps between injured venules endothelial cells. And cool. So superficial burn, it only involves the epidermis, and it looks like a sunburn. Localized, dry, blanching redness with no blisters. It is, however, painful. Okay. Superficial partial thickness burn. This is epidermis and papillary dermis. Okay, so appearance is blisters, blanches with pressure, and swollen and warm. So painful to temperature and air. Okay. And then you have deep partial thickness burn. This is epidermis and reticular dermis as well. Uh, Blisters easily unroofed due to sorry blisters easily unroofed, does not blanch with pressure. Okay, so this one doesn't blanch, this one does. For this, I think we should look at skin. So epidermis. Okay, there you go. So you have striatum corneum and epidermis right there. Then you have papillary dermis, then the reticular dermis. These are the ones with the venules, right? Papillary one doesn't have it. And hypodermis, you have the venules there as well. Larger arteries and veins. Okay. So papillary dermis, blister blanches with pressure and swollen and warm, painful to temperature and air. In deep partial thickness burn, so like halfway over here, you have blisters, easily unroofed, does not blanch with pressure. It's painless, perception of pressure only. So you can still understand pressure when you apply pressure to it, but it's not painful. And if it's full thickness burn, it's epidermis and full thickness of the dermis, right? Uh, it's gonna be white, waxy, dry, inelastic, leathery, and does not blanch with pressure. Okay, so all of these will branch with pressure. All these three. It stops blanching after this. Why? Because there's no more blood, anyways, right? And blanching occurs due to histamine and mast cells. You won't have mast cells if you don't have bloods coming there, right? Um, Blood vessels coming there. Okay, white, waxy, dry, inelastic, leathery, does not blanch with pressure. Sensation is painless, perception of deep pressure only. Deeper injury burn, that's epidermis, dermis, and involvement of underlying tissue, for example, fascia and muscles. White, dry, inelastic, does not blanch with pressure as well. It's painless, some perception of deep pressure though. Here you only had perception of pressure, right? Here you have pain and temperature and painful to temperature and air. Here it's painful. Here it's painless. Instead of perception, you only have some amount of it. Okay, cool. Next. Skin cancer. Basal cell carcinoma, more common above upper lip, and squamous cell carcinoma, more common below or lower lip. Sun exposure strongly predisposes to skin cancer. So S for lower lip and B for upper lip. Basal cell carcinoma, it's most common skin cancer found in sun exposed area of body, for example face. Locally invasive but rarely metastasizes, waxy pink pearly nodules, commonly with telangiectasia, rolled borders, right? Like that. Okay. Basically, this is what they'll give you in a description, that it's waxy pink and pearly nodule. Commonly with telangiectasia and rolled borders, central crusting or ulceration. Basal cell carcinoma also appears as non-healing ulcer with infiltrating growth, like that, or as a scaling plaque, superficial basal cell carcinoma. Okay, basal cell tumors have palisading aligned nuclei. Okay, like that. It's palisading aligned nuclei. Let's look at a few more of these. Okay, anywhere above the lips, I guess. Uh, in the sun exposed area. And then you have keratoacanthoma. It's seen in middle-aged and older adults. Rapidly growing, resembles squamous cell carcinoma, presents with dome-shaped nodule with keratin-filled center. It grows rapidly, 4 to 6 weeks, and may spontaneously regress. Okay, like that. It has keratin in it, and it's dome shaped. Okay. Melanoma, they will give you a marker for this. It's S100. Okay. Common tumor with a significant risk of metastasis. S100 tumor marker. Associated with dysplastic nevi. Right, so you had the mole or nevis or whatever. What was it called? This thing, melanocytic nevis, and then it becomes malignant. Right. Where'd it go? So, and infiltrating core has that, and basal cell tumors are present did that. Keratin right here. Okay, gross and spontaneous and melanoma. Associated with dysplastic nevi, right? People with lighter skin tones are at increased risk. Depth of tumor, bristle thickness correlates with risk of metastasis. Look for the A, B, C, D, E's. You look for the asymmetric, uh, border irregularity and color variation and diameter, more than 6 mm and evolution over time. Okay. So let's look at this as well. So that's a melanoma. They're different colors and they're not symmetrical, right? The borders are irregular as well, and usually that's what it will look like. If they give you a photo for it, it's very easy to figure it out. It's not going to be anything else. So something like that, not that, not that. This, they do give you that, and then they'll ask you why is there a lighter color compared to the dark one. It's because it's or like something like that. So they'll ask you about that, and it's because of healing. It's healed over there. Okay. 10 minutes. Okay. Uh. Okay. Done that and that. At least 4 different types of melanoma, including superficial spreading, F, nodular, so like that. They don't ask you about that, and lenticular maligna, or H, that they could ask you, and acrolentigenous, or highest prevalence in people with darker skin tone. They ask you about that, and this is the location that they ask you of as well. Okay. Highest prevalence in people with darker skin tone, often driven by activating mutation in BRAF kinase. Primary, remember, bruh, what the fuck? Primary treatment is excision with appropriately wide margins. Advanced melanoma are also treated with immunotherapy, for example, ipilimumab and or BRAF inhibitors, for example, vemurafenib. They don't ask you about this, so it's okay if you don't remember it. Just remember how to identify melanoma. And they'll give you this, and then they'll ask you what is it. It's a melanoma. It's that simple. Okay. So we read about where'd it go? Actinic keratosis and its risk of squamous cell carcinoma. So that's what we are going to read about. Squamous cell carcinoma, second most common skin cancer associated with immunosuppression, chronic non-healing wounds, and occasionally arsenic exposure. So marginal ulcer, that's squamous cell carcinoma arising in chronic wounds and wounds or scars. Usually develops more than 20 years after insult. Okay. Commonly appears on face or lower lip. Okay, that's face, lower lip. Ears and hands. Locally invasive, may spread to lymph nodes and will rarely metastasize. Ulcerative red lesions, histopathology is keratin pearls. Okay, you'll see keratin pearl, it's squamous cell carcinoma. Actinic keratosis, a scaly plaque, is a precursor to squamous cell carcinoma. Okay. On to pharmacology. Arachidonic acid pathways. So you have membrane phospholipids. With the help of phospholipase A2, it makes arachidonic acid, and the arachidonic acid then becomes either 5-HPETE, which makes leukotrienes, or cyclic endoperoxidase, which makes prostacyclin, prostaglandins, or thromboxane. Okay, so what are leukotrienes for? You have LTC4, LTD4, and LTE4. No, that's not the data one. Uh, they all increase bronchial tone. You have LTB4 that increases neutrophil chemotaxis. That's important. Okay, so you have leukotriene synthesis, 5-lipooxygenase, zilioton, which reduces or inhibits this, right? 5-lipooxygenase. We saw that in RESPI and the drugs for that. Leukotriene receptor antagonists, montelukast and zafirlukast, saw those there as well. They inhibit the LTC and LTD and LTE as well. Uh, so they don't let it increase bronchial tone or cause bronchoconstriction. To reduce this or these, you can just use this and that will do that. Or you can give them corticosteroids and that will still inhibit this, right? So if you give glucocorticoids, it will inhibit this. However, it will increase this, uh, the factor that causes differentiation, right? It inhibits that NFKB, and what that usually does is it stimulates COX-2. Okay, uh, COX-2 and COX-1 makes cyclic peroxides. Okay, uh, you have endoperoxide synthesis or cyclooxygenase, right? So COX-2 only. So this one blocks only this, and this one's non-selective, right? So this one's selective for COX-2. That's celecoxib. Okay, easy to remember. And for COX-1 and 2, you have aspirin, irreversible, other NSAIDs, reversible. Diclofenac, ibuprofen, indomethacin, ketorolac, and naproxen. Right. Okay. You have prostacyclin, so that's PGI2, right? I for inhibition, so it inhibits platelet aggregation. It inhibits the vascular tone. Uh, the drug is called epoprostenol. These are agonists, I believe, or like analogs of PGI2. So epoprostenol, we'll read about them. You have PGE 1, 2, and 2. Sorry, that's F2A. Okay, so PGE 1 and 2. 1 decreases vascular tone. So that's alprostadil, the analog for that, and the analog for this is dinoprostone. It increases uterine tone. Okay. Am I reading those right? Okay, back to this. Sorry. PGF2A alpha. It increases uterine tone. F. Okay. So these both, the ones that has 2 in it, for E and F, they increase uterine tone. Carboprost and dinoprostone. And then you have this for that. Okay. Thromboxane, that's TXA2. It increases platelet aggregation and increase in vascular tone. Okay. So thromboxane, we read that, right? Increase in platelet aggregation, increase in vascular tone. Okay. So LTB4, the neutrophil chemotaxis, is a neutrophil chemotactic agent. PGI2, it inhibits platelet aggregation and promotes vasodilation. Neutrophils arrive before others. Okay. And platelet gathering inhibitor. Acetaminophen, it reversibly inhibits cyclooxygenase, mostly in CNS. Inactivated peripherally. Clinical use is antipyretic, analgesic, but not anti-inflammatory. Used instead of aspirin to avoid Ray's disease, right? However, you give this in what? Kawasaki, right? Syndrome in children with viral infection. Adverse effect is overdose, produces hepatic necrosis, acetaminophen metabolites that is NAPQI. It depletes glutathione and forms toxic tissue byproducts in the liver. So you give N-acetylcysteine, which is an antidote to generate glutathione. Okay, this is important. You have to remember that. Aspirin. Also, there's I think a question about a person who took multiple pills of acetaminophen and also alcohol at the same time, and normally individually it would hurt him, but since it was together it didn't hurt him as much because both of them competitively inhibit, or not inhibit, but they competitively go for the same receptor on the mitochondria, so cytochrome P450 or whatever. And yeah, so that's why it was okay, and not dead. Someone who committed suicide or tried committing suicide. Okay. Aspirin, uh, mechanism is NSAIDs that irreversibly inhibits cyclooxygenase, both COX-1 and COX-2 by covalent acetylation, leads to decrease in synthesis of thromboxane 2 and prostaglandins, increase in bleeding time. Okay, that's what it does. No effect on PT and PTT; those are coagulation factor, right? Uh, Effect lasts until new platelets are produced, so that's why it's considered irreversible. Okay, clinical use is low dose, less than 300 milligram per deciliter, decrease in platelet aggregation. Intermediate dose, that's 300 to 200, 2400 milligram per day, antipyretic and analgesic. That's uh, that's the use for it. High dose is 2400 to 4000 milligram per day, to use as an anti-inflammatory. Okay, so 300 to 2400 is antipyretic and analgesic. High dose is for anti-inflammatory, and less than 300 to decrease platelet aggregation. Adverse effects is gastric ulceration, tinnitus. That's an important one. Allergic reactions. Oh yeah, this is important too. Peptic ulcers. Allergic reactions, especially in patients with asthma or nasal polyps. Chronic use can lead to acute kidney injury, interstitial nephritis, GI bleeding, risk of Ray's disease syndrome, and children treated with aspirin for viral infection. Toxic doses causes respiratory alkalosis early, but transitions to mixed metabolic acidosis, respiratory alkalosis. Treatment of overdose is sodium bicarbonate. Okay, then you have celecoxib, COX-2. So it reversibly and selectively inhibits the cyclooxygenase isoform 2, celecoxib. Okay, because it's selective for that. Which is found in inflammatory cells and vascular endothelium and mediates inflammation and pain. It spares COX-1, which helps maintain gastric mucosa. thus does not have the corrosive effect of other NSAIDs on the GI lining, spares platelet function as thromboxane 2 production is dependent on COX-1. Okay, cool. Clinical use is rheumatoid arthritis, osteoarthritis. Okay, adverse effects are increased risk of thrombosis and sulfa allergy. Okay, NSAIDs, ibuprofen, naproxen, indomethacin, ketorolac, diclofenac, meloxicam, and piroxicam. Mechanism is reversibly inhibit cyclooxygenase, both COX-1 and COX-2, block prostaglandin synthesis. Clinical use is antipyretic, analgesic, anti-inflammatory. Indomethacin is used to close a PDA. We learned about that. Indomethacin ends PDA, right? Adverse effects are interstitial nephritis, gastric ulcer, prostaglandin protect gastric mucosa, renal ischemia, prostaglandins vasodilate afferent arteriole, and aplastic anemia. Leflunomide mechanism is reversibly inhibits dihydroorotate dehydrogenase, preventing pyrimidine synthesis, suppresses T cell proliferation. Okay. Right. We saw that in this right there. Right. Okay. So mechanism reversibly inhibits dihydroorotate dehydrogenase. Okay. Preventing pyrimidine synthesis, suppresses T cell proliferation. Clinical use is rheumatoid arthritis and psoriatic arthritis. Adverse effects are diarrhea, hypertension, hepatotoxicity, and teratogenicity. Okay, bisphosphates, these are your dronates. Okay, so aldronate, ibandronate, resindronate, and zoledronate. Mechanism is pyrophosphate analogs bind hydroxyapatite in bone, inhibiting osteoclast activity. That's the important mechanism of it. It inhibits osteoclastic activity, right? How it binds to both of these things. This thing, and it's a pyrophosphate analog. Clinical use is osteoporosis, hypercalcemia, Paget disease of bone, metastatic bone disease, osteogenesis imperfecta. Okay, that's the collagen, uh, blue sclera blue sclera one with collagen defect. Adverse effects are esophagitis if taken orally. Patients are advised to take with water and remain upright for at least 30 minutes. Osteonecrosis of jaw happens. That's an important one. You have to remember that one for dronates. And atypical femoral stress fracture. Then teriparatide. That's mechanism is recombinant PTH analog. That's where we heard that one. It increases osteoblastic activity when administered in pulsatile fashion. Okay, because if it's in a steady state fashion, then it's gonna do osteoclastic activity. So clinical uses for osteoporosis causes increase in bone growth compared to anti-resorptive therapies like bisphosphonates, okay, or dronates. Uh, Adverse effects. Okay, right. It increases osteosarcoma. Avoid use in patients with Paget's disease of the bone or unexplained elevation of alkaline phosphatase. That's important. Avoid in patients who have had prior cancers or radiation therapy. transient hypercalcemia. Okay. uh, Gout drugs. So chronic gout drugs, and then you have acute ones. We read about them. So uh, before that, let's look at this. You have purines, hypoxanthine, xanthine, and plasma uric acid going into the um, tubules, renal tubules, or right. You have xanthine oxidase over here getting inhibited by allopurinol fiboxazide. So to inhibit the tubular secretion, you have diuretics, and to inhibit the reabsorption, you have probencenide. Okay. Allopurinol, competitive inhibitor of xanthine oxidase, decrease conversion of hypoxanthine and xanthine to urate. Also used in lymphoma and leukemia to prevent tumor lysis associated urate nephropathy. Increase in concentration of xanthine oxidase active metabolites as a thioprine, as a thioprin and 6-mercaptopurin. Okay, yeah, so it inhibits xanthine oxidase and it's used for chronic gout. Pegloticase is recombinant uricase catalyzing uric acid to allantoin, a more water soluble product. Okay, that's what that is good for. Fiboxystat it inhibits xanthine oxidase. Think febuxostat makes xanthine oxidase static. Okay. Uh, Probenecid is it inhibits reabsorption of uric acid in proximal convoluted tubule. Also inhibits secretion of penicillin. It can precipitate uric acid calculi or lead to sulfa allergy. Acute gout drugs, NSAIDs, any NSAID. Use salicylates with caution, may decrease uric acid excretion, particularly at low dose. Right, so we know acute gout in acute gout you give NSAIDs, glucocorticoids, and colchicine, right? And that's same for pseudo gout. We use these, but in prophylaxis you give colchicine for pseudo gout though, right? In glucocorticoids, it's oral, intra-articular, or parenteral, and colchicine is it binds and stabilizes. Hold on, I'll share it with you. All right. So colchicine it binds and stabilizes tubulin to inhibit microtubule polymerization, impairing neutrophil chemotaxis and degranulation. Acute and prophylactic value, GI neuromyopathic adverse effects can also cause myelosuppression and nephrotoxicity. Okay, and last bit. Tumor necrosis factor alpha inhibitor. So this is a inflammatory cytokine, right? Interleukin 1, 6, and TNF alpha. They recruit interleukin 8 and 12, and anti-inflammatory are uh, interleukin 10 and TGF beta. Okay, intercept, that's the one that's decoy. Okay, so fusion protein, it's a decoy receptor for TNF alpha and IgG for the FC. It produced by recombinant DNA. So intercept intercepts TNF. It's used for rheumatoid arthritis, psoriasis, and ankylosing spondylitis. Infliximab, adalimumab, certolizumab, and golimumab. So these are anti-TNF alpha monoclonal antibodies as well. However, it's this one was decoyed. This one actually does an action on it. Inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and psoriasis. So adverse effects for them are the same. It predisposes to infection, including reactivation of latent TB, right? Because if you do this, that means what uh, It's not going to recruit any macrophages to that, and new macrophages are not going to attempt to wall off the TB. So before you give this, you have to do a PPD test to make sure there is no tuberculosis infection prior to this. Predisposition to infection, including reactivation of latent TB, since TNF is important in granuloma formation and stabilization. So remember that, that's important. It can also lead to drug-induced lupus. Okay, not that important. Imiquimod mechanism, that's a new drug. It binds toll-like receptor 7, TLR7, or of macrophages, monocytes, and dendritic cells to activate them. It leads to topical anti-tumor immune response modifier. Clinical use is anogenital warts and actinic keratosis. Remember, this is the one that goes on to becoming squamous cell carcinoma. Okay, and adverse effect is itching, burning pain at site of application, and rashes. And that's it.